Dr. Bhaskar Nandi and Dr. Prasenjit Das to please be also on the stage. Thank you. The first session is on clinical pathological conference. Thank you.
Good morning, everyone. I think it's time for us to start with our CPC. This is a very interesting case of 40-year-old male who has been having recurrent vomiting, abdominal distension for the last several years. Dr. Bhaskar Nandi will be the clinical discussant. Dr. Nandi is Chief of Gastroenterology and Hepatology at Amrita Hospital, Faridabad. I think what we'll do, we'll have about 20 minutes for the clinical discussion, followed by 10 minutes for comments from the audience, and then 20 minutes for the pathology, and last 10 minutes we'll keep for the clinical pathological correlation. May I request Dr. Nandi to start with the clinical discussion, please.
Thank you, Chairperson, sir. Good morning to all of you. Just before I entered the hall, Professor Naresh Bhatt remarked that I have done CPCs too many. So my answer to him was that maybe till I get it right at least once, I'll keep getting it. Thank Dr. Govind Makharia, Dr. Sandeep Nijavan and the organizing team for giving this opportunity to reappear again. You'll all agree with me that this is the pathologist's game and everybody knows who controls it. So with this disclaimer, I'll start with my presentation. What I'll do is in the first couple of slides, I'll just go through the salient features in the clinical presentation and then maybe go on to analysis on my differential diagnosis. My patient is a 40-year-old male. It's a long history which dates back about 8 years, started in 2013 when he had come with recurrent vomiting, early satiety, bloating post meals. It was insidious in onset, progressive. The vomiting, it is written as non-bilious and non-projectile. And there was no history of obstipation, no diarrhea, no dysphagia, no systemic features. And gradually he started losing weight because of the vomiting. He had reduced his eating, so there was progressive features suggestive of emaciation. This continued for about 3-4 years before he first consulted in 2016 when he was evaluated at a center. Endoscopy had revealed dilated stomach and duodenum with stale and residual food. Even the duodenum D1, D2 was grossly distended, and there was a cutoff for a collapsed D3. The aortomesentery angle was less than 40 degrees, distance was 9 mm, and the treating unit's initial diagnosis was the SMA syndrome, and he was taken up for gastrojejunostomy with a part of duodenal resection. That's what is written in the protocol. I'm not very clear whether this part of duodenum means actually that portion of duodenum was resected and end-to-end, or it was a full thickness biopsy which was taken. Both of them could have been possible. But what happened to the natural course is in the next 3 months, in the 4 months till January 2017, this patient has undergone 3 surgeries to correct his symptoms. After the first surgery, there was recurrence of symptoms. In fact, there was no change. So a duodenojejunostomy was done in November 2016. And finally in 17, when the clinical presentation was similar, the findings of a distended stomach, duodenum till D2 was similar, and there was dilatation of jejunum and ileum also at this part. And there was some ascites, I think it could be nutritional. So he underwent a jejunostomy with a feeding jejunostomy. So basically a long presentation of 4 years with early satiety, bloating, and post meals, vomiting, recurrent vomiting, 3 surgeries to correct this issue, but patient still remained asymptomatic, and the initial diagnosis given was SMA syndrome. After the 3 surgeries, there was some partial relief in the sense he did a lot of lifestyle changes. He took low fiber, small, frequent meals, took all those precautions, and took nutritional supplements like iron and vitamins. In 2019, an endoscopy report is there which just shows esophagus full of food, and the procedure was discontinued. He continued to have symptoms, and in March 2020, that is about 7 years after the onset of symptoms, there was a slight addition to his symptomatology. This time he also had constipation, fullness, and post-meals regurgitation. CT continued to show a dilated stomach, duodenum with a doubt of distal obstruction, and stomach was full of residual food. So even after 3 surgeries, the symptomatology, the clinical findings have more or less been similar in this particular patient. The point to highlight was throughout he had no prior medical illness, no comorbidity. There was no mention about any family history of such similar or any GI related illness. There were no other systemic features or extra intestinal features which have been written in the protocol. January 21, he had come to All India Institute, and this is where the further management evaluation of the patient had taken place. Patient at that time had persistent symptoms. In between, he had a DVT, which was treated for about 6 months. No further details are there. He was malnourished, and clinically, there was nothing positive to report except for his low BMI. Endoscopy, distended stomach and duodenum with residual food. Colonoscopy was normal. CT showed a dilated stomach, duodenum with possibly an obstruction at D3. This time an esophageal manometry was done, which had shown absent esophageal contractions. The integrated relaxant pressure was 2.7, ruling out all achalasia. The distal contractile integer was 0, showing about 100% failure in esophageal contractions. There was a normal LES, and anorectal manometry, though had shown a pelvic floor weakness and decreased in the sphincters, internal and external sphincteric functions, the retroanal inhibitory reflex was normal, ruling out any Hirschsprungs in adults. So these were the images which have been provided to me. Basically, it shows a grossly distended stomach. This is the duodenum, and here we go. This is, I think, is the D3 part. There is a possibility that there is a GJ over here. Yes, that's what we are seeing. This is the coronal section. There is a nasogastric tube over here. This is the stomach, which is totally distended, grossly distended. Follow it up to the duodenum, D1, D2, and then we'll be coming to D3 over here. This is the portion which is narrowed. So the point to highlight is, though we have this finding over here, but then there is no intraluminal obstruction. It doesn't seem as if there is anything extrinsic compression also taking place in the films that I could review. The jejunum, ileum are also dilated. These were the investigations. Hemoglobin was low, calcium was low. If we correct for albumin, it comes to around 8. Albumin was 2.9. He had a lot of nutritional issues. The LFT was normal. Unconjugated hyperbilirubinemia. Viral markers negative. No diabetes. Euthyroid. B12 levels were normal. Vitamin D levels and iron levels were normal in this particular patient. As far as the surgical concerned, surgeries done concerned, it has remained a puzzle to me. I tried to reconstruct it with a line diagram. Now, the first one, when the SMA syndrome was diagnosed, I think GJ was done, gastrojejunostomy over here, and there was some part resection or full thickness biopsy from this side. Since this was not a rule loop, maybe what was happening is it was forming a sort of a vicious cycle over here, and the patient didn't get any relief. So thinking of this, the next surgery was done was a duodenojejunostomy. They tried to open up from here. This also didn't work, and the final surgery was they did a jejunostomy, jejunojejunostomy over here. So I think pathology or the treating unit will give us further details on the surgery, but I feel these were the 3 surgeries which were done and why they were done. So now if we come to the analysis, we have a 40-year-old long history, recurrent vomiting, non-bilious, early satiety. And the main features to remember is despite the dilatation of the stomach, duodenum, and even the esophagus at certain times, and sort of a cutoff level at D3, a diagnosis of SMA syndrome was made. If we go into clinical diagnosis first, I think this is a case of high gut obstruction, and we basically have to look into what could have caused a high gut obstruction in this particular patient. Now, this is a study from BHU Varanasi, which they have labeled it as a surgical enigma. There were many causes. If we go through the causes in this table, which is quite exhaustive, I think most of the causes could be ruled out in a cross-sectional imaging, endoscopy, and three surgeries which have been done. Now, if we look at intraluminal causes, we look at the luminal causes, except for maybe SMA syndrome, that was the initial diagnosis, and pancreatic lesions were not there, hepatobiliary lesions were not there, retroperitoneal lesions would have been picked up in a cross-sectional imaging, and lymphoma, few nodes here and there, but definitely there was no widespread lymphadenopathy. So more or less, I think if we rule out most of the mechanical causes of high gut obstruction, talking of SMA syndrome, is it a reasonable diagnosis? I think yes, even my diagnosis initially when I just gone through the first presentation was SMA syndrome. But then we all realized that diagnosing SMA syndrome is something more than just measuring the angle and the distance, because first of all, we do not have the history of the patient's habitus before the onset of symptoms. Now, usually we expect it in a very thin individual, and then there is no history related to change in the symptoms with posture, whether it's in a prone position or the knees to the chest position. In SMA syndrome, these postures, they make a lot of difference. As far as limitations are concerned, I think the way to diagnose SMA syndrome will be in a dynamic study rather than a static cross-sectional imaging, because dynamic study in the fluoro, if you do, you can change the position of the patient, and actually proving the functional component of SMA is more important, because there is a lot of normal overlap between if we just measure the angle and the distance. And the surgery, as I said, maybe if a rule loop was not done, that could it have been an SMA syndrome, but the surgery was inadequate? These are difficult questions to answer. But what I gather from here is, if I rule out all the mechanical causes, which could be ruled out based on the table which I had shown about causes of high gut obstruction, then we come to a large group of conditions which are the functional causes for duodenal obstruction. It could be a chronic intestinal pseudo-obstruction, gastroparesis, a lot of connective tissue disorders. There are so many causes for SIPO. But then we generally see very few cases of this, especially of the idiopathic variety without any secondary cause. So if we concentrate on the functional aspects of this obstruction, SIPO definitely has in all series been mentioned as a close differential diagnosis of SMA syndrome. In fact, this study of 27 cases of SIPO has shown that the commonest misdiagnosis in SIPO was obstruction of the duodenum by the superior mesenteric artery. And of course, these were the other diagnoses. Manometry definitely helps in diagnosis of SIPO, but then we didn't do a small bowel manometry. What we have is a esophageal manometry, and that's also very interesting, because as you go through the manometry literature in SIPO, we expect the small bowel and maybe colonic involvement, but then as I'll come later, the esophageal involvement is also very common in SIPO if we do on a basis of manometry. In fact, about 2/3 of cases of small bowel SIPO also had esophageal involvement with changes in the esophageal muscles, in the smooth muscles, in the mesenteric plexus, in the neural plexuses over there. This is the way to differentiate whether it's a myogenic, neuropathic, and mechanical obstruction. At this point of time, I'm just concentrating on mechanical occlusion. A manometry in a mechanical occlusion would have shown such a picture with prolonged contractions, as it is said, giant contractions and clustered, which were actually not there in our patient. So can we safely assume that this is a duodenal, rather than a mechanical duodenal obstruction, are we dealing with a functional gut obstruction? And the manometry, the imaging, the endoscopy, they actually rule out a mechanical cause for this. If you look at SIPO, it's a neuromuscular disorder of the gut, and there are three varieties of it: visceral, myogenic, and those which are involving the interstitial cells of Cajal, mesenchyomyopathies. Over half of them are because of the secondary causes. Now, these are the cases which we usually see, which have an underlying secondary cause. And I don't think I've seen much of idiopathic variety of SIPO very frequently. Small bowel and colon are the commonest site of involvement. And in adults, the mean age of onset is around 17 years in the various series. The natural courses of exacerbations and remissions. Now, relentlessly, patients continue to have baseline symptoms, but they have acute episodes wherein the patient needs to get hospitalized, treated, again they go back home, but they never actually get well. In fact, this is the natural history of SIPO, which is there in the few small series of studies which are there on intestinal pseudo obstruction. Symptoms are similar to what our patient had: abdominal pain, distension, vomiting, constipation, and diarrhea. And esophageal involvement is common, as I was discussing, and it is also a prognostic marker. It is documented that if your esophageal manometry is abnormal in a case of SIPO, the prognosis is bad, and it is usually a severe disease and also indicates higher mortality. Prognostic yield of a esophageal manometry, I think this is what we were just discussing, that the motor disorder in SIPO is not restricted to small intestine. In majority of the cases, esophageal involvement in 73%, and of course, anorectal and gastric emptying are also abnormal, but they do not have a prognostication value as a esophageal involvement has. I think this is important for me to find out, do we have a secondary cause in this individual? If I am talking of a functional bowel obstruction in this particular patient, there are various diseases, autonomic and peripheral enteric nervous system diseases, immune-mediated, collagen, endocrine metabolic, and of course others. These are the common conditions which we look into. Now, if we closely look at this chart, even though there is nothing in the history, I think a paraneoplastic syndrome is something which always to be ruled out or to be kept in mind, because it is said that SIPO can predate a paraneoplastic syndrome actual tumor by a decade, 8 to 10 years. So that is very important, that the follow-up of the patient, though we have had it for about 8 years, but then search for the primary, I think that is one possibility. Systemic sclerosis, esophageal involvement, very common. And of course, metabolic conditions, most of them have been ruled out, except the calcium values were low. I don't know whether it has got anything to do with nutrition or the low albumin levels, or it's a case of primary hypoparathyroidism, because that is mentioned as one of the causes. And of course, iatrogenic diseases are not there. Chagas disease, sorry for the spelling mistake. It was interesting to note that there is one case of trypanosomiasis reported in Indian literature. It was from a village called Shivani, 140 kilometers from Nagpur, and it was because of Trypanosoma evansi. And this has been documented by a WHO lab, and in fact, when they did a serology in that particular village, they found a prevalence of 22% antibodies, serology for Trypanosoma evansi over there. And of course, nobody had any clinical manifestation except for this index patient. But otherwise, we take it as we do not get this parasitic disease in our country. So moving ahead, if we see two series of intestinal, remaining in the secondary causes, amyloidosis was one of the cause. It's a very uncommon presentation of systemic amyloidosis, but what's interesting was that whether you have got a myogenic SIPO or a neuropathic SIPO depends on which amyloid protein is being deposited. If you have the primary light chain amyloidosis, AL, or the hemodialysis associated, that is more of a myopathic disorder, whereas the neural involvement is with amyloid A deposition. So there is a difference in the presentation and the type of amyloidosis protein which is getting deposited. So amyloidosis by itself is a difficult diagnosis, especially in the absence of any renal involvement or any other clinical clue to that. Systemic sclerosis, connective tissue disease always remains a possibility when we are talking of a SIPO. Well, patient didn't have any of these signs, I think, and it's an adverse prognosis if SIPO is there in systemic sclerosis. But as I said, even in connective tissue disorders like paraneoplastic syndrome, SIPO can predate this for many, many years. You can get this. Natural history is what our patient had. Usually, full thickness biopsy gives a result to this. What's interesting is the mean interval diagnosis and onset of symptom is around 8 years in a idiopathic intestinal pseudo obstruction. Surgeries per patient is 2.9 mean. Our patient has had 3 surgeries and finally 1 more surgery. Manometry was abnormal in all, severe clinical scores, intestinal failure, poor outcome. Similar issues in the next series that we have of 20 patients. This was the diagnostic criteria. If it is a SIPO, patient had a symptoms more than 6 months. The presentation symptoms were as mentioned over here. We had a dilated GI tract and organic lesions blocking the GI tract. We did not observe in our cross-sectional imaging and endoscopy, and in fact operatively during a surgery. And if we do a normal HE staining of the full thickness biopsy, we may miss the findings. And of course, secondary conditions to be ruled out, like I was discussing, that table of secondary causes of SIPO will be very important. Is it possible for a clinician to differentiate between myogenic, myopathy, neuropathy, and in a case of SIPO? I think after going through the literature that it is best left to the pathologist, because there is so much of overlap, though there are. I think I've reached my final slide, with permission of the chair. What revision surgery could have done, it beats me. I have shown the first line diagram of the 3 surgeries. Maybe I was thinking that there were 2 possibilities. Either they constructed 2 Roux loops to prevent this dilatation and reflux which was going on. So maybe this is the one arm, the gastrojejunostomy was refashioned into a Roux loop. And of course, from the duodenojejunostomy was refashioned again into a Roux loop. Or they could have done, since the CT over here, the latest CT which was made available to me, also showed some pneumobilia. So could it be that hepaticojejunostomy was done and the GJ was refashioned? So that was also one possible revision surgery which could have been done to give symptomatic relief to this patient. So this is my final slide, that if I have to offer a differential diagnosis to this, what we were thinking of a mechanical obstruction, SMA syndrome, I think I'll keep it as functional gut obstruction in the form of chronic intestinal pseudo obstruction in this patient. And they can be sporadic, familial. I don't have any family history, so this could be sporadic. And there are a lot of genetic causes to it also, but then sporadic cases in adults are more common. And why I'm saying that this is a functional is because I could not pick up any mechanical obstruction in either clinical examination or on the study results that have been shown to me. The clinical history more or less is similar. It could be a myopathy, could be a neuropathy. I think the full thickness biopsy will give us a clue to that. Do I have a strong differential to this? I think the secondary causes will be my differential to this, that we do need to, I think, a PET CT for a paraneoplastic syndrome, and the endocrine and the metabolic causes, parathyroid, we could look into that, and maybe an observation and a follow-up, whether any secondary condition, any connective tissue disorder is coming up in this patient or not. This is the hospital where I work. Thank you for your patience here. Thank you.
Thank you very much, Dr. Nandi, for a nice discussion. I think we'd like to have diagnostic possibility for the audience now. 10 minutes by the audience. Dr. Sharma.
In this patient, if I analyze the history, beginning he had symptoms and findings of imaging upper gut obstruction. Later on, he developed lower bowel symptoms and imaging lower bowel ileal findings also. So it was a gradually progressive disorder, not which are upper GI first and then progress to lower GI. Ileal is involved. Maybe later on follow up large bowel colonic is also involved. That we will see. And this feature, to my mind, is seen in scleroderma. Scleroderma will be my diagnosis, and other peripheral features of scleroderma may not be there always, and it can involve intestinal nerve plexus, and that too is gradually progressive. So I go with diagnosis of pseudo obstruction but cause scleroderma.
So your point is well taken, and in fact, I did mention in my presentation that a strong differential will be the secondary causes of SIPO, of which the connective tissue disorders, a primary somewhere, and some of the metabolic endocrine causes we have to keep in mind. And as far as the predominance of the upper gut symptoms are there, even I think even in the initial photographs, in the first CT which they had shown, There was a dilatation of the jejunum, ileum. So there was involvement of the entire GIT, but our attention was drawn towards the gross dilatation of the upper GI. And once the patient had a gross dilatation, I think his intake was so poor. I think that also had a bearing that most of his clinical presentation was of upper GI rather than of the lower GI.
One thing is long history, paraneoplasty from my side is out, and secondly, upper gut features extending to then later involving lower GI. I think even idiopathic is also out.
Excellent case discussion, Dr. Nandi. Congratulations for that. I think straightforward pseudo obstruction. There's not much doubt about it. Regarding the etiology, have you looked at that thymus in your CT? Because thymus is known to be lasting for such a long period and produce paraneoplastic syndrome. Parathyroid we have already mentioned. Another thing is these syndromes of megaesophagus, megaduodenum, and megacystis, that means urinary bladder also
Yes.
tend to get distended. Did you that CT showed any distended urinary bladder?
Yes, sir.
Another thing is if it is a neuropathy, pupillary abnormalities and postural hypotension and those sort of symptoms also can occur. And myopathy usually don't have such problems.
Question one, if we look at the first CT,
There was nothing obvious
of
there.
course, thymus and all we couldn't see. But if we keep the common causes of paraneoplastic, like you mentioned, thymus is one, but small cell lung carcinoma is the commonest cause of SIPO, followed by bronchial carcinoid. And then, of course, the other features come in. I don't have the CT chests with me, but the abdomen, what I could gather is the kidneys and the ureters were normal. Because the condition that you're mentioning, sir, is mostly seen in the pediatric age group, where they come with dilated mega ureters and all that. So, but they were normal. I have a cut over here. I think for lack of space, I didn't put it, but it is there in that video of the CT that I have
So you
shown.
also think it's idiopathic chronic intestinal pseudo obstruction.
I have kept that as first, but second is that secondary
There has
causes,
to
like
be
I
some
said.
bias.
Because
Secondary
most of the cases that we see is usually secondary to a cause underlying, and as rightly pointed out, the cause may not be apparent even in the initial years. It can still come up later.
Thank you.
But to narrow down clinically any further, yes, like Dr. B.C. Sharma said that scleroderma, he will keep it as first. It's there.
I have a Dr. Nandi. One second. Can I? After.
Then SMA you stressed on and adenogenosity was, I mean, this is also done. Does SMA have non-bilious vomitives?
It should have been bilious.
Yeah. So why all surgery and your possibility is also there?
Excuse me, sir. In the biochemistry and
No, no,
calcium.
1 minute, sir. The SMA thing, I was trying to discuss what was the initial bedside diagnosis and what were the positives and the negatives in that. SMA is not my diagnosis.
Sir, calcium was low.
Yes, sir.
Focusing on parathyroid and related paraneoplastic is one of the possibilities.
Absolutely. I mentioned that parathyroid hormone primary hypoparathyroidism we need to look at, because even if we correct the calcium, it comes to 8. For an albumin of 2.9, roughly it comes to around 8. It's still low.
Dr. Nandi, what is the differential count? What is the differential count in this patient?
Differential count.
Yeah. It was not mentioned in the protocol.
You're talking of the complete blood count differential?
Yeah.
5,200 and 2 lakhs.
Differential count.
No, it's not
Eosinophil
mentioned.
count.
It is not there in the protocol.
It could be. It is a systemic thing, and there should be an infiltrative disease which you already considered. I want to know about the differential count in this patient.
I don't have it in this. Yes, eosinophilia. But ruling out eosinophilia is because of you are thinking of parasites, drugs, or a primary eosinophilic gut.
Normal stophils. Normal stophils.
Yeah. I had one thing. In the SIPO causes, the congenital variants of the neuropathies and myopathies, for a middle-aged man starting now, just 5 years, and would you expect thickening of segments of bowel in that, vis-a-vis some more of an infiltrative thing like amyloid you mentioned in the beginning?
I didn't get your question, Sandeep. You are talking of secondary causes of SIPO. No, you're talking of?
I'm talking about both the possibilities in SIBO when you have a pseudo obstruction, whether myenteric or a neuropathic cause. Onset somewhere in the middle age is one thing which is generally, unless you're talking about the secondary causes.
No, if you go through the literature, there are of course small series of 27 to 50 patients. There are about 3-4 of them, and I am talking of adult idiopathic SIPO. I have only
Absolutely.
included that.
Absolutely.
So there is a presentation of even idiopathic SIPO in adult agehood. Idiopathic I'm talking of.
Okay.
Presenting as in adults.
At many times they mention thickening of pylorus, thickening of duodenum segment, short segment thickenings. Thickenings wouldn't we expect more in localized infiltrative, come neurogenic disorders?
In the neuropathic variety of SIPO, fibrosis and thickening is well mentioned. That is one. And secondly, one more thing which we need to keep in mind is like if it's a hollow viscous and you've got a lot of obstructions below, sometimes the changes which come up in the upper GI are the sequelae, the effects, upstream effects rather than a primary disease in them. So when we interpret that where is a contraction, where is a narrowing, it may be an effect of the obstruction rather than a disease process sitting inside that. I hope I could explain myself.
Dr. Nandhi, do you think the diagnosis of superior mesenteric artery syndrome was justified in this patient? The angle was less than 40. Most recent studies have taken less than 25. And this is also 9 millimeter. In fact, most recent study taken this one less than 7 millimeter. So you think, was it in retrospect, this diagnosis was really justified?
So, like I mentioned that initially when I just started reading the protocol, the first thing which came to my mind was SMA syndrome at the bedside. Of course, that is before all the imaging and all we could see. So my clinical bedside diagnosis could have been an SMA syndrome or a mechanical obstruction when we couldn't find any. But the parameters that they've used for diagnosing SMA are actually quite different. In fact, it is much less like you said. In fact, the angle should be somewhere between 15 and 22. And 40 is too high for that. And the distance is, if you have it 8 mm or less, then it becomes. But again, I said in static images, these all may be overlapping.
And the biggest point against this is that we want dilatation of that distal small ball
Yes,
also,
so
although this is in hindsight.
once you do a manometry, the SMA thing has been ruled out at all.
Thank you very much. I think I'd like to put a stop here now for the clinical discussion. But before you request a pathologist, may I request Dr. Makharias to tell us what are the diagnosis of the treating unit? Diagnosis without the knowledge of the pathology.
I think nothing much to add what Dr. Nandhi said. Since this patient had a recurrent vomiting and 3 surgery done, and when he came, and the kind of imaging we saw, we had a similar diagnosis as Dr. Nandhi presented.
My own diagnosis is same as Dr. Nandhi has said. Personally, I think the cause of this chronic intestinal obstruction is visceral myopathy, and this is a typical story in these patients. They are treated repeatedly by conservative therapy, repeated surgery. The outcome with conservative therapy as well as surgery is most of the time not satisfactory. I think with this, we request our pathologist now to tell us what we saw on the surgical resected specimen, which might give us a diagnosis.
Before we go ahead, can we have a very short comment from the surgeon? Is that possible? Or
Do we have a surgeon here? Yes.
Good morning, everyone. I'll just be sharing the details of the surgical procedure that the patient underwent. So when the patient was taken up for the procedure, we found that his duodenum was dilated from D1 to D3, and it was quite large. It was 16 centimeters in diameter. And the bowel beyond the DJ flexure, however, appeared to be normal. The affected segment, the walls were very thin, and during the surgical procedure, at many points of time, there was tearing of the bowel wall. So prior to the procedure that we did intraoperatively, this is what we saw. This was the status post the 3 surgeries he had undergone prior to our institute. There was a gastrojejunectomy which was in place with gross dilation of loops, as I've explained, and there was a jejunectomy placed. So the procedure which we had done for this patient was a bit unique because a simple Whipple's could have taken care of it, but given that he had so many comorbidities and he was malnourished, we decided to take care of the disease segment, preserving as much of the viscera and the pancreas as possible. So we did a resection of the gastrojejunectomy and the jejunectomy site, and a pancreas sparing duodenal resection along with papilloplasty and duodenal jejunal anastomosis. This was followed by biliary and pancreatic stenting, a transjejunal stent placement, Roux-en-Y gastrojejunostomy and a jejunojejunostomy. So I think it's easier if I provide it in the figure over here. The figure which you see to the right is the preoperative status, and this is the postoperative status. So what we basically done is taken out a part of the duodenum, done a papilloplasty, spared the pancreas as far as possible, created a rulum and put in a feeding tube to continue feeding the patient. Post-operatively, the patient did quite well. There was just a mild pancreatic leak which was managed conservatively, and he started accepting orally at the time of discharge. I'll be presenting a slide bit of the follow-up of our patient now as well. Presently, he's accepting orally. Our surgery was doing quite well. He's gained around 6 kgs of weight following this procedure. And in terms of objective assessment, his gastric clearance has increased. The baseline at 1 hour was around 12%, has gone up to 32. And in order to increase this, we've added prucalopride as an adjuvant. And post-operatively, we also reviewed the family history. This question had come up during this discussion as well. And we found that there was a history of similar abdominal pain and similar symptoms in his father as well. And he had undergone abdominal surgery at 40 years of age, but unfortunately expired during the surgery. So the exact details of that were not available to us, even on review of the previous data. That's all from my side. I'd like to request sir to please take over.
So thank you, chairpersons, and I thank Professor Makharia, Professor Nijapan, and the whole organizing team for giving me the opportunity. And as we have seen, this patient has a long history of 8 to 9 years. Will not repeat all those. But at this time, when the patient landed up at AIIMS, the blocks were submitted for review, and this was from the 2016 surgery, and it was mentioned that part of the duodenum was resected. So whenever there is a problem with the peristalsis, as a pathologist, what we do, we look into the ganglion cells which is present in the Meissner's plexus and Auerbach's plexus, and that we did initially for this case. And as you can see, this is the submucosal plexus where the ganglion cells are well preserved and there is no eosinophils, no inflammation. And that was also present in the Auerbach's plexus, and there was also no hypertrophic nerve bundles, no feature of degeneration or lymphocytic or eosinophilic cell infiltrate. But if we look into the peristaltic mechanism, the intestinal neuroenteric system is very complex, and it is innervated by the parasympathetic and sympathetic nerves, as well as it has intrinsic component which helps into the peristalsis. And that also includes this interstitial cell of Cajal and the perineuronal glial cell network. And this interstitial cell of Cajal network, a pathologist can very well observed by doing CD117 stain, and this is the network what we usually see. This surrounds the nerve plexus is in between two muscle layer, and when we see there is loss of these cells, we call this mesenchymopathy, and this is one of the important cause of peristalsis. But in the index case, as you can see, CD117 positive network, cell network was well preserved into the Auerbach's plexus, and they are also present in between two muscle layer, which is the normal pattern. There are other important components in addition to interstitial cell of Cajal is that there are muscles, and we know there are inner circular and outer longitudinal muscle. Outer longitudinal muscle layer is slightly thinner than the inner circular layer, and in addition to the anatomical changes, yes. And in addition to the anatomical changes, what we can also assess if there is any myofibrillar changes. Like you can see, this is a SMA control. The smooth muscle actin, it stains the muscularis mucosae and all layers of muscularis propria very evenly. But in cases of leiomyopathy, you will see there is loss of the SMA stain. This is an example of desminopathy where we see abnormal desmin positive inclusions in the muscle layer. And in addition to the muscle layer, what we need to also see, this is, they are called a fibrous sling. This is like a snake skin. It encases the muscle layer, both the muscle layer, and inside this muscle layer, the inner circular muscle and outer longitudinal muscle, they synchronously contract and the other one dilates. And this is very important. If this is lost, there will be a peristalsis again. And this can be highlighted by the serious red stain, which is a collagen stain, and it forms an obtuse angle, all these fibers between the inner circular muscle and outer longitudinal muscle layer. So what we saw in the index case, if you compare with the controls, in the index case, the inner circular muscle was normal. It was not hypertrophied nor atrophied. But if you look at the outer longitudinal muscle layer, there was irregular thinning. And there was a lot of fibrosis in the submucosa, in the subserosa. And this fibrosis was also present into the outer longitudinal muscle layer. See, comparatively, the inner circular muscle layer is normal. In addition, if we go into high power, we could see that all the muscle fibers, they are almost degenerative. We can see vacuolar degeneration, and there is marked loss of the muscle fiber. And this is actually pale zone, which is representing the collagen, which is replacing the abnormal muscle fiber in the outer longitudinal layer. And as you can see, this is inner circular muscle, this is the orbax flexus, there is no inflammatory cell infiltrate, and this is the higher part of the outer longitudinal muscle layer, where you can see all the cells, they are undergoing degeneration, vacuolation, and there is being replaced by fibrosis. This is the Mason's trichome and serious red stain. Both represent the collagen staining, and you can see the outer longitudinal muscle layer is very thinned out, and this has been replaced by collagen deposition in the outer longitudinal muscle layer. The inner circular muscle layer is normal. There is no evidence of atrophy or fibrosis. We could confirm that by again doing SMA and desmin stain in comparison to the inner circular muscle layer. See, there is marked loss of the muscle fibers into the outer longitudinal muscle fiber, and all these pale zone are represented, they are representing the collagen deposition, and it is same with the desmin stain also. So here, in addition, I talked about the fibrous sling, and this is a control where the fibrous sling should be present in both the layers and they form an obtuse angle. But here you can see in the index case, inner circular muscle layer as well as the outer longitudinal muscle layer, there is partial loss of this fibrous sling, what is called partial desmosis. This is another important cause, but this feature can also present secondarily, and it can be also lost transiently post surgery. This is an example of complete desmosis from another case. What is there in the mucosa in the index case? As you can see, this is the small bowel which was present there. There was mild villus abnormality, no significant villus atrophy. It was inflamed, and in high power we could see increased intraepithelial lymphocytes. So to summarize, the major finding what we identified is in the muscularis propria. Inner circular muscle was normal, but outer longitudinal muscle layer, there was irregular thinning, loss of muscle fiber, vacuolar degeneration, and there was marked fibrosis, which is also present into the subserosa. In the AIMS also, the patient underwent surgery, that was also mentioned, and these are the features from the fresh surgical specimen. As you can see from, in contrast to the control, in the surgically resected duodenum also, you are seeing marked thinning and loss of muscle fibers into the outer longitudinal muscle fibers. This is the high power. You can see all are degenerated muscle fibers, and this is being replaced by collagen. At places, the muscularis propria was very thinned out. This is again representing the same, and this is the collagen deposition we can see. This is again rarefied outer longitudinal muscle layer in some of the areas, and in high power we could identify vacuolar degeneration as well as intracytoplasmic inclusion, which were highlighted by PAS stain. This is periodic acid stain, and the deposition was diastase resistant. So this was the collagen stain. Again, in the index case, fresh specimen, similarly we could identify marked fibrosis which was present into the outer longitudinal muscle layer, very focally into the inner circular muscle layer, and there was loss of desmin and SMA fibers. CD117 positive interstitial cell of Cajal, they were present again in the freshly dissected specimen, and ganglion cells are normally present. So again, to summarize, in the freshly dissected specimen, the findings were similar into the outer longitudinal layer. So what was the diagnosis? And by this time, we were sure like there is no mechanical obstruction. So the diagnosis was intestinal, chronic intestinal pseudo-obstruction. And as already have been highlighted, we need to now think if the cause is primary or the secondary. We did not found any deposition of amyloid or any other features like inflammatory cell infiltrate. There was no significant drug history in the case. There was no neuronal pathology, especially we identified normal ganglion cell. There was no hypoganglionosis, no feature of intestinal neuronal dysplasia. So we thought it could be a primary muscular dystrophy. This CIFPO group was first classified clinically in 2009 by the International Working Group, and in 2014 we published pathological approach for classifying these intestinal myopathies. As you can see, these myopathies can be either anatomical or it can be constitutional abnormality like myofibrillar myopathy. I showed we have to do SMA and desmin stain to identify if there is loss or inclusions, or there can be degenerative myopathy both in children as well as adults. Anatomical abnormality can be either atrophic or hypertrophic. Atrophic type of myopathies can be either sporadic visceral myopathy or familial visceral myopathy 1, 2, and 3. Hypertrophic type of myopathies are usually of 3 types. In one type, which is the index case, there will be hypertrophy or normal inner circular muscle, but there will be atrophy and fibrosis of the outer longitudinal muscle, which is actually this case. On the other hand, there will be hypertrophy of both layers, which is called idiopathic muscular hypertrophy. And in the third type, there will be hypertrophy again of both the muscle fiber along with vascular degeneration of the muscle cells, that is called visceral myopathy hypertrophic form. There can be some other anatomical abnormalities. I will show you some cases. So to summarize the index case, we had normal inner circular muscle, but outer longitudinal muscle was very thinned out, and there was replacement by fibrosis. So our diagnosis was this was primary visceral myopathy type 4 involving the small bowel, esophagus, and stomach. And why there was increased ILs, we thought it could be due to bacterial overgrowth. So this is the visceral myopathy types, and there are 4 types already has been discussed. The first type is autosomal dominant, and it can present with megaduodenum and megacystis. Type 2, all other types are recessive. In type 2, we see ophthalmoplegia. Type 3 predominantly present as intestinal involvement, and type 4, it is autosomal recessive and show the classical feature what we saw in the index case. To very briefly give a definition of familial visceral myopathy, I quoted this title of this article, there is fall of the cytoskeleton. That is appropriate definition to describe the pathology. As we can see, as already has been asked by one of the respected chairpersons, that if these patients can present in the adulthood or not. See, familial visceral myopathy, 80% presentations are seen in the infants. They can be both a familial or sporadic form, but it has been described in the adults. This is a case which was described in a 18-year-old female. And she presented again with chronic history of gastroparesis, and metoclopramide was given. Then nutritional supplements were given. She did not improve over the years, and then again intestinal transplantation was done, and the patient improved dramatically. This was reported from a group from Michigan and New York. This is a 13-year-old female who again presented with almost similar like our cases, again markedly dilated stomach, and on the histological examination there was fibrosis into the muscle layer, so they identified this is visceral myopathy. This is one reported from the South Africa, one 13-year-old male, massively dilated intestine, and on the resected specimen there was again atrophy of the muscle fiber with replacement by fibrosis. This patient presented, this is a 30-year-old female who presented with markedly dilated intestine, and the history was of 10 years. And on resected specimen, there was marked atrophy of the muscle fibers, and again a visceral myopathy was described. This is a very rare presentation again in an adult who presented with acute appendicitis, and on radiological examination, there was found a dilatation of the ascending colon, and later histological examination revealed the patient was having visceral myopathy. As already has been highlighted, if genotyping can help or not, it can help especially in the visceral myopathy type 1, which is autosomal dominant. This is a Swedish patient family, and this is a Chinese family where whole exome sequencing revealed actin gamma 2 gene abnormality, and here myosin 11 gene abnormality mutations were identified. So if you are identifying visceral myopathy with megacystic and megaduodenum, it is worth ordering a whole exome sequencing. And as already been highlighted, full thickness biopsy or laparoscopic seromuscular biopsies are must to identify this group of lesions. Few examples, this is one of our cases where the part of the ileum was resected, and it was thought that there is a tubercular stricture in this case. There was again a diverticula where the capsule endoscope was lodged, and on histological examination we found a very curious case, and this is duplication of the muscular fibers with partial loss of the smooth muscle fibers, and there was also duplication of the mesenteric plexus, and in this case also we identified associated leiomyopathy. So this is a very complex case. This is another case of anatomical abnormality of the muscle fibers where dilatation of the intestine was identified when the fetus was in utero at 32nd week, and he was operated on the first day after birth, and it was found that there was a supernumerary layer of the muscularis propria. This is the inner circular muscle, this is outer longitudinal muscle, and there is a third layer which was present, and post-surgery the child did well. There are similar reports in the literature. This is another case where myofibrillar myopathy was identified in a child where there was a collapsed part of the intestine, and there was abnormal Desmin positive inclusions, and also there were multiple degenerated muscle fibers we identified on electron microscopy. This is a child where also we identified degenerative leiomyopathy, but here you can see degeneration and fibrosis involving both layers, especially the inner circular muscle layer. Degeneration can be seen by alkaloids, or it can be seen by anthracycline based chemotherapies, or by neuropsychiatric drugs, but it can be idiopathic. In this child, it was idiopathic. This is an example of intestinal neuronal dysplasia type 2 or type B, where we identified multiple giant ganglia. Giant ganglia are defined by presence of numerous ganglion cells, and most of them are immature. And it is important to identify what is the cause of the CIPO, because management is totally different. I highlighted some of the management points, and here if you follow up the patient and counsel the family after 3 to 4 years, these ganglia become often normal and the child gain peristalsis. This is one example where there is a transient postoperative peristalsis what was persistent, and we identified that there is, in comparison to the control, there is complete loss of the interstitial cell of Cajal. This is one example of aperistalsis from a 9-month of male, where you can identify marked degeneration of the ganglion cells and there is surrounding numerous eosinophilic cell infiltrate. There can be also lymphocytic infiltrate. This is called eosinophilic ganglionitis, more commonly seen in children, but can also present in adults, and usually in the serum, anti-nuclear hue antibody is positive. This is a recently discussed CPC in our center, where the patient was 42-year-old female. There was a old 10-year-old history of surgery due to renal cell carcinoma, and she presented with CIPO, and we identified there is numerous foam cell deposit with fibrosis of the outer longitudinal muscle layer, and this case was diagnosed as intestinal xanthomatosis. So what is the presentation summary? Today we saw a case of CIPO, which was very classical clinically, but the cause was visceral myopathy type 4 with secondary partial desmosis. All these are very rare disorders, but it is important to consider visceral myopathy as a diagnosis in patients with long-lasting or recurrent episodes of abdominal distension without evidence of mechanical obstruction like the index case. Especially adults can also present to you with chronic constipation, and there can be intermittent abdominal pain. There is a need to train the gastroenterologists and pathologists to recognize this uncommon group of disorders, because many pathologists often also not aware of these entities. A full thickness or seromuscular biopsy should be taken when suspected, and also mucosal or just a deeper biopsy will not help. At least the changes of myopathies need to be recognized. To differentiate between the primary and secondary is very important. And as I have already told, management is evolving, though it is not totally standardized, but management is not same for all and depends on the cause of the CIPO. So the cause, we should investigate the patient to know the cause, and discussion of these cases will help everyone in a multidisciplinary team meeting. So thank you so much for inviting me.
Thank you very much, Dr. Das, for a very exhaustive review and excellent pathological demonstration. I think we have 3 or 4 minutes left for this. Any quick comments from the audience? And who would like to share the experience?
In the literature, it is said that this patient undergo repeated surgery, and after some time, the pseudo obstruction will converted into a mechanical obstruction due to adhesions. So in the end, one may see a combination of pseudo obstruction plus real obstruction also. So that is also possible. This is one of the risks of repeated surgery in such patients.
That's absolutely right.
That's very well described actually. Initially they have only pseudo obstruction, then the element of mechanical obstruction is also added. I think the surgeon gave us some follow-up. Again, how much is the follow-up now after surgery? The surgery which you have done at AIIMS, and you said the last follow-up was patient had gained weight, symptoms were not there, but how much is the duration of this interval between the surgery and the last follow-up?
Sir, we have a follow-up of around 1.5 years.
Around
1.5 years.
1.5 years.
1.5.
Oh, that's pretty encouraging, because usually they would not show this kind of weight gain and no symptom almost 1.5 years. How do you explain it? Is it the usual experience in the literature that after this kind of surgery, they do well, they start gaining weight for almost 1.5 years of the follow-up now?
Sir, given that the patient had esophageal involvement, we were not expecting such a good response, because in literature described they usually don't do so well. But in the case of our patient with effective nutritional rehabilitation and continued feeding, we also added prucalopride to ensure that.
When did you see him last?
Sir, we saw him around a month back, and we've contacted him telephonically since he's not able to come very frequently.
That's really interesting. And I think before I close, one last minute while you're here, if the involvement is predominantly of small bowel, is any published data about the role of intestinal transplantation in these patients? It's only the involvement is only a small bowel. I know there's some limited reports, but I do not know much about it.
Sir, I would have to review the literature.
Okay, well, there are some case reports where the involvement of small bowel and people have been treating by small bowel transplantation, but probably that these patients, they have this kind of hollow visceral myopathy involving the whole GI tract, and therefore it's not likely to be very helpful in the long run. Well, ladies and gentlemen, before I close, I must say that this is a very good learning exercise for all of us.
So can I
Brilliant presentation by the clinician, Dr. Nandi.
So can I say a few words?
Presentation by the pathologist, Dr. Nandi. Want to make last minute comment?
Clinical diagnosis is usually by pattern recognition, and I think in this particular patient, we arrived at a functional cause of obstruction, that is SIPO. From SIPO, we arrived at idiopathic as the first differential, secondary being the second. The question is clinically, was it possible? The challenge was it possible to narrow it down further into a myopathy or a neuropathy? And if a myopathy, could we have arrived at such uncommon conditions? I think as far as myopathy, neuropathy is concerned, there were certain clues like esophageal manometry was more suggestive of a myopathic involvement rather than neuropathic involvement. But then I was reading that in a longitudinal muscle involvement, a very good clinical clue is that you get valvular packing in the gut because obviously the muscles get fibrosed also. Now the pictures provided, actually they didn't have that particular sign. But then of course, as I said, this is just one sign, one clue. So I don't know what's the feeling of the house that can be clinically differentiated between myopathic and neuropathic disorders. And the second question was, which sir has already asked, that have we seen or heard last of this patient? I think a lot more things are going to develop in future because this is not a definitive treatment what we have offered. Thank you.
Thank you very much. Once again, like to thank both our clinical discussant as a pathologist for doing such an excellent job.
Thank you for this session. For the next session on acute pancreatitis, can I please invite Dr. D.K. Bhargav, Dr. Philip Augustine, and Dr. Siddharth Srivastav to please chair this session.
Well, we start our next session is acute pancreatitis, and the first speaker is on intracellular events in acute pancreatitis beyond enzymes, Dr. Tony George Jacob. Dr. Tony. Yeah.
So good morning, and thank you very much, sir.
Let me see, Dr. Tony is
Yes.
additional professor, Department of Anatomy, All India Institute of Medical Sciences, New Delhi.
Yes, sir.
Yes, Doctor.
Thank you very much. So, thank you very much to the organizers for inviting me to present some of our work and our ideas about acute pancreatitis and things that are beyond what is already known. That is, what is known is usually about, everyone knows about how the zymogen granules co-localize with the lysosomes, and that eventually leads to the autolysis of the cell, the release of a lot of the enzymes, which leads to the cascade of events that is called as acute pancreatitis. But beyond that, there are many other events that take place which could precede or actually be part of the entire event of the pathogenesis of acute pancreatitis. For example, an extremely important ion is calcium. Then there is UPR, that is unfolded protein response, and the ER stress that can happen, mitochondrial dysfunctions and oxidative stress, dysfunction of autophagy, as well as damage-associated molecular patterns and their receptors. So I would start with something that is very basic that you are all aware of and that you are extremely familiar with, and that is the pancreatic acinar cell, which is one of the most beautiful cells that is there in the human body. And it is a perfect example for me to teach a structural and functional correlation to my undergraduate students. And this acinar cell, it forms in a typical histological section, it forms these little round structures that are known as acini, wherein you can see a bipolar staining, where the central portion has the zymogen granules that are eosinophilic, whereas the peripheral portion has the nuclei as well as a lot of rough endoplasmic reticulum. And it is this rough endoplasmic reticulum where a lot of the protein is produced, that is, translational activity takes place. And there are multiple functional zones to this pancreatic acinar cell. Most importantly, an apical zone, which contains these zymogen granules and is involved in the secretion of the enzymes or the protoenzymes into the pancreatic duct. and also a basolateral zone wherein a lot of the synthesis takes place and a lot of regulation takes place of the pancreatic acinar cell. So if we look at it in electron microscopy, you can see that it's a typical pyramidal cell wherein you can make out that it has a basal portion as well as an apical portion which is exposed to the lumen where the secretions take place. So what you're seeing is these black granules, electron dense granules, are actually the zymogen granules. I'm sorry. And here, because of the functionality of the cell, sometimes you may get even more than one nucleus because it's an extremely transcriptionally active cell. And towards the basal aspect, there are a large number of rough endoplasmic reticulum which is involved in the translational process. Now, this acinar cell is a protein factory. Apart from the lactating mammary gland, this is one of the largest producers of proteins in the body. And because of this protein production, you may be aware that protein production is an extremely tightly quality controlled process. However, there is a catch when it comes to the pancreatic acinar cell, and that is that the secretions actually go out of the body, and that is into the lumen of the gut. And therefore, the tightness of the quality control is not as much as you may expect in an area where the cell is functional within the body, or the proteins are supposed to be functional within the body. And because it has got such a high output of protein synthesis, it also has a lot of QC as well as a lot of recycling that takes place with the help of the process of autophagy. So this is something that I would like you to keep in the background of your mind while I go ahead. Now, what all can actually hurt the cell? So when we learn medicine, one of the important etiological agents that we discuss when it comes to pancreatitis are alcohol and gallstones, particularly gallstones. And that is the reason why one of the important models for replicating pancreatitis in the labs are also surgical models wherein we either ligate the duct, obstruct the duct, or even inject bile salts or bile pigments into the duct to reproduce the same thing that happens when there is a microlithiasis of the pancreatic duct, usually arising from the common bile duct. Apart from that, there are multiple other reasons that can lead to pancreatitis, like toxins, infections, hyperlipidemia. There could be drugs. It could be iatrogenic as well, particularly related to ERCP. Now, how does it hurt? I'll take a classical example of gallstones, which through microlithiasis can produce acute pancreatitis. Now, there are two theories behind it. One is that the increased intraductal pressure itself alters the fluid dynamics of the pancreatic exocrine gland. That is, we all are aware from whatever physics that we've learned in school that fluid will always flow from a region of high pressure to a region of low pressure, right? Now, if there is an increased intraductal pressure for various reasons, it could be experimental, it could be pathological as well. This fluid dynamic alters. And what is located near the apical domain of the pancreatic acinar cell are mechanisms for the secretion of the zymogen granules. And that is also secreted under a pressure dynamism. And if there is an increased intraductal pressure, this doesn't happen, and that we call as an apical block. And if there is an apical block, what we see in many models of acute pancreatitis is that there is an accumulation of zymogen granules. Now, the zymogen lysosome theory says that, yes, if there is an apical block, the lysosomes come and fuse with them, and there is an auto-activation of the enzymes within the pancreatic acinar cell, which leads to the auto-digestion and so on and so forth. But a very important thing that you must remember is that lysosomes don't go and automatically go and dock with or join with a zymogen granule. There has to be a factor that is actually mediating this docking. And a very important factor over there is actually calcium. So where does this calcium come from? This increase in the intraductal pressure itself alters the cell junctions that are present at the apical domain. And the cell junctions which are tight junctions which prevent any leakage, and it seals off the luminal compartment which belongs outside the body and the basolateral compartment which belongs inside the body. So those tight junctions are very important. And this increased intraductal pressure disrupts the tight junctions. And the moment there is a disruption of the cell membrane, one of the easiest molecules that comes inside is sodium and calcium. And the moment this calcium comes inside the pancreatic acinar cell, it activates something that is already known in glomerular damage, and that is calcineurin. Which is why in a lot of glomerular diseases, as well as in graft versus host diseases related to renal transplants, we use a lot of agents that are actually used to inhibit this activation of a very significant calcium-related protein, and that is calcineurin. So sirolimus that is used in graft rejections is actually a calcineurin inhibitor. So this calcineurin, the moment there is an increase in the amount of calcium, it gets activated, and that in its downstream pathways can activate not only the inflammatory response, but also relate to other cell responses, which include cell death as well as the inflammation that we see in acute pancreatitis. Now, this increased calcium also helps in the docking of the lysosomes and the zymogen granules, which leads to the autodigestion, which is seen. Now, apart from that, whenever there is microlithiasis, there is also a possibility of reflux of the bile into the pancreatic duct, and the bile salts themselves have G-protein coupled receptors on the apical domain of the cells. And these G-protein coupled receptors also function as calcium channels, which again increases the amount of calcium in the cell, which can again produce the autodigestion that is seen. Now, the other common cause that we see for pancreatitis is alcohol. So a lot of people with high intake of alcohol and in alcoholics, they have a tendency for an increased incidence of acute pancreatitis. Now, alcohol itself can produce multiple methods of injury to the pancreatic acinar cell. The first and foremost is the generation of acetaldehyde and fatty acid esters, which again can disrupt calcium homeostasis. And a central molecule in all this is NF-kappa B, the nuclear factor kappa B, which is a central regulator of a lot of cellular processes, which includes inflammation, cell death, cell regeneration, autophagy. A lot of homeostatic processes can be regulated through this nuclear factor kappa B. And eventually, because of the calcium homeostasis imbalances, it can also lead to the zymogen activation. But apart from that, whenever there is this free fatty acid ratio, it also changes the ratio of lactate to pyruvate, which in turn also changes the redox balance of the cell. And whenever there's a change in the redox balance of the cell, again, there can be damage to the mitochondria, release of factors that can again produce the inflammatory response that we see in pancreatitis. Now, apart from that, apart from these two common causes, something that we replicate quite a lot in the lab is the use of toxins. And those toxins could be cholinergic agonists like nicotine. And in the lab, what we use are cholecystokinin analogs as well, which hyperstimulate the pancreatic acinar cell. Now, whenever you hyperstimulate a cell that is meant to produce proteins, the thing that would happen is that there is a hyperstimulation of protein production. And whenever there is a hyperstimulation of protein production, you can understand that there would be a lot of proteins that is produced, and then the endoplasmic reticulum that is actually producing it needs to be on the job to check the quality of the protein. And whenever there is too much of anything happening, the quality check also gets affected. And therefore, the cell goes into endoplasmic reticulum stress because of an unfolded protein response. And that itself can activate the NF-kappa B and the inflammatory pathway. And if the cell is not able to produce adequate processes of homeostasis, the cell can again go in for cell death. Another agent that we use in the lab is L-arginine, and large amounts of this levo form of the amino acid arginine. So the usual amino acid that is used in the cell is the dextro form. This levo form, whenever given in excess, cannot be used for protein synthesis. So it actually breaks down and produces a lot of nitroxidative species, which is a cause for oxidative damage again. And that affects the mitochondria and produces cell stress again. Now, whenever this also happens, that you can have multiple toxins that also come and activate the cell. And these toxins could also be coming from the damaged cell. For example, cytochrome C or double-stranded DNA or RNA, which are packed inside a cell. The moment it comes out of the cell, including ATP, they all can produce damage by themselves. And these molecules are known as DAMPs. So these DAMPs were discovered because of their ability to activate certain receptors which were responsive to bacterial pathogens like lipopolysaccharide. And some of those receptors are like the toll-like receptors, the TNF-alpha receptor complex, the NOD-like receptors. So there are multiple receptor complexes which downstream of themselves, if you can see, would be producing an activation of NF-kappa B, production of pro-inflammatory cytokines, and either cell death or inflammatory responses. So whenever these DAMPs or alarmins activate these kind of death receptors or death domains on the cell surface, we can get inflammatory response through the complex 1, apoptosis of the cell through complex 2, or even necroptosis, which mimics the necrotic kind of the cell death morphology but it's a programmed form of cell death. So whenever there's necrosis, there is a breakdown of the cell membrane and the cellular contents come out, which again reinforces DAMPs on TLR4 receptors on other cells, and which just keeps on cascading the process. So there are multiple levels of cell injury which can lead to either necrosis or apoptosis, which perpetuates the damage. So in summary, there are multiple common pathways which can not only produce the damage but also perpetuate it. So the multiple responses can be there to multiple injuries, and the activation of enzymes is probably an effect and a bystander of the injury and not necessarily the actual causative injury. So what we see as autodigestion of the pancreas is probably an effect and not necessarily the cause. So that is what I would like to leave you as a message beyond the enzymes inside the pancreatic acinar cells. Thank you very much.
The discussion will be at the end of all three presentations. Now I call upon Dr. Rakesh Kochar from Chandigarh to present on the important topic of organ dysfunction in acute pancreatitis. Dr. Kochar doesn't need any introduction to this gathering, I suppose.
Thank you, chairpersons, and I must thank the IST for giving me this opportunity today to discuss a bit about organ failure in acute pancreatitis. We know that the three major determinants of outcome in acute pancreatitis are organ failure, necrosis, and infection, and in many ways there is a reciprocal relationship between organ failure and necrosis. The revised Atlanta classification uses modified Marshall scoring system to classify and grade organ failure. The three organ systems which are taken into account are respiratory, renal, and cardiovascular, and a score of 2 or higher indicates organ failure of that particular system. It was about 20 years ago that it was recognized that organ failure which persists beyond 48 hours is associated with higher number of local complications as well as mortality in comparison to transient organ failure, which is organ failure lasting less than 48 hours. Thus, accordingly, in 2012, the revised Atlanta classification has used this as the major fulcrum around which classification of severity of acute pancreatitis is defined. So, presence of persistent organ failure defines pancreatitis to be severe. mere presence of organ failure which is transient defines the severity to be moderate. Now, organ failure in acute pancreatitis occurs following inflammation, tissue injury, and the initial or the early organ failure is due to the systemic inflammatory response, and later on in the course of the disease you have late or secondary organ failure because of infection, which is the second hit. Infection occurs in increasing frequency as the time lapses, as the disease progresses. The impact of primary versus secondary organ failure was defined very clearly by this study from AIIMS led by Pramod. They had 614 patients, of whom 274 had organ failure, 177 had primary and 97 had secondary. Among those with primary organ failure, early deaths occurred in 16% of individuals and 84% survived this, and a sizable number of them developed infected necrosis. Those who did not have primary organ failure, 437, of them 40% developed infected necrosis, and in them 60% of them developed secondary organ failure with a mortality of about 38%. So we have two phases: primary organ failure because of SARS and secondary organ failure because of infected necrosis. It is not merely the presence of infection in the pancreatic or peripancreatic tissues, but also extrapancreatic infections which are also related to development of secondary organ failure. And the second aspect is that infection with multi-drug resistant organisms, whether in or around the pancreas or elsewhere, can also lead to complicated course and higher mortality as compared to the drug sensitive organisms. How often does organ failure occur? 8 to 20% in population based studies and up to 40% in tertiary centers. How often does single and multiple organ failure occur? You can have a single organ failure, 2 organ failures, and multi-organ failure, all the 3 organs failing. So in this apprentice study of from 22 international centers, it was seen that single organ failure occurred in about 54%, 2 organ failed in 27%, and 3 in 19%. Respiratory system was the commonest organ involved, followed by renal failure, and the last one was cardiovascular. However, studies from different parts of the world will have different frequencies of organ failure. It has been shown by many studies, virtually everyone has unanimity on the fact that mortality increases with the number of organs failed. Single organ failure 4%, 2 organ failures 33%, 3 organ failures as high as 50%. Which organ fails first? This was looked at by the Dutch study group. The respiratory system generally fails the first and lasts the longest. The renal failure has the shortest duration, probably because of effective renal replacement therapy. Timing of organ failure. The primary organ failure will occur right in the beginning, in the first week, and beyond second week you will have the secondary organ failure. So you have a high group of patients who will have high mortality in the first week itself, and then you have a peak beyond the second week. However, the Dutch study group did not find that the onset of organ failure had impact on mortality, though many studies, including the one from AIIMS, which had actually defined severe acute pancreatitis with organ failure occurring in the first 48 to 72 hours having the highest mortality. So there's slight variation in reports of results of this particular study. Duration of organ failure, again, many studies have suggested that longer the organ failure lasts, the higher is the mortality, and that probably holds true in our setup, though this Dutch study did not find any correlation between the duration of organ failure and the mortality. This apprentice study also did not find the onset or total duration of organ failure to be affecting mortality, but as I said, the results of different studies are at variance. Now, can you predict organ failure? Yes, the clinical scores like APACHE-2 and BISAP can be used to predict. More effective is using the SIRS score. It has been seen that greater the SIRS score, and if this SIRS score is worsening, there is a higher risk of persistent organ failure. And if the SIRS score is persistent, then the odds ratio for development of organ failure is 26 times as compared to those who have transient SIRS. This is understandable. The area of curve for worsening SIRS was 0.85 as compared to area of curve for only SIRS, just taking it as positive or negative, it was 0.70. So can you add to SIRS? Yes, by using IL-6 levels, it has been shown that a combination of SIRS and IL-6 will have better predictability of organ failure. We had shown that a combination of IL-6 and IL-8 more than 250 picogram per ml has very high specificity for development of acute lung injury. For acute kidney injury, urinary NGAL or even serum NGAL has been used by different people in critical care and elsewhere to predict the development of renal failure. So this seems to be a good marker of prediction of renal failure. Now, as I said, there is a important interplay between these three factors, particularly organ failure, necrosis and infection. Universally, it has been shown that the greater the necrosis, more are the chances of persistent organ failure. It has also been seen that patients who have peripancreatic necrosis have higher chance of organ failure, and some people have even attempted to quantify the extrapancreatic necrosis and seen that there is a correlation between the volume of extrapancreatic necrosis and organ failure. Infection and organ failure. Most studies till a decade ago had shown that in presence of infection has higher chance of organ failure and higher chance of mortality, and presence of infected necrosis versus only organ failure, presence of infected necrosis only organ failure versus no organ failure, there was higher mortality in both the groups, but a combination of the two, that is presence of organ failure as well as infected pancreatic necrosis, doubled the risk of mortality. According to this, subsequent to this, this determinant based classification was devised, which included critical acute pancreatitis beyond the severe acute pancreatitis. That is, critical acute pancreatitis was one which had both infected necrosis and persistent organ failure with the highest mortality among the groups. However, recent studies in the last 10 years with better antibiotics, better drainage of infected collections endoscopically and percutaneously, better intensive care management have shown that the currently infected necrosis does not carry as bad a prognosis as it was over 10 years ago. And this Dutch study showed that infected necrosis and sterile necrosis had the same mortality if organ failure was present or not. In fact, sterile necrosis had a higher mortality, but when they excluded patients in the early phase, first 7 to 10 days, the mortality was similar. What is the impact of organ failure? How different characteristics of organ failure can impact the outcome of acute pancreatitis, and which organ failure is the worst in terms of subsequent course? It was shown by Ragesh at our center that transient organ failure 0 mortality, persistent organ failure 42% mortality, but among this persistent organ failure, if the organ failure was deteriorating, the mortality was very high. This is simple to understand. Then it was also shown that patients who have hypotension in the first week are more likely to have infected necrosis as well as bloodstream infection. Possibly the reason was that hypotension in the first week will have ischemia, more ischemia of the pancreas, making it devitalized and making it more prone to infection. Now, mortality with persistent organ failure, the sequence of organ failed. It has been shown in that apprentice group that mortality is higher when the cardiovascular and lung failure occurred first or concurrently as compared to when AKI occurred first. It was seen that presence of renal failure has better outcome as compared to when there is cardiovascular or lung failure. It was confirmed for both when 2 organs were involved or all 3 organs were involved. Looking at the upper figures, 3-organ multi-organ failure with renal failure first had 30 times odds ratio as compared to single organ failure for mortality, but the odds ratio was 600 when the respiratory failure or cardiovascular failure occurred first and the renal failure was not there. Another aspect which has been looked at is if the occurrence of organ failure is simultaneous, that is within 24 hours, or sequential, that is beyond the second organ fails beyond the first 24 hours, after 24 hours of the first one. It was seen that sequential organ failure has worse outcome as compared to simultaneous organ failure. Again, it was seen that presence of renal failure had lower mortality as compared to cardiovascular or lung injury. So patients with sequential organ failure had the worst outcome as compared to simultaneous organ failure. With no organ failure and single organ failure, the mortality was much less. Lastly, coming to COVID and acute pancreatitis, a problem we all faced, particularly in the second week. In this study, between AIIMS and PGI, we had collected 85 patients who were COVID positive and compared them with 230 propensity matched controls, propensity for severity. So we had 3 types of patients. One was COVID-related acute pancreatitis, that is when acute pancreatitis was attributed to COVID viral infection. The second group was superadded COVID on a patient of acute pancreatitis. It was divided into co-infection if it occurred within first 2 weeks and superinfection if it occurred beyond 2 weeks. It was seen that between the 2 groups, though they were severity matched, there was more lung injury in the COVID patients and higher mortality. And among the 4 groups, that is COVID acute pancreatitis versus the other groups being COVID co-infection, COVID superinfection and non-COVID acute pancreatitis, the first group, that is COVID acute pancreatitis, had the highest mortality. It was probably related to the lung injury. As is seen in this picture, that the first picture had mild COVID lung, severe acute pancreatitis. The second picture has severe COVID lung on X-ray and CT scan and moderate pancreatitis. So the outcome was much worse in patients who had severe COVID, that is primarily COVID lung. The management revolves around triaging the patients, monitoring the patients and giving them fluids, basically organ support in the beginning. There is a question being raised that should the initial part of management, before we start managing complications with endoscopy or percutaneous drainage or whatever, should the initial part be given to the intensivist rather than to the gastroenterologist? Thus, to summarize, ladies and gentlemen, organ failure is the most important determinant of outcome. SIRS score and interleukin levels can predict organ failure, and you have the number of organ failures and grade of organ failure are related to mortality. The association between infected necrosis, onset of organ failure and duration of organ failure and mortality, there are conflicting reports, but there's an association between at least the onset of organ failure and mortality. Lastly, sequential organ failure has more mortality than simultaneous organ failure, and mortality is probably higher if the cardiovascular and respiratory failure occurs first than renal failure. Probably more data needs to be seen on this. And COVID acute pancreatitis has worse outcome than patients of co or superinfection with COVID in patients of acute pancreatitis. Thank you for your patient hearing.
Thank you, sir, for a nice talk. So we will take questions at the end of the session. The next talk is on how to improve outcomes in acute pancreatitis, to be delivered by Dr. Pramod Garg. Sir is a professor of gastroenterology, and it's my privilege to invite him to take up the lecture.
I'd like to thank the organizers for this opportunity. So, I'd like to talk about improving outcomes in acute pancreatitis. And what I've written here is, it's a disease looking for a treatment. I have no disclosures. So my talk has actually been made very easy by the previous two talks by Tony and Professor Kochar. Acute pancreatitis, we know, has both local as well as systemic injury. And often the local injury correlates and probably leads to systemic inflammation, as highlighted earlier. And it is the systemic inflammation which leads to organ failure. And we know now that there are two major determinants of survival in acute pancreatitis: organ dysfunction and infected necrosis. Now, if we have to decrease mortality, what is it that we need to do? So the things that have emerged here, number one, we have to suppress systemic inflammation. Second, we have to prevent necrosis. And possibly, if we can, prevent infection in that necrotic collections. And this also probably by decreasing SIRS. And of course, we have to have targeted therapy to improve or prevent organ failure in these patients. These are, very, very important goals. Whether we have been able to achieve some of them or not, we're not sure. So the conceptual model that we have discussed so far is that there is tissue injury which leads to local and systemic inflammation, and systemic inflammation leads to organ dysfunction. In the first 24 to 48 hours, there is cellular stress and cellular injury. What Tony has shown very clearly, that acinar cell injury results in the beginning, but beyond that period, there is glandular necrosis. And there is an important differentiation between cellular injury and glandular necrosis. So you have cellular injury in the beginning of the acinar cells leading to inflammation. And as Tony has shown, there is release of DAMs which act on the inflammatory cells, which release multiple cytokines. And these cytokines in the beginning attract local inflammatory cells to the pancreas and the peripancreatic area, but subsequently also lead to systemic inflammation. So the paradigm here is you have acute event, which could either be infection, trauma, or pancreatitis, leading to local inflammation and tissue injury, release of PAMs and DAMs, which leads to pro-inflammatory response, leading to systemic inflammation, and finally, organ dysfunction. There could be a second hit, what Dr. Kochar has mentioned, of infected necrosis, which can also lead to organ failure. And Dr. Kochar also referred to COVID-19. The reason I'm bringing this slide here is that we have now understood that even in infectious disease, less than 5% of patients developed organ failure, although the virus was the same all over. What was the reason? These were the patients who had what is now known as cytokine storm, sudden massive increase in cytokines, which led to organ dysfunction. And steroids were effective in a condition which is led by infection. Mind you, this is very important. Everybody is scared of giving steroids in infectious disease, but here actually steroids save thousands of lives, or rather hundreds of thousands of lives all over the world. So same way, even in acute pancreatitis, IL-6 and has been shown, for example, many years ago by us, that correlates with organ failure. Dr. Kochar has also shown that. Tony has also shown that. Recently we showed that presence of SIRS and IL-6 could predict development of organ failure very, with a high positive predictive value. And also nowadays, actually we measure IL-6 on a routine basis. No more it's a research tool for us. Almost every day, patients who are sick in the ward will have an IL-6 determined. And this is unpublished data of 6 patients in whom you find that as the IL-6 improved, their organ function improved and they survived. And on the other hand, this is a series of patients in whom IL-6 remained very high, upwards of 400, 500, and even beyond that, and all of them died. So there is a very clear-cut correlation between the clinical trajectory and IL-6. So for organ failure to improve, we have to target systemic inflammation. Simultaneously, what is happening in these patients when they have systemic inflammation is circulatory changes. And these circulatory changes lead to glandular necrosis, what is called as pancreatic necrosis or peripancreatic necrosis. So many years ago, we showed in a study of perfusion CT that in the beginning, within the 24 hours, if there is decreased perfusion, then this correlated with, so for example, here you find decreased perfusion, later on CT showed necrosis in that area. In this picture, you find multiple areas of hypoperfusion, and there is a lot of necrosis later on. So the sensitivity and specificity of perfusion CT was very high. What does it tell us? It tells us that if you have to prevent necrosis, first we have to target systemic inflammation and also possibly reverse ischemia. We are not talking about cellular injury here, which has already occurred. Another thing which is happening during the first week is when you have this very large amount of systemic inflammation and cytokine release, this leads to a compensatory anti-inflammatory response or CARS. And there are multiple mechanisms which lead to this state, and this is a state of relative immunosuppression. So three things happen here. You have necrosis here, you have CARS, and also you have increased intestinal permeability, and these factors lead to infected necrosis. And this is how the severity and the course of the disease pans out. You have early peak because of the initial cellular injury and glandular necrosis, activated enzymes, cytokines, vascular injury, leading to primary organ failure, and late peak because of infected necrosis, again leading to increased inflammation and organ dysfunction. And this is what Dr. Kocher has mentioned, that now we understand that there is a state of primary organ failure and secondary organ failure which should be understood. And if we have to decrease mortality, and mortality in these patients in our series combined all together was 42%. This is similar to the World report. That study showed 38% mortality. Spanish study showed 52% mortality. All over the world, the mortality remains the same in severe pancreatitis. So these are the goals that I listed initially: suppress systemic inflammation, prevent necrosis, possibly by reversing ischemia, prevent infection, and there also we need to understand that we have decreased SIRS so that CARS does not set in, and develop some targeted therapy. Unfortunately, as of now, none of these is available. And that's why I mentioned in the beginning, it's a disease looking for a treatment. But we can still improve outcomes, and I think we have to some extent. So what can we do and what we ought not to do is also very important to understand. So in the first week of illness, many times we don't pay enough attention for analgesia. And I think providing adequate analgesia, preferably with opioids, is very important. There is a school of thought that if there is persistent pain, it may actually feed into inflammation. And then some work has been done. So adequate analgesia is very important. There was one study from China 2 years ago which showed that COX-2 inhibitors might also improve survival by decreasing inflammation, but I think we need more confirmatory data before we can recommend that. Then I discussed on the first day of the conference that early enteral nutrition is very, very important in these patients. It preserves intestinal integrity and thereby possibly prevents secondary infection, and this is through increase in the intestinal alkaline phosphatase. Also, we should not give prophylactic antibiotics because it can lead to MDR infections and fungal infections, and this is not just theory. In a study that we conducted many years ago, we found that of 209 patients, there were overall mortality of 22%. The independent predictors of mortality were one, organ failure, which we know, and Dr. Kocher very elegantly described that. But more importantly, we found that infected necrosis due to MDR infection was a predictor of mortality, but infected necrosis per se wasn't a predictor. What does it mean? It means that if you have infected necrosis, but you don't have MDR infections, today with the available tools that we have, we can easily treat these patients. It doesn't really lead to mortality. In the first week, again, we have to give optimum hydration. So analgesia, early enteral nutrition, no antibiotics, and optimum hydration. What is optimum? Again, we don't know. There has been a lot of debate about aggressive and non-aggressive. So the recent trial, Waterfall trial, published late last year, in NEJM from Spain showed that of 249 patients who were randomized to either aggressive or moderate aggressive resuscitation, the incidence of primary outcome, that is incidence of moderate to severe pancreatitis, wasn't different, but patients who were given aggressive fluids had, more of them had fluid overload. So the point here is we should not harm the patient by giving too over-aggressive or overzealous treatment. And that is what we wrote in an editorial 2 years ago. The concept here is that if you have mild pancreatitis, whatever amount of fluid you give, this is okay. Even if you give more, the body's responses are preserved. So body will just do diuresis, will result in diuresis, and there's no problem, right? But if you have moderate to severe pancreatitis, what is happening is there is release of a lot of inflammatory cytokines which act on the vascular endothelium, causing capillary leak syndrome. And these are the patients, if you give more fluid to these, more fluid will leak out, there will be more interstitial edema, more tissue hypoxia, and this will add to the systemic injury. So we should not give more fluid, and I would recommend that all units which are treating severe pancreatitis patients should have these two modalities, that is bedside ultrasound for measuring the IVC diameter and also a lung ultrasound. This is not difficult to do, I can tell you, but it should be done to understand what is the fluid status. And the recommendation today is to give about 3 liters of fluid, preferably ringer lactate, over 24 hours, depending upon, of course, the fluid assessment and severity of pancreatitis. And beyond 3 days, the intake should be as per output. Now, beyond the first 2 weeks, the mortality governed by infected necrosis, and the current treatment paradigm for infected necrosis is conservative first approach. That means you treat them with antibiotics, supportive therapy, go on for percutaneous drainage, and then if required, minimally invasive necrosectomy. And many years ago, we showed that primary conservative treatment results in mortality which was somewhat lower in patients who are treated surgically. And it wasn't statistically significant, but numerically we found it is lower. There were a lot of skepticism about this. How can you treat infected necrosis conservatively? But then in a meta-analysis, again, we found that 64% success could be achieved with the primary conservative therapy. 2 recent trials, not really recent, maybe 4 or 5 years old, Miser and Tension have shown that endoscopic drainage, which is minimally invasive, results in mortality between 6 to 18%. So the mortality has now, there is a trend mortality to come down in single digits. It will take some more time, but I think it should be there. Very important finding of a recent Dutch trial, this is a Pointer trial, was that 1/3 of patients who were designed to have either early drainage or late drainage could be treated with antibiotics. So reaffirming the fact that infected necrosis, we should treat them with conservative first approach. So coming back to the slide, the goals that I have listed, what is the future? Where are we now and what is the likely future? So I searched the WHO and clinical trials registry for various trials which are currently ongoing in acute pancreatitis, and I could find 134 trials on acute pancreatitis. These were related to analgesics, nutrition, fluids, endoscopic therapy, post-ERC pancreatitis, and systemic inflammation. But the ones that caught my attention were related to those efforts at decreasing systemic inflammation. So there is one trial ongoing in UK. They just started recruitment on TNF-alpha antagonist. There are 2 trials on steroids, one in USA, and that is why I mentioned about steroids in COVID. There is one trial on CytoSorb, which is extracorporeal removal of cytokines. There is a trial ongoing in Germany. And there's one trial on anti-IL-6, tocilizumab, in patients with predicted acute severe pancreatitis. And that's why I mentioned about IL-6 being important in the pathogenesis of systemic inflammation. There are some recent newer concepts. One of them is calcium channel, and Tolley elegantly showed that how calcium signaling could be very important in the beginning. And the same calcium signaling also operates in the immune inflammatory cells. And there is a trial ongoing in the US on calcium channel inhibitors, and possibly this trial will also come to India. There are 2 trials on low molecular weight heparin, and that is why I mentioned about reversing ischemia to prevent necrosis in the beginning, and there is a possibility that we may have something on that. So, ladies and gentlemen, I'd like to summarize by saying that in the first week of illness is critical. We need to provide adequate analgesia, optimum hydration, no antibiotics, and early enteral nutrition. And with these measures, we have shown some reduction in mortality across different centers. No intervention should be done at this stage. Please refrain from doing interventions in the first 2 to 3 weeks. For infected necrosis, conservative first approach should be the norm. And we need to develop targeted therapy for systemic inflammation, and I'm happy that there are at least 6 or 7 trials ongoing across the world, which will likely show some improvement. And I'd also like to invite you all for a joint International Association of Pancreatology and IPC conference later this year in September in New Delhi to learn more about pancreas. Thank you for your kind attention.
Should other speakers come to stage also? Dr. Jacob and Dr. Kocher.
I think you can come here.
Yeah. One chair less.
Yeah.
Aye. Well, we invite questions from the audience.
Excellent talks and very informative and very succinct. Question, I think any Dr. Kocher or Dr. Pramod, anyone can take that. So our intensivists are now insisting that the patient is not improving, especially in the 3rd week, to add antifungals empirically. Good idea, bad idea? How do we prove, disprove?
So, I don't think we have enough data to support that. In one study, we found that 9% of our patients had invasive fungal infections, but that was, beyond 3 weeks, maybe 4, 5, 6 weeks. But yes, if patient isn't improving, he's on, maximal antibiotic support, ongoing sepsis, I wouldn't say no. I may not start, but I wouldn't say no. Yeah. Sorry about that diplomatic answer.
Dr. Pramod, most of the times when the patient land up in any center, he has already been started on antibiotics. So that's a big problem. What to do in those cases?
Right. So, it depends on the timing. If patient comes in the first week of illness on antibiotics, I would stop it. I'm not too worried about that. Because I can always start antibiotics, there's no problem. But so far, the data we have suggests that it doesn't really help. So, might actually harm. So, I would stop it without thinking. Often there is, this false sense of security to say if I start antibiotics, I'm covering everything.
That's a wrong.
Shouldn't do that, yeah.
And secondly, that how best is the judgment by aortic pulsations that you can, or
the IVC diameter, I think is fairly accurate. So IVC diameter is very easy to measure. You can see whether there is underfilling or overfilling, and do a bedside lung ultrasound. All our residents now do bedside ultrasound.
That's everybody is doing. So
yeah. So I think this is much better than CVP, the central line. That has its own limitations.
My question pertains to percutaneous catheter drainage. When you say no intervention, I suppose you are not considering PCD as a intervention. So what is the indication for doing a PCD, and how important is increased intra-abdominal pressure in causing the organ failures?
So I think again important point. So PCD, even the first 2 weeks, I would say hold on. Most of the times, sometimes you can go in for a PCD in 3rd week if required. And the recent Pointer trial that I mentioned actually showed that if you postpone your drainage, you are okay beyond 4 weeks, right? So 3rd week onwards, you can do PCD. For intra-abdominal hypertension, you can do it anytime. If you have collections, you have some ascites, whatever, you just drain it out. Because some or the other you will try to reduce pressure, but you may not be able to do so, but yes.
Good morning, sir. Actually, I have a question that regarding acute necrotizing pancreatitis, or a pancreatitis with acute necrotic collection. So as per data, 50% mortality if it is infected. So, but it can be sterile also. So whether any center will take a risk of not starting antibiotics in case of acute necrotic collection?
What is risk? In fact, there is risk if you start antibiotics.
But sir, 50% mortality if it is infected.
But
so
it's-
unless
it-
we put a needle, we cannot prove that it's infected.
Right, but
so
it-
whether we'll do a PCT or
So,
we'll start.
so the question is, when do you want to start? First week, no. You might actually end up having more severe infection. But if you suspect infection the second or third week onwards, surely you start antibiotics. But prophylactic antibiotics, no. Empirical, yes.
How far are we from making low molecular weight heparin as a standard of care?
So, you know, there are animal experiments to show it is beneficial. There is one human RCT from China which showed some benefit, but as of today, not enough data, and I showed you the 2 trials ongoing. Dr. Kochhar actually discussed, we discussed earlier. Sir, what's your opinion on that? Heparin, I would like to give or start some trial on that.
Yes, it needs to be looked at and studied. As yet, one would not.
Thank you.
So one of our
Management
students
of
had
acute
actually.
pancreatitis, we are being taught about aggressive fluid management. Now we are shifting to optimum fluid management. What should be the distribution of fluid management on day 1?
Oh, so the question is about fluid management on day 1?
Yeah.
So day 1 is same. I mean, I showed you that the usual requirements of fluid in a day for an adult would be around 1.5 to 2 liters. So you just add up a little bit more and that should be enough. It depends because patients usually nil by mouth, he might be vomiting, and there is some loss in the third space. So anywhere around 3 liters in the first 24 hours is a good enough, and that's what the trial has shown.
Oh, thank you.
Very nice talk, Pramod, but any role of trypsin inhibitors?
So they were tried. Anti-proteases were tried many years, for many years and many decades ago. No benefit. And the reason for that is this: what Tony has shown, you have initiation of injury now, and the proteases gets activated, possibly leads to cellular injury. But by the time the patient comes to you with pain, there is already inflammatory cells acting. The trypsin story is over by that time, and there are some doubts about trypsin, by the way. So that's the reason it doesn't help, because the patient comes to you, it's over.
Yeah, I guess maybe if we are able to predict early, and then there might be a role of giving trypsin inhibitor, but that is the problem area.
And the people tried that.
Yes, that's right. And you know, interestingly, you see, we have a problem with the availability of certain opioids. So what analgesic would you recommend?
In a randomized trial, we tried pentazocine, Fortwin, which is a commonly used opioid, and we found it better than diclofenac. Many times it may not be available, then you can do tramadol. Dr. Kochhar published a study on tramadol, which is a reasonably good alternative. Or you can even go for higher. What we also use as a rescue analgesia is fentanyl through a patient control analgesia pump. And I would strongly recommend that all units should have a PCA pump available to provide them adequate analgesia. And you know, you can always regulate the dose and other things. So that's very, very, very effective.
Thank you.
You told no antibiotics in pancreatitis, but sometimes you can come across increased counts, patient having collapse consolidation of the respiratory system, the respiratory failure. Do you start on those scenario or no?
But that's a typical situation in a patient with severe pancreatitis. The counts will be up, you will have respiratory dysfunction. But again, this is sterile inflammation. As far as we know as of today.
Patient is having a collapse concern, pneumonia, underlying pneumonia, bilateral.
I mean, then it's a non-question. If you have pneumonia, treat with antibiotics. I mean, nothing to do with pancreatitis.
Well, one question to Dr. Jacob, that you have shown that different types of etiology of pancreatitis can lead to different types of toxins. Now, why we only measure amylase and lipase, but what about other enzymes which we can measure to show that the pancreatitis is there?
So the reason why amylase and lipase became extremely popular is that the production of enzymes and the cohort of enzymes and the proportion in which they are produced is also dependent on the kind of diet a person follows. For example, in the Indian scenario, as well as in a large amount of the continents, not only in India, but in Asia, Africa, the diet is predominantly carbohydrate rich. And therefore, the predominant enzyme that is actually produced by the pancreatic acinar cell is usually carbohydrate digesting enzymes like amylase. Similarly, in a diet that is heavy on proteins, you would get a large amount of proteins, that is trypsin and so on. And therefore, even proteases as well as lipases are measured as a function of pancreatic acinar cell damage, because it's only when the acinar cell gets damaged that the enzymes are able to get into the interstitial compartment or into the plasma. And therefore, one is able to, beyond the start of the pancreatic cell damage, start measuring the enzymes or the activity of the enzymes in the plasma.
Okay. Dr. Kochhar, how can you predict that initially everybody will present as a mild pancreatitis? Then who are the other persons who will go to severity? So can you predict in the beginning that this person is going to get a severe pancreatitis?
Actually, ultimately we are looking at organ failure. The criteria for severity will be organ failure or necrosis. We detect necrosis only at day 5 at least of the onset. So CT is a late diagnostic test. Organ failure, a patient comes today, it will take you 48 hours. So that means around 3 days to detect severity. So prior to that, you have the scoring systems, the Apache 2 score, the BICEP score, or something like IL-6 levels, which probably are the easiest to do and the most effective in looking at it. You in any case are looking at the SIRS and SIRS score. So SIRS score, IL-6 levels, and a simple test which can be done is a C-reactive protein. So that can just warn you that be cautious that this is the patient where you should go further.
Thank you, Dr. Kochhar. We can understand the huge interest in pancreatitis. That will be the last question from the audience.
Any advantage of nasojejunal tube feeding in a subset of patients who have got recurrent vomiting despite IV antiemetics?
Yeah, that is strongly recommended. Yes.
I think we close this session because time is up.
So one
thank
question,
you,
please.
thank you, Dr. Pramod, Dr. Kochhar, Dr. Jacob, for nice lectures given. The topic of pancreatitis is interesting and it will always remain interesting. So thank you very much.
Thank you. Thank you so much. Thank you, chairpersons, and thank you, speakers. For the next session on celiac disease, may I please invite Dr. Ashish Chauhan, Dr. Atul Sachdev, Dr. Shravan Bora, and Dr. Alka Kumari to please chair this session. I would also like to announce that the alumni meeting will be from 7 p.m. to 7:30 p.m. For SMS, it will be in Hall U5. For Bombay, it will be in Boardroom, first floor. And for GB Pant, it will be in Hall D, 7 p.m. to 7:30 p.m. Thank you.
Okay. Well, I think for this session of celiac disease, we have a stalwart in Govind, and he's going to talk about the extra-intestinal manifestations of celiac. Can I just request you to start the talk, please? Thank you.
Thank you, sir. Thank you, chairpersons. Very good morning, everyone. We all know celiac disease was one time rare, but at present it's an important disease globally and also in our country. The clinical manifestation of celiac disease have changed. We believe that all celiacs should have a GI manifestations only, but they are at least half of patients. Of 100 patients, 50% patient will have a non-GI manifestations. Therefore, it's very important for each one of us to understand the wide clinical spectrum of this disease. Why this will happen, why multiple organs are involved, there are reasons for that. And we'll come back to pathophysiology in a minute time, but just to understand that this is an interaction with wheat protein and genetic susceptibility that leads to adaptive and innate immune response, lead to generation of gliadin-reactive T cells. And this T cell has now been recognized as a single cell which damages all the organs. And all the strategy to treat is to, or to make a diagnosis, is to identify as gliadin-reactive T cell. And this T cells infiltrate different effector organs, and that leads to enteropathy,
which all we know, but also it leads to multiple other organ involvement, including liver, skin, pancreas, and many other organs, and we know brain for sure. So coming first to the most important extra-intestinal manifestation of celiac disease is dermatitis herpetiformis. And all we know, this is a lesions which are there on the extensor surface of arm and the leg, and that leads to these sporadic lesions. And this was one of the first most important extra-intestinal manifestations. And number of patients with celiac disease will have a DH. Coming to one important feature which has come over the last about 5 to 7 years is the liver involvement in celiac disease. And this is quite interesting. The first evidence which came that liver is affected by celiac disease is a study from Finland, and this is just an observation. There were 4 patients with liver failure waiting for transplant, but while they were waiting for transplant, they were found to have an anti-TTG antibody positive. The biopsy shows villus atrophy, and they were given GFT. And of 4 patients, 3 recovered partly, and they were out of transplant list. Meaning thereby, in these 4 patients, there were improvement with gluten-free diet if they have celiac disease. And furthermore, then they looked at all patients they have transplanted. Of 185, they found that 8 had celiac disease associated. This is one of the first evidence to show that liver disease can be because of celiac disease. And furthermore, if you look at all celiacs, about 1/4 will have raised transaminases, 1/4 will have a raised ALT, and if you treat with gluten-free diet, almost everyone, the ALT will go down within a year of gluten-free diet. Therefore, the question comes, this involvement of raised ALT, what is that? Is it real, liver is really involved in these patients? Therefore, there are patients who have asymptomatic endocrine transaminases. If they remain unrecognized, we also know that the many celiacs where there be mild anemia or mild diarrhea, which patient may not recognize or patient may not complain, and they have underlying raised ALT. And if this ALT is unrecognized, it leads to persistent liver injury and can lead to cirrhosis later. And once they come as cirrhosis, as a liver failure, they will be mostly diagnosed as non-cryptogenic liver disease. Celiac can also have other liver disorders like autoimmune liver disease, fatty liver disease, and vascular disorders of liver. So let's look at all the data that celiac disease in patients with liver disease and liver disease in patients with celiac disease. Coming first to looking at celiac disease in those patients who come to us as a liver disease. And this is a study published or presented yesterday by Sakira in her plenary session. And we did a systematic review to look at all patients who have a cryptogenic cirrhosis, how many have a celiac disease. And the review shows that 5 in 100, 5 of 100 of cryptogenic cirrhosis, 5 have associated celiac disease. Similarly, if you look at all patients who have all-cause cirrhosis, then 1 per 100, like general populations, not increased. If you have a cryptogenic hypertransaminesemia, those patients have a raised transaminases, but no cause found. Even about 5 of 100 will have a celiac disease. Furthermore, we looked at our own data at our center, 232 patients with cryptogenic cirrhosis, and we found that 4.5% have biopsy-confirmed celiac disease. Biopsy means intestinal biopsy-confirmed celiac disease. And if you look at a very small number, but quite interesting and encouraging, that if they have a cirrhosis, cryptogenic cirrhosis, if you have celiac disease, or 5 of them, if you treat with gluten-free diet, their liver functions gets better compared to those who don't have celiac disease and we don't give them intravascular treatment. Then we looked at why only cryptogenic. We look at all cirrhotics. And that study done by a very bright boy, this is Ankit, and looked at 621 patients with cirrhosis, and of that, 19 had associated celiac disease. Interestingly, number of patients who have a confirmed alcoholism or AIH or Wilson's or HPV confirmed, they had associated celiac disease. Very high titer of TTC. And Dr. Agarwal raised a point that cirrhotic can have false positive TTC. We agree they can have false positive TTC, but it's very high TTC, and they have a Willis atrophy. Coming to autoimmune liver disease. Of all autoimmune liver disease, how many will have celiac disease? Again, this is a systematic review published last year. About 3.5% of all autoimmune liver disease will have celiac disease. Therefore, all autoimmune liver disease should be screened for celiac disease. Coming to other aspect. So those who have patients with celiac disease, how many have liver disease? Two important points. The first point, as I said earlier, that about 1/4 of patients with all celiac will have raised ALT. And if you treat them with gluten-free diet, majority will get better within 1 year. Furthermore, and we know this is a global epidemic of fatty liver disease. Even in celiac disease, we all believe celiacs have undernutrition. And this undernutrition leads to fatty liver. That might be playing a role. But look at all fatty liver disease. This is again systematic review done by one of my bright colleague, Nishant. And it data shows that at diagnosis of 100 celiacs, 15 will have fatty liver. Remarkable number. 15 have fatty liver. And if you treat a gluten-free diet for few years, 14 more are added. It means 29 per 100 people. It means every third celiac will have fatty liver disease. And if this fatty liver disease is not treated, there are additional risk for complications. Coming to other aspect, I think I'm going to convince you that in celiac disease, liver is an important effector organ, and liver damage as in part and parcel of celiac disease. And this is really important. Coming to reproductive life of patients with celiac disease. We know celiac will start in early part of life. From early part means year 1 to 2 to any age. So therefore, those women with celiac disease will have effect on their reproductive life. And what effect can have? They can have a starting from menarche to menstruation and to infertility. And to look at, to understand this, we want to understand how life of these patients are affected. So this work is being done by Subham, and this is a wonderful understanding on this case control study. And what we saw that all celiac patients, and we had a control, 288 celiacs and 586 control, 2:1 ratio. And we found that almost 2/3 of patients with celiac disease have some reproductive abnormality compared to half in controls, and ours is 2.3. So patients with celiac disease have some form of reproductive system abnormality. And this could be a delayed menarche, this could be menstrual abnormalities, but these are not major. But the more important is that delay in conception. They don't conceive early, and delay in conception defined by they should conceive within 1 year of marriage, if they want, unless they want protected from pregnancy. And this is 1/3 of patients have involuntary delay in pregnancy. The fertility rate is infertility is twice compared to controls. Also, they have a high rate of abortion compared to controls. They have a low birth weight of babies. The preterms are higher, and live births are lesser. Stillbirth is more common in patients with celiac disease, untreated celiac disease. Therefore, it's so important that once we see a patient with celiac disease, we must look at all of these, and this is an important aspect of treatment of these patients. Endocrinopathy. We all know type 1 diabetic celiac disease is unrelated, And of all type 1 diabetics, at least 6 have celiac disease. Therefore, all type 1 diabetics must screen for celiac disease. Short stature. Our data shows 10% of all short stature patients, of 1,000 short stature patients, 10% are from celiac disease. Systematic review of global literature. Of all short stature, 1 in 10 are seropositive celiac disease, and 1 in 11 have celiac disease. Therefore, all patients, all children who come with short stature must think of celiac disease, and if so, this will be treated for celiac disease. The question is how this happens. We know that celiac disease affects small intestine, but why other organs, and what could be the mechanism? So let's understand what is the pathophysiology. So we know this is a wheat protein, wheat flour, and the wheat flour is not digested by human gut because the gluten protein has a high number of glutamine and alanine, not alanine, and therefore the bond between this is not broken properly, and that leads to this peptide remain partly undigested. They pass through intercellular junction. As between 2 introsites, as they pass, they are deamidated by this peptide. That's called TTG. This deamidated peptide is a positive charged particle. It binds with is an antigen, binds with HLA molecule, internalized by APC, leads to T cell activation. And this T cell activation leads to more antibody formation, and this T cell damage mucosa. And one of the important thing is clear now that the gliadin-reactive T cells are the most important cell in celiac pathophysiology. So what will happen, these T cells which are there in the blood, they infiltrate intestine, but they can also infiltrate other organs. And other organs could be liver, skin, and other organs. That can lead to, that what happens, that leads to liver inflammation. And if we don't treat them, the persistent inflammation leads to chronic injury to liver and other organs and can lead to cirrhosis later. Question is, how do we see that? How do we look at this effect? And to look at this effect, the only way to confirm that you need to see the gliadin-reactive T cell in the liver. And until now, that technology has got advanced. Now we have technology to look at the gliadin-reactive T cells in the liver, and this is work is being done by with Prasenjit and Samudha, that we can now demonstrate anti-TTG antibody in the liver biopsies as one part of information. But more important would be to take liver biopsies, and from these liver biopsy find out these gliadin-reactive T cells. And if you show that, this will be direct evidence to show that liver is affected by gliadin-reactive T cells and leads to liver injury. With that, we must know that celiac disease GI manifestations are very important, but there are patients who will come with other manifestations. They can come with only anemia, and if you don't think them, you might miss celiac disease. They can come with liver disease. They can come with brain disease. They can come with reproductive errors or reproductive abnormalities, and they can also come with osteoporosis, osteomalacia, and ataxia. Thank you for your attention.
Thank you, Dr. Govind Makharia, for this interesting talk. The second talk in the series is about non-celiac enteropathies. I'm going to invite Dr. B.S. Ramakrishna for this talk.
Thank you, chairpersons, and thank you to the organizers and society for asking me to talk about this. So we heard about celiac disease. Let's look at the other kinds of diseases which can affect the small bowel. And here I've listed some. So starting with tropical sprue, parasitic diseases, eosinophilic enteritis, collagenous enteritis, hypogammaglobulinemia, IPSID, Whipple's, lymphangiectasia, and so on. So I'll deal with most of them here, just very briefly. So tropical sprue is a disease that used to be very common, particularly in our part of the country. In southern India, it had been described from all over India. But in recent years, there seems to be a declining trend. So typically, this affects young adults, 20 to 40 years. Typical presentation was a diarrhea and weight loss. The diarrhea is usually the small bowel type, frothy, large volume, foul smelling. Borborygmi and abdominal distension are very prominent. In fact, that was one of the names given to that was based on the abdominal distension that these people have. Glossitis, beefy red tongue are important. But in recent years, we see manifestations like hyperpigmentation here, which is very typical in the palms and on the dorsum of the hands. So in the olden days, essentially what we used to do was to do a barium meal follow through. You see the loss of the feathery pattern in the jejunum with edema of the folds. But in more recent years, people have progressed to things like CT. And here this is using CT with positive contrast. What this shows is that these bowel loops fill the abdomen, so that's called, and they're kind of pushing against each other, so that's called constraining. And you see when you use positive luminal contrast, you can see what is called progressive dilution, so that in the proximal bowel, the contrast is a little more intense, but as it goes into the distal bowel, it's much more diluted. So it's another feature of malabsorption. When we do endoscopy, there's loss of villi, which is quite well appreciated with white light endoscopy, but you can use narrowband imaging to localize areas of this thing. So when we look at the small bowel histology, and here on the left panel, basically you have tall villi. I apologize that this doesn't show the crypts, but crypts are usually about a third or a fourth of the height of the villi. And as we get, this is the kind of partial villus atrophy that you see in tropical sprue. There's an increase in the inflammatory cells within the lamina propria. And when you get to something like this, which resembles the colon, that's usually complete villus atrophy, which you do not see in tropical sprue. And this is complete villus atrophy. If you see this, we'd probably think of celiac disease first. So there is a publication from, and Dr. Govind Makaria is an author on this, with compares tropical sprue and celiac disease. So in celiac disease, we heard short stature is more common, scalloping is more common. We do see scalloping in tropical sprue. There's a high Marsh score, which means there's more likely to be a complete villus atrophy, the thickened basement membrane. In tropical sprue, anemia is more common and abnormal D-xylose, normal mucosal folds, which is not true. Well, I guess that's the analysis here. A decrescendo pattern of intraepithelial cell infiltration, lymphocyte infiltration. So the problem with tropical sprue is that it was a diagnosis made using absorption studies. So we had to demonstrate malabsorption of 2 or 3 different substances at least. And then we would say, yes, maybe there is some mucosal atrophy and so on. There is no positive finding for the diagnosis. So one of the reasons for why we might not be picking up tropical sprue now is we don't do tests of absorption anymore. The only test of absorption which is really possibly available to many is a D-xylose absorption. Fecal fats are all but given up. The vitamin B12 absorption is no longer available. I mean, the things that you need, the isotopes that you needed for it are no longer available. We do see a lot of people with vitamin B12 deficiency. This happens even in people who've taken a non-vegetarian diet. This happens without evidence of gastric atrophy. We don't know whether these people have tropical sprue because we don't have the means to diagnose this. The treatment for tropical sprue was largely folic acid and vitamin B12 in pharmacologic doses and long-term antibiotics, of which we had the most experience with tetracycline. Now, eosinophilic enteritis is something that we see a lot of. Here's a coronal reformatting section of a CT. You're basically showing that you have these jejunal loops which show there's a lot of edema of the wall, and there is the submucosal and lipomatous kind of change. And in this particular patient, there's also a little bit of free fluid. So this person had, and this is something that we are picking up a lot of patients now. Some of them are less obvious and some of them are full blown. So the Klein classification is used, basically depending on whether the infiltration is predominantly mucosal, muscular, or serosal. The HPE criteria, at least 20 eosinophils per hive per field, but it's usually much, much more. And we have eosinophilic cryptitis and cryptabscesses. We need to exclude other causes of tissue eosinophilia. Primary immunodeficiencies are not uncommon. So we do say selective IgA deficiency occasionally, but we see a lot of common variable immunodeficiency. And typically this happens with younger people who present with recurrent infections, recurrent gastrointestinal infections, partial villus atrophy. In IgA deficiency, they can be a completely flat mucosa like in celiac disease, and most often the diarrhea is due to parasitic infections or small intestinal bacterial overgrowth. They might come with recurrent respiratory infections. We've seen the occasional patient with recurrent meningitis and sinusitis. And the therapy is good because you have IV gamma globulin. Unfortunately, the recurring costs are so much that many of our patients are not able to afford it. And sometimes we do consider doing a marrow transplant, even though this is a kind of B-cell disorder. Sometimes a marrow transplant might cure it. Infections of the small bowel. I've listed some of these infections which can cause enteropathy, protozoa. We'll see a few of them, helminths, and the fungi. So Giardia, you can occasionally pick up on duodenal biopsy. In the last 2 weeks, we had 3 patients with Giardia who were picked up only with duodenal biopsy. It's just that stool examination seems to have gone out of vogue, or maybe the people are not able to recognize it so well, or maybe there's a delay in taking the samples to the lab. And it's strange that we should be picking this up in duodenal biopsy. It's easy to treat it, of course. Isospora belli, which used to be called, it's now called cystoisospora belli, the intestinal coccidiosis. The reason I bring this up is that this parasite resembles a malarial parasite. It multiplies within the epithelial cells. And if your pathologist is astute enough to make a diagnosis, which many non-GI pathologists do miss out on this diagnosis. So if they can pick up the forms of isospora in the duodenal epithelium or the jejunal epithelium, you have got your diagnosis. You can identify these in stool. If you do the cysts of this, if you can use a modified acid-fast stain, which many people in practice are not aware of, and they don't actually request this. The treatment is easy, cotrimoxazole. And if somebody is immunodeficient, you need a maintenance or pyrimethamine. Cryptosporidium, likewise, you can diagnose with acid-fast stain of stool. But malabsorption and chronic diarrhea is mostly in immunocompromised source, and we see a lot of post-transplant patients who might have this. The treatment is actually not very satisfactory, but we use nitazoxanide, and paromomycin might be used. Bovine colostrum has been used. Cyclospora, this is another patient that we saw recently, and again, it depends on whether the pathologist is able to recognize this. So if you look at the epithelial cell here, you can identify the forms of the cyclospora in the epithelium. Microsporidiosis originally was thought to be protozoan, but now they are reclassified as fungi. There are 2 major species. One is enterocytozoon and the other is enkephalitozoon. The reason for distinguishing them is one of them responds to nitazoxanide and the other responds to albendazole. Strongyloides is something that is much more easily recognized. You can see the ova in unstained stool. So there's a bile stained the larva here. And essentially, these people present with anemia, protein-losing enteropathy, but diarrhea is not so conspicuous. Again, duodenal biopsy very often picks this up. Capillaria is largely localized to the Philippines, but we have reported it from India. And there's this practice of feeding live fish for asthma, and this was from a patient who got this treatment for asthma in Visakhapatnam. And you can see this long worm here. Immunoproliferative small intestinal disease is of interest because we used to see a lot of it. It is originally more in people coming from a lower socioeconomic status who are exposed to repeated infections in childhood, and usually happens in adolescents or young adults with diarrhea, abdominal pain, and weight loss. Finger clubbing is characteristic of the disease. There may be an abdominal mass. The disease varies. It's basically a monoclonal proliferation of these plasma cells, and it can vary from a benign disease, which is called stage A, to a frank lymphoblastic lymphoma, which is stage C. The stage A, we have been able to revert people back to normal with tetracycline, but once it goes to stage C, it is chemotherapy, and usually we chop one of the things there. So the thing about immunoproliferative small intestinal disease, the characteristic lesion, I apologize for this little kind of poorly preserved specimen here, but basically the crypts are effaced. You can see the total loss of crypts here, and they're replaced by this monotonous infiltrate. And here again, you can see that the crypt effacement is not so prominent here, but once you do immunostaining for these lymphocytes, you can make that out very clearly. Intestinal lymphangiectasia happens sometimes, and that's something we see occasionally. We see a lot of it, but not to the extent that they come to us with symptomatic issues. So malabsorption, steatorrhea, they may have peripheral lymphedema, and I've seen patients with lymphedema of the eye, of the limbs, and so on. The stool fat is grossly increased. Endoscopy is diagnostic. You see these lipemic villi. And the treatment is to avoid long-chain triglycerides. ARB-induced enteropathy is something that we've seen a lot of recently, and olmesartan particularly, and here is Dr. Naresh Bhatt sitting in the front row here. He had a series of cases. We've recognized a number of these patients. They present very much like tropical sprue or celiac disease with villus atrophy and so on. And here you can see that there is fairly marked villus atrophy. Again, recognizing and removing this there are other drugs which cause enteropathy, including the anti-neoplastic agents listed here, and immunosuppressants like mycophenolate, lenalidomide, and bortezomib. MAI, occasionally you see these villi filled with foamy macrophages, and you can see the AFB in this after a Zeal-Nielsen staining. Usually happens in immunosuppressed patients, HIV. So just my last slide here, just to show you the spectrum of enteropathies in India. These are list studies which are done in the past 15 years or so from, here's Vellore, AIIMS, Lucknow, Mumbai, and Andhra Pradesh. And you can see that tropical sprue is still there in many places. If you take AIIMS, then you'll find celiac disease is the most common here. And then you have parasites are not so much, and then there are many others that are here. So with that, I'll end. Thank you so much.
Thanks for the nice talk, sir. I'd like to invite the next speaker. The next speaker is Dr. Ashish Agarwal. He's an assistant professor at AIIMS Jodhpur. He'll be speaking on non-celiac gluten sensitivity.
Good morning, everyone. First of all, I would like to thank the chairpersons and the organizers for the kind invitation for taking this talk. And I'll be speaking on non-celiac gluten sensitivity. It's a relatively new disease. Although initial case reports had been published in 1970s. However, the increasing interest has been there only in the last 1 decade, and majority of data and research on this disease is available from the last 1 decade. It's not moving. I declare no financial conflicts, and we'll start with a case scenario. So we have a 32 years old female patient. She's a business executive by occupation, and she has been suffering for the last 8 years with complaints of abdominal pain, bloating, alternating diarrhea and constipation. She also complains of generalized feeling of weakness and easy fatigability. She has gone through multiple diagnoses such as functional GI disease, IBS, stress, lactose intolerance, and has been empirically treated for a long period of time without any improvement in her symptoms. She finally went to a gastroenterologist who evaluated her and found that IgG, AGA was positive, though IgA, TTG, and EMA were negative, and a D2 biopsy was also done, which was essentially normal. However, the gastroenterologist considered a diagnosis of celiac disease and started the patient on GFD. For the first time, she had an improvement in her symptoms immediately after starting GFD. Within 2 weeks, she reported significant improvement of her symptoms. She went to another gastroenterologist for a review, and on review, TTH and EMA were again negative. The physician also did an HLA DQ2 and DQ8 testing, which was also negative. Biopsy was again reviewed. There were only March 1 changes without any evidence of villus atrophy in these patients. As there was no conclusive evidence of celiac disease, the diagnosis was refuted and the patient was advised to restart gluten. However, on restarting gluten, she again had recurrence of her symptoms. So here we have a patient who does not have evidence of celiac disease, but she's showing a response, immediate response to gluten withdrawal, and her symptoms are recurring with gluten challenge. She's not having celiac disease. The most likely diagnosis in this patient probably would be non-celiac gluten sensitivity. So wheat has been the most consumed food grain worldwide, and gluten is an important storage protein of wheat, forming up to 80% of the protein content of wheat. However, we have realized that gluten is highly immunogenic and can give rise to multiple disorders in a genetically predisposed individuals. All these disorders have been clubbed together to call them as gluten-related disorders, and based on their pathogenesis, they can be divided into autoimmune disorders, the most common being the celiac disease, allergic disorders, which could be IgE-mediated or non-IgE-mediated, and the newly described disorders, that is NCGS, which is neither autoimmune nor an allergic phenomenon. So what is basically NCGS? NCGS is basically a cluster of gastrointestinal and extraintestinal manifestations in a patient where both celiac disease and wheat allergy has been ruled out, and they show significant improvement in their symptoms once they are started on gluten-free diet, with a recurrence of symptoms when gluten re-challenge is tried in these patients. Regarding epidemiology, there is a paucity of information because it's a recently recognized disease and there is a lack of definite biomarker for a definite diagnosis of the disease. Majority of the data is available about the prevalence of self-reported NCGS. That is, patients who report having gluten sensitivity and have symptoms when they have a gluten exposure, and they are adhering to a gluten-free diet. So as you can see, there are multiple studies. Most of these studies are questionnaire based and they have a variable prevalence. The prevalence has been reported to be ranging from 0.5% to 12%. This highly heterogeneity in the data is mainly related to the heterogeneous population that has been studied, different questionnaires that have been used for their study, and the approach for data collection, whether the collection was done on an interview face-to-face interview or it was an internet-based survey. Clinical manifestations, as we have discussed, the patients can have both GI as well as extraintestinal manifestations. Among the GI symptoms, the patients can have abdominal distension, bloating, pain or discomfort. They might have diarrhea or constipation, nausea, vomiting, and reflux. So basically, they have functional GI symptoms, and there's a significant overlap between NCGS and IBS, and up to 1/3 of patients with NCGS actually satisfy the Rome 4 criteria for the diagnosis of IBS. There's a wide range of extraintestinal manifestations, along with the most common being feeling of lack of well-being, easy fatigability and tiredness. There could be neuropsychiatric manifestations in the form of headache, blurred mind or brain fog as they call it, anxiety and depression. Some studies have also shown association between NCGS and autism and schizophrenia. Other than that, patients can have musculoskeletal manifestations such as fibromyalgia and joint pain. So important here is that the symptoms in NCGS occur within hours to days of gluten exposure, as opposed to wheat allergy, where the symptoms occur within minutes to hours after gluten exposure, and in celiac, where a longer term exposure from weeks to months is required for development of symptoms. Similarly, the response to gluten withdrawal is also very rapid. And in a patient who's presenting with functional GI symptoms, the plethora of extraintestinal manifestations might be a clue towards the diagnosis of possibility of NCGS. Regarding the natural history, we are still not sure whether it's a temporary disease or it's a permanent disease. However, as long-term data is not available, there's only one study which reported on 200 patients with definite NCGS who were followed up for 8 years. At the end of 8 years, they found that 75% of the patients were compliant with GFD still, and of these only 2% had a recurrence of symptoms. However, of the 26% who had restarted gluten, 41% patients had recurrent symptoms. Further, 20 patients also underwent a second double-blind gluten challenge, and all of them had a recurrence of symptoms, suggesting that it might be a permanent condition, though more data is needed. Regarding the risk of development of autoimmune disorders and intestinal malignancies, there is no long-term data that is available. So pathogenesis is poorly understood, though it is evolving. Whatever data is available has suggested that it's innate immunity that plays a major role in the pathogenesis of NCGS, as opposed to celiac disease that Govind sir talked about, that there is both innate as well as adaptive immunity playing a role in development of celiac disease. Other than that, there is altered intestinal permeability and there is changes in gut microbiome. So basically what happens is, because of gluten and other components of wheat, there is an increased intestinal what has been postulated is that there is an increased intestinal permeability, leading to increased passage of antigenic stimulus across the epithelium into the intestinal mucosa, leading to local and systemic immune activation. Along with that, secretomotor and neuroimmune interactions are responsible for the activation of the gut-brain axis, leading to development of neurological manifestations. Now, regarding triggers of NCGS, the most earlier studies had implicated that it's probably gluten, which is the main culprit behind the development of NCGS, just like celiac disease. However, it has been increasingly realized that it might not be just gluten, but other components of wheat that might be playing a role in the pathogenesis of the disease. The other components being wheat germ agglutinin, FODMAPs, and amylase trypsin inhibitors, and thus even the name, people have suggested that rather than NCGS, it should be called as probably non-celiac wheat sensitivity. Alpha-gliadin is the main antigenic peptide of gluten, and the 33-mer peptide sequence has been implicated in the pathogenesis of celiac disease because of immunomodulating effects. However, there are other peptide sequences that in the alpha-gliadin which have cytotoxic and apoptotic activity, gut permeating activity, and they also cause CXR3 dependent IL-8 release, leading to activation of the innate immune response. And these peptide motifs have been proposed to be responsible for pathogenesis of NCGS. Regarding amylase trypsin inhibitors, these form 2 to 4% of wheat protein, and they act as natural pesticides. Both in vitro and in vivo studies have shown that they activate immune response by activation of the TLR4 complex in dendritic cells, and clinical studies are required to substantiate it. FODMAPs, recent studies have suggested that it might be FODMAPs rather than gluten responsible for the symptom generation in NCGS. However, we need to understand that NCGS is an immunological phenomena. While intolerance is not similar to sensitivity, it's related to enzyme deficiency. And in FODMAPs, basically are a group of short chain carbohydrates which are poorly absorbed, and because of their small size and increased hygroscopic activity, they absorb a large amount of water, leading to luminal distension. Along with that, they undergo fermentation in the colon, leading to production of large amount of gases. Both these things lead to luminal distension, leading to functional symptoms in a patient with visceral hypersensitivity. However, they cannot explain the extra GI manifestation, and the role is likely contributory. The diagnosis is difficult as there is a lack of specific diagnostic test, and a group of international experts met in Salerno in 2014 to propose a criteria for positive diagnosis of NCGS. What they suggested is that in a patient who is suspected of NCGS, first we should rule out celiac disease, and then a baseline assessment of symptoms should be done when the patient is on a gluten-containing diet. In step 1, the patient should be started on gluten-free diet with regular monitoring of symptoms at every weekly interval. Those who do not respond likely do not have NCGS, while those who respond should go to the second step where gluten re-challenge should be done, which should ideally be done in a double-blind and placebo-controlled method. Those who have a worsening of symptoms then should be diagnosed as NCGS, while those who do not worsen are not likely having NCGS. They further suggested that modified GSRS questionnaire should be used for symptom assessment, which consists of both GI as well as extraintestinal manifestations, with symptoms scored from 1 to 10 based on VAS scale, and a response is defined as more than 30% reduction in 3 main symptoms after 6 weeks of gluten-free diet. Sadly, there is no biomarker yet available for a definitive diagnosis of NCGS, though significant research is ongoing. Anti-gliadin antibodies, which are now obsolete for the diagnosis of celiac disease, have a rekindled interest because 50% of these patients might be positive for anti-gliadin antibodies, and an isolated positivity in patients, symptomatic patients, might be a clue towards the diagnosis. Histology is essentially normal. Presence of villus atrophy, we should question NCGS. There might be MARCH1 changes in a proportion of these patients, but the increase in the interstitial lymphocytes is generally mild, and the distribution is different. In celiac disease, the distribution is diffuse, while in NCGS, they are arranged in palisade pattern in the deeper mucosa, while in clusters in the villus. Gluten-free diet is the treatment of choice as the patients have symptoms related to gluten consumption. However, it is not clearly yet understood that do they need strict GFD or just they need gluten avoidance. Duration of GFD also has been questioned, whether they lead lifelong GFD or some of these patients can be started on gluten-containing diet after some time. And then do they need to avoid gluten or they need to avoid wheat per se. There is no evidence of published data regarding presence of NCGS in India. We recently completed a trial at AIIMS Delhi to assess the prevalence of NCGS in consecutive patients with IBS with biological evidence of sensitivity to gluten. So we included consecutive patients with IBS who were strongly positive for anti-gliadin antibody, and celiac disease was ruled out in these patients with a negative serology, absence of villus atrophy on D2 biopsy, and we also did an IgA TTG staining on D2 biopsy to rule out seronegative celiac disease. So we recruited 492 patients with IBS, and we screened them for both IgA TTG and anti-gliadin antibody. 429 patients were negative for both, while 2 turned out to be positive for TTG, and they were excluded. There were 61 patients who were positive only for anti-gliadin, strongly positive for only anti-gliadin antibody, and they were, of these, 31 patients were started on a 6 weeks of gluten-free diet after baseline symptom assessment. 31 of these, 4 patients did not show any response to GFD, while there was some response to gluten-free diet in 27 patients. Of these, 17 patients had more than 30% response as defined by Salerno criteria, and they were subjected to a gluten re-challenge with recurrence of symptoms in 100% of these patients. And a diagnosis of definite NCGS was made in these patients, while 10 patients had a partial response, and gluten-free diet has been continued for a later assessment in these patients. So our study suggests that 61 of 492 patients had biological evidence of gluten sensitivity, and of these, 31 patients who were started on gluten-free diet, 87% patients had symptomatic response to gluten-free diet, and more than 50% patients had definite NCGS. Thus, preliminary data suggests that there might be existence of NCGS in Indian patients with IBS. To summarize, NCGS is likely a distinct clinical entity, and it is still evolving disease. It's a work in progress. Epidemiology and pathogenesis is not clearly understood, and there is an urgent need for a biomarker for a definitive diagnosis of this disease. Thank you.
Thank you very much, Ashish. Can I request Professor Ramakrishnan to join us, please, on the, I think there are a couple of chairs available. Thank you. Well, we now open all the three talks for questions and comments. Yes, please.
Can I ask the first question? I would like to know what are the challenges that we should be encountering and should be prepared for to get a compliance, because we have patients who want to go off gluten-free diet, but the family may not be so cooperative, and this probably is a way. I mean, long-term failure or non-compliance is a big problem. So, any of the speakers who spoke on gluten could take up this.
I think this is a very important aspect. Adherence to drug, if it be diabetes or be hypertension, is so important. Even with that, the compliance rate is only 80%, even with diabetes and hypertension. Once you come to nutrition therapy as a sole therapy, the compliance is extremely poor. Globally, about 50% of all celiacs, they don't comply completely to gluten-free food. That's how everybody knows that's a challenge. And the only solution is, at this point of time, is counseling.
Okay, thank you.
And counseling very well. Involve a dietitian in counseling, because none of us will have enough information about diet of celiac disease. It's not about asking them to avoid gluten, but also to give them balanced diet. Therefore, involvement of a dietitian is the integral part of our prescription and treatment. And repeated counseling is the treatment for to maintaining adherence.
Excellent talks. Gluten has now become the flavor of the month, and I think dietitians, lifestyle experts, everybody is recommending gluten-free diet for everything from obesity to diabetes to NCGS and everything else. So the question is, how about these food allergy tests that are now highly prevalent and are more easily available? So if you have a negative TTG, a negative food allergy test, do we still think that gluten should be playing a part, and should we be actually joining the bandwagon of recommending gluten-free diet trials for many different diseases?
Ask you to take this question.
There's a recent trend that gluten-free diet is being recommended for a lot of conditions. However, it is not, all of it is not backed actually by evidence. The only evidence that we have started now accumulating is about celiac disease. Celiac disease is a definite indication. Beyond this, this is majorly become a mostly become a fad, and there is lack of evidence regarding its role in other disorders at this point of time.
So you can add one more point on that. That there's an industry that they want to promote gluten-free food, and their business. Right. So certainly they have to push gluten-free food for any indication, from headache to migraine to whatever you say. But the question is that is up to the patient what he wants to do. In Australia, every third individual is gluten-free. In the US, every 10th person is gluten-free.
About the food allergy tests that we are doing, I don't know what antigens they are testing, that test like 50 different antigens, the food allergy test.
I think the Society of Allergy, and they don't recommend food allergy test. And if they do, then you have to measure IgE levels to particular food antigen rather than to whole bunch of 100 food items.
Govind, like your talk, can we talk about celiac ataxia, which you didn't have a chance to cover? Do you believe that the neurological complications that you mentioned, ataxia, peripheral neuropathy, are only seen in patients with overt malabsorption, gross villus atrophy, or do you think there is some other mechanism? Because it's a disease of the history books, in my experience.
Absolutely. Ataxia is an important manifestation of celiac disease, and most of the studies has come from Sheffield, the Marios, and what he demonstrated that in his ataxia clinic, that about 40% of patients are AGA positive, those who are idiopathic ataxia, and he has shown videos of patients who had crippled, but on gluten-free diet, they have improved, not to complete, to partially. And the reason being that celiac in intestine will recover completely, but organs which have a gliosis or fibrosis like liver or brain will not recover completely, unlike intestine. Therefore, mechanism also, we have a hypothesis, I know a lot of people will still challenge this hypothesis, that like IBD, PSC, those who have PSC, IBD is mild in them. And they come to as a liver disease rather than as IBD disease. Similarly, in celiac disease, their patients, something drives, maybe genetic drives, that you go liver pathway, you go skin pathway, you go intestinal pathway, or you go brain pathway. There's a predominant organ involvement in certain patients. And there are two examples that 1/3 of patients with DH, dermatitis, have a normal intestine. Similarly, Marius has shows that those who have a brain ataxia or gluten ataxia, they have a normal intestine. It may be that the gluten drives other cell damage irrespective of small intestine.
Rama, like your comment on this, we have a kind of a pandemic of B12 deficiency. So how much does B12 deficiency contribute to changes in the gut? We know that functionally it does. Does it actually change the biopsy? So in which case, do we treat the B12 first, wait for a period of time before we biopsy to make out the etiology of the disease?
So B12 does cause histological changes, and you might see megalocytosis. Just like you see megaloblastic anemia, you might see changes in the epithelial cells. But beyond that, I'm not aware that of any evidence which says that you might have inflammation or shortening of villi or elongation of crypts. So I'm not too sure. But the issue is that I'm sure you do too. We see a lot of patients with vitamin B12 deficiency who, when you inquire about their diet, it looks like they do have adequate sources of vitamin B12 in the diet. Veganism is not very common in India. In fact, most vegetarians have milk and milk products which contain B12. And we don't find atrophic gastritis. You don't find any other explanation for it. So I just wonder if we might be missing patients with some different kind of B12 malabsorption, because we don't have the absorption tests available to us.
Nice talk, Govind. You covered it extensively. I think one possibly thing that you missed out was Down syndrome. So if you have a patient, the prevalence of celiac disease in Down syndrome almost to the tune of 10%. So it is mandatory to screen all Downs for celiac disease. And one comment for Dr. Rama, with the advent of the nucleic acid techniques, MALDI-TOF, etc., the BioFire test that we are, it's now not so labor intensive to look for cystoisospora and all these, because within 2 hours or 3 hours you can have any of these exotic parasites. The report will be there on your table. Yes, the cost is the major factor, but I think in time to come, and the more and more popular that they become, the cost is definitely going to go down.
Appreciate that comment, Amrinder, but a stool smear with a modified acid-fast stain is much cheaper, and you can still get it done in an hour.
Absolutely, there's no this thing, but the gamut that is covered by these MALDI-TOF techniques is so that you really come out. And most of the people doing the stool examinations are the rookies, so they may not be very well versed.
This is a comment about non-celiac gluten sensitivity, Dr. Ashish. Now you have verified that this disease does exist in our own country. That's nice. We have a huge chunk of patients who have got IBS-like symptoms. So the time has come that rather than refuting that this disease doesn't exist in India, I think we should evaluate these patients. If they meet clinical criteria, We should do anti-gliadin, IgG, as you have mentioned. And those who are positive, they should be left out of wheat for 6 weeks. That's not a big deal. Stopping wheat for 6 days, it's okay. It's not going to harm your body in any way. And after 6 weeks, those who are symptom-free, patient needs to be symptom-free at the end of the day. Otherwise, these patients, they keep moving from clinician to clinician with a umbrella diagnosis of IPS.
I agree to that, sir. They should be. We should now start looking for NCGs because it's probably present in our country. Regarding the diagnosis, sir, we still need a biomarker for a specific diagnosis because it is still difficult. Stopping the gluten is easy, but these patients might have NCGs, or do they have a pseudo response to just stopping GFD is not. We are not really sure because there might be a strong placebo effect on also, and thus a gluten re-challenge. Currently, gluten re-challenge, and that too ideally in a blinded manner, is required for a definite diagnosis of NCGs, and that is a bit difficult at this point of time. This point of time, sir.
A subset of these patients are very dedicated and they would like to do anything that you are going to suggest. We all know that.
Yeah, thank you all the speakers for the wonderful talk. Thank you, sir. Thank you, ma'am. Thank you. For the next session on optimizing imaging of GI tract, may I please invite Dr. K.T. Shenoy, Dr. M.R. Kotwal, Dr. Sangeet Datta to please chair this session.
Session on optimizing imaging of the GI tract, and me and the other chairpersons would like to thank the ISG for giving us this opportunity to be here, and we'll start the session straight away because we are behind time. So can we invite the first speaker, Mr. Ankur Goel, to please come, and he'll be talking on CT scan versus CT enterography for small intestinal imaging.
Good morning, everyone. So in the next 15 minutes, let's talk about why enterography has become the radiological investigation of choice for imaging evaluation of small bowel diseases. So let's begin with a quick question. There are 4 options, which all of them are for evaluation of the small bowel. All of these imaging acquisitions involve exposure to ionizing radiation except. Any takers for this? A, B, C, D? D. Excellent. So this is just to show the evolution of small bowel imaging. This is the first investigation, the barium-meal follow-through study, which was traditionally employed a lot for evaluation of the small gut. Then came the era of enteroclysis, in which a tube was placed, and this led to better evaluation of the mucosal details. Since we wanted extraluminal and mural information as well, thus CT came into play, and thus the barium studies were made redundant. And now is the era of MR enterography, in which there are multiple paradigms, multiple sequences to increase the diagnostic confidence to diagnose these conditions. So just as gastroenterology has evolved and now spiral enteroscopy is like the investigation of choice to see the entire extent of the small gut, similarly enterography, be it CT or MR, is currently the radiological investigation of choice. The role of imaging is not only to diagnose these conditions, but also to map out the entire extent, assess whether it is an active inflammatory involvement or it is fibrotic involvement, and also imaging comes into play prior to starting the treatment and also post-treatment response assessment. So in the barium-meal follow-through, the aim was to deliver a single continuous column of barium. So there was opacification of the lumen of the small bowel, and there was distension. So any segment which remained undistended was suspicious for a pathological segment, and the filling defects could be seen on the barium-meal follow-through study. Then came barium enteroclysis. So the good thing was that an NG tube was placed which circumvented the pylorus. So rather than relying on the pylorus supplying contrast to the gut, a direct tube was inserted beyond the DJ flexure, and thus in a controlled way contrast could be injected, and this led to more reliable opacification and distension of the small bowel loops. The problems were unpleasant for the patient. There can be technical difficulties. Good things were that luminal distension was better, the accuracy to assess the small bowel was more, and in contrast to barium meal follow through, where we had to follow up the entire column of barium for about 4 or 5 hours, once the NJ tube is inserted, the examination can be completed in the next 20 or 30 minutes. But since we want extra luminal information as well, anyways we are giving radiation, so why not get the extra luminal information? That is why barium studies have more or less become redundant, and there are only certain niche indications which include assessment of the motility of the bowel segment, as well as to demonstrate any contrast leak or fistulas. CCT, that is CT done with IV contrast without any oral contrast, is very easy to do. So the patient comes in, a cannula is put, IV contrast injected, and CT is acquired. Problem is, when we have to evaluate the small bowel, then it is very difficult to diagnose whether the mural abnormality is there or not. The collapsed bowel appears brighter compared to the distended bowel. We cannot diagnose the probable strictures, and it may appear fallacious, like it is abnormal. More examples. So this is an example where there was presence of ascites. So very difficult to assess whether these bowel loops harbor any abnormality or not, because they are just collapsed. So we cannot evaluate whether there is abnormal bowel wall thickening or not. So then we started doing contrast enhanced CT with positive oral contrast. So positive oral contrast meaning that it was either a diluted barium or a water soluble iodinated contrast. About 1 liter of fluid was taken by the patient over 1 hour, and again the aim was luminal opacification and distension. Opacification is helpful because it can be differentiated from the lymph nodes, which will not show contrast, and distension, as I said, to evaluate the wall. Now we can see in this example, we can see that this segment is distended with oral contrast, shows definite abnormal bowel wall thickening in the region of the terminal ileum with increased mesenteric vascularity. What are the problems? The problems with positive oral contrast include that it masks the enhancement of the wall. So normally in active inflammatory stage, we expect the inner layer to be hyper-enhancing and then submucosal edema. So since the lumen is already very dense, it is impossible to appreciate that stratified pattern of enhancement in such a scenario. Secondly, in cases of mesenteric ischemia where we need angiographic reconstructions, so since there is positive oral contrast, it interferes with those 3D reconstructions. And thirdly, since there is no definite protocol of how to drink this fluid, the bowel distension in all the segments may not be optimal. So the current indications of using positive oral contrast include to delineate the fistulas or the anastomotic leaks, and sometimes to identify in cases of multiple stricture to really identify that what is the functional site of obstruction, till where the positive column of contrast has gone, so that will suggest the functional site of obstruction. Let's see some examples. So in the era of the films, when we were used to looking at films, then this oral contrast was quite helpful to distinguish from the necrotic lymph nodes. But now that we do workstation reading, this is usually not required. More examples of extensive necrotic mesenteric lymph nodes, and there is displacement of these contrast opacified bowel loops to the periphery. So this is an example where we see there is presence of small bowel dilatation. There is presence of a stricture with upstream dilatation, but we know that this stricture is not absolute because the positive oral contrast which has been given has gone distal to the site of stricture as well. So this is a useful indication of positive oral contrast. However, the problem is we can hardly make out and comment whether the wall enhancement is normal or not. That is a real problem in such scenarios, and this indeed was a case of mesenteric ischemia in which there was venous thrombosis. We can see the paucity of vasculature here. We can see the engoid vasa recta in the other segment. So assessment of the mural enhancement, be it inflammatory enhancement or be it reduced enhancement in mesenteric ischemia, that is important, and that is masked when we give positive oral contrast. In such cases where there is interbowel loop collections, it is desirable to give positive oral contrast to see whether the contrast has gone out. And in cases of post-operative leaks, we can trace that, okay, this is the segment and there is extravasation of the oral contrast into the collection. Let's come on to CT enterography. So when we say enterography, the aims are optimal luminal distension and it should enable good bowel wall evaluation. So how do we achieve that? The patient has to take continuously large volume of high osmolality contrast media, and usually we use neutral contrast, which looks like fluid, like in these images. So as we can see, the bowel wall shows normal enhancement in these images. So it's easy to appreciate the bowel wall, both the thickness as well as the enhancement pattern, whenever we give neutral oral contrast. So optimal distension is required to confidently diagnose the strictures. Neutral oral contrast enables us to assess the wall enhancement, wall thickening, and this is even more useful in cases to diagnose GI bleed. It has relative good tolerability because no NG tube is inserted, although because of this large volume of fluid, there can be vomiting, diarrhea, and abdominal colics. So various agents have been used in literature, and the practice varies from institution to institution. Usually it's a high osmolality solution, so water mixed with methyl cellulose or PEG or mannitol or very low density barium sorbitol. These are the various options which are available. Plain water is not used because it is absorbed by the distal small bowel, so it doesn't lead to good distension in the distal small bowel. And we know that it is the distal small bowel where the money lies. We cannot afford to have suboptimal distension of the distal small bowel. So these are the examples of images which are achieved in CT enterography. So we can very well appreciate. So this is a distended segment but shows abnormal bowel wall thickening and segmental mural hyperenhancement compared to this normal looking bowel segment. So usually a single phase of acquisition is sufficient. However, in cases of GI bleed, a multiphasic examination is required. So this is an example of a typical protocol. So over 15 minutes, 500 ml, next 15 minutes, again 500 ml, then 250 ml, 250 ml, and so on. So it is important that the patient continuously sips rather than occasional gulps. And some studies say that metoclopramide and hyoscine can be given, but usually this is not really needed. And CT acquisition is very fast, so usually anti-peristaltic agents are not required. What is the ideal volume of oral contrast? So people have used up to 2 liters, and it is the usual consensus is that around 1300 to 1500 ml is the amount which is ideal. In cases which have who have undergone surgery or in pediatric patients, this volume will be lower. CT enteroclysis. So enteroclysis would mean putting in a nasojejunal tube under fluoroscopy guidance and then delivering the same contrast through the tube. So theoretically, it offers mildly better distension of the small bowel since the pylorus is circumvented. But it is not routinely used because it hardly adds any additional benefit to the CT interpretation of images and the imaging diagnosis. And since it is invasive and uncomfortable, so it is reserved only for those sick patients where we want an enterography-like study, but they cannot drink large amounts of fluid. So in them, NJ tube may be inserted and then neutral contrast can be given. So let's see a few examples of how the CT enterography images look like and how do they show us the different disease entities. So here we can see there is a stratified pattern of enhancement in this area of bowel wall thickening. The inner wall is showing hyperenhancement, then there is submucosal edema, there is proximal dilatation, so this is an active inflammatory stricture. On the other hand, in this case, we see there is a focal stricture which shows relatively homogeneous enhancement. Similarly, multiple focal strictures in this sagittal image. To show again that whenever positive oral contrast is given, the dilatation and strictures are picked up, but the mural enhancement is something where we can go wrong. So in neutral oral contrast, the mural enhancement and mural wall thickening are better picked up. More examples. So here we can see very subtle findings. So very mild abnormal wall thickening in a segment of ileum. Here we can see more marked wall thickening with segmental hyperenhancement, and here there is exuberant involvement of the terminal ileum and associated with cecum and ascending colon involvement. An example of NSAID associated strictures, so multiple membrane-like strictures involving the distal ileum with mild proximal dilatation. This is an example of long segment involvement in Crohn's disease showing hyperenhancement. And this is an example of lupus enteritis where almost all of the small bowel shows mucosal fold prominence, wall thickening and hyperenhancement. A word regarding CT versus MR enterography. So CT is usually the first investigation, and especially when there is acute presentation, it is the preferred investigation. And for follow-up of such patients, MR enterography is the preferred investigation. And in younger patients or in the pediatric age group, one may prefer doing MRE as the first line investigation. Okay, so let's end with a question. In these two images, multiple findings are seen. If anyone can take up this out of ABCD. So is there abnormal bowel wall thickening, enhancement, stricture, or all of these? So here in fact everything is seen. So we see there is definite abnormal thickening, there is stratified type of enhancement, there is engorged vasa recta, there is asymmetric involvement with preferential involvement of the mesenteric border and pseudosaculations along the anti-mesenteric border. So this was active inflammatory stricture in a Crohn's disease which was causing obstruction. And we know that stricture is diagnosed on imaging whenever there is luminal narrowing associated with upstream dilatation. If there is no dilatation, then we call it probable stricture. And we try to characterize whether it is predominantly inflammatory or predominantly fibrotic. So to conclude, CT and MR enterography are the radiological investigations of choice for small bowel evaluation, because optimal bowel distension is essential for the correct interpretation. In acute high-grade obstruction, there is no need to give any oral contrast because the patient is already in high-grade obstruction. So there will be native contrast between the obstructed and the dilated loop. And neutral oral contrast is better because it allows the mural evaluation, and positive oral contrast is reserved to define the leaks and the interbowel loop collections. I'll take this opportunity to thank my mentor, Dr. Raju Sharma, Dr. Govind Makharia, and Dr. Sandeep Nijavan for giving me this opportunity. Thank you.
Thank you, Dr. Ankur. May I request Dr. Usha Goenka from Kolkata to come and give her presentation on indications and interpretations of MR difficography. Dr. Usha.
Thank you, chairpersons, and warm greetings from the city of Kolkata. Defecatory disorder is a very common health problem, so much so that it accounts for nearly 10 to 20% of patients who attend the GI OPDs. Sadly, it impairs the quality of life and it incurs a substantial economic drain worldwide. The diagnostic tools which have been conventionally used to evaluate a patient with defecatory disorder are anorectal manometry in all its forms, conventional, high resolution, and 3D. It's the most established technique to provide direct functional assessment of the anal sphincter and recto-anal coordination. It's widely available, easy to perform, and the patients accept it well also. But it only provides functional information and does not give the structural details of the pathology. Fluoroscopic difficography is invasive, uses ionizing radiation. Ultrasound endoanal and MRI pelvic or endoanal provides only the structural details. None of these investigations, therefore, provide a holistic overview of the entire pelvis with both structural plus functional information. And this is where MR difficography very snugly fits into the algorithm of patient with a defecatory disorder. So I will be talking in the next couple of minutes about MR difficography with emphasis on indications and interpretation. What is MR difficography? This slide has been put for the non-initialized. It's a test done for evaluation of a patient with defecatory disorder. As the name suggests, it uses MRI to obtain images, both static and dynamic, at various stages of defecation and is used to evaluate how well the pelvic muscles are working, where are the pelvic organs located compared to where they should be normally located, and also to provide insight into the anorectal function. So MR defecogram helps to find out the cause of fecal incontinence. It helps to evaluate patients with constipation, particularly obstructive defecation syndrome, and it also helps to evaluate patients with pelvic organ prolapse and variable degrees of cystoceles and rectoceles. So why is there so much ado about MR defecography? Well, it is non-invasive, multiplanar, it provides good temporal resolution, it has high soft tissue contrast. So all these give explicit structural details of the pathology. In addition, there's no ionizing radiation and it provides real-time functional imaging. So, in short, it provides both high-resolution morphological data and functional data through the dynamic cine sequences. And in addition, the most important aspect is it detects pathology in multiple compartments simultaneously. It is very important because pelvic pathologies involve more than one compartment more frequently than not. Thus, MR defecography helps triaging patients requiring conservative treatment, that is, training and biofeedbacks, versus the surgical treatment. And for all this and more, MR defecogram is rightly the modality of choice for evaluation of defecatory dysfunction. In short, I would like to tell you about the technique. A bowel cleansing enema may be given in some centers about 12 to 24 hours before the examination. On the day, 4 cups of water are given over 30 minutes prior to the exam in order to partially fill the urinary bladder. Diaper, molly sheet, and gown are provided. The radiologist and technician explains the procedure and tells the maneuvers which the patient has to do on the MR table. This is the most important step in order to get the correct images. The patient is then placed in the right decubitus position and 200 to 300 ml of ultrasound jelly is injected into the rectum and sometimes into the vagina to bring out the fornices better. These are the sequences which are taken. Both static images are taken and cine loops like this are taken. And it's important to take the sequences in all 4 phases, that is rest, squeeze, strain, and evacuation. And then comes the most important step, interpreting a MR defecogram. There are certain prerequisites and steps which go into it. First is you need to identify the important landmarks, draw reference lines and angles in all the phases of the study, do the measurements, and then you interpret the results. So a sound knowledge of the dynamic pelvic anatomy is very essential. The pelvis is divided into 3 compartments, as we all know. The anterior compartment is the bladder and the urethra, the middle compartment is the uterus and the vagina, and the posterior compartment is the rectum and the anal canal. And I would like to re-emphasize that the disease can involve more than one compartment very often. So the reference lines and angles which are important. The most important line is the pubococcygeal line. It is drawn from this is the pubic symphysis, from the inferior point of the pubic symphysis to the last coccygeal joint. This is an important line because in all phases of defecation, the organs of the pelvis, the bladder, the vagina, the uterus, and the rectum, they all should be above this pubococcygeal line. Another important line is the M line, which indicates the descent of the pelvis or the pelvic organs. Normally, it should be less than 2 to 2.5 centimeters, and it's a line drawn from the posterior anorectal junction and is a perpendicular on the pubococcygeal line. So, if there is descent of the pelvis, it goes in this direction. The third important line is the H line or the hiatal width, and this is drawn from the pubic symphysis to the anorectal junction. And normally this is less than 6 centimeters. If it grows in this direction, and any lengthening of this H line indicates the abnormality of the puborectalis muscle and the weakness of that muscle. Based on this, we can even grade, or based on MR deficogram, we can even grade if the M line is 0 to 2, as I said, it's normal, and in its increasing order, it could be mild, moderate, or severe pelvic floor descent. Similarly, the H line should be normally less than 6, and as it grows, the severity of the hiatal enlargement or the muscle weakness is more and more. There is an important angle, that's the anorectal angle, which also needs to be seen. And this angle is between the posterior rectal wall and the posterior anal canal. So this angle should normally be 108 to 127 degree. During squeezing, it should decrease about 15 to 20 degree. And during straining, that is when the patient needs to evacuate, this needs to increase. So any abnormality in this indicates an abnormal anorectal angle, abnormality in the anorectal angle, and could indicate a spastic perineal syndrome. There are two more lines. One is the anterior rectal line and the posterior rectal line. And this indicates the anterior rectal wall and the posterior rectal wall. And any elongation of the rectum beyond this indicates a rectocele. So again, based on these angles and lines, we can grade the severity of the pelvic organ prolapse. Now I'll be sharing a few cases. This patient presented with constipation and incomplete evacuation. At rest, everything seems normal, but on defecation phase, you can see the rectum is way beyond where it should be. The anorectal junction is approximately 6.3 centimeters, and this indicates a rectal descent. Similarly, the hiatus width is 8.8, it should have been less than 8. So this indicates a descending perineal syndrome, and it occurs due to loss of pelvic muscle tone. This can involve only one compartment, as in the index case. It could involve two compartments, the bladder plus rectum, and it could be tricompartmental also, as in this particular figure. Another case presenting with incomplete emptying of the bladder and the bowel. So again, at rest, things look okay, but in the defecatory phase, you can see the bladder has descended way down where it should have been above the puborectal line, but it's pubococcygeal line, but it's way down. Similarly, the rectum has also descended down, and this is the anterior rectal line. There's a large projection beyond, so this is a moderate degree of anterior rectocele. So this patient has a descending perineal syndrome with bicompartmental prolapse and anterior rectocele. The third patient presented with constipation, painful defecation, flatulence, and bloating. And in addition to the descending perineal syndrome and a tri-compartment involvement, that means the bladder, the vagina, this was a post-hysterectomy patient. So in addition to the bladder, the vagina, and the rectum, everything has descended down. There is a large anterior rectocele, and a very important finding of the mucosa of the rectum, which has invaginated into the anal canal. So this is a mucosal type of recto-anal intussusception. MR difficography also helps in differentiating mucosal versus full thickness rectal intussusception. And it's important to differentiate because the treatment of the two is different. The last patient who had complained of constipation with failure to evacuate. Now, in this, we've measured the anorectal angle. At rest, it's 99 degree. During strain, it has reduced in size, but it's much more reduction than what is normal. So this indicates that there is a spasm of the puborectalis, and during straining, the angle should have actually increased, but it remains small. So the diagnosis is a spastic pelvic floor syndrome, and this occurs due to a hyperactive puborectalis, which shows a paradoxical contraction rather than relaxation, and it could also occur due to pelvic floor dyssynergia or anismus. There are some other pathologies which can be picked up on MR difficogram. In this first picture, we can see that the peritoneal compartment should have been also above the puborectal line, but it has descended way down and the small bowel loops are reaching almost till the floor of the pelvis. This is an enterocele. In the second picture, the uterus has descended down and it's actually projecting beyond, and this is a severe uterine prolapse. This third case, in this case, in the rest phase and in the strain phase, the anal canal is open and the defecation, the expulsion of the jelly actually took place in the strain phase. And when we did the axial section, this is showing the puborectalis muscle is atrophied and is showing fat infiltration. So this is a case of anal incontinence. Just a slide on comparing fluoroscopy with difficogram with MR. In this patient, this was a 44-year-old woman who was presenting with features of obstructive defecation syndrome. Fluoroscopy showed rectal prolapse, intussusception, there was an anterior rectocele, and there was enterocele. The small bowel loops also look below. But in MR difficogram, we can see that there was rectal prolapse, there was a small anterior rectocele, there were pelvic organ descent, but there was no enterocele and no intussusception was present. This shows that MR difficogram is more accurate compared to fluoroscopic difficogram. This is a slide on the studies going on in our department. We've done more than 450 patients on MR difficogram, but this is a data of only 117 patients included in the study. The age distribution shows that most of our patients were within 40 and 70 years. More males were present. The patients mostly presented with chronic constipation. There could be a referral bias also because most of our patients are referred from gastroenterology department, and a number of patients showed normal results. The most common diagnosis was spastic perineal syndrome and pelvic floor dyssynergia. There were many patients with rectoceles and cystoceles also. To summarize, defecatory disorders are increasingly frequent debilitating conditions, adversely affecting quality of life and are financially draining, frequently involves multiple pelvic compartments and requires accurate pre- and post-operative assessment. If we depend on symptoms and clinical examination alone, it will underestimate the diagnosis, and it also results in misdiagnosis of the prolapse site in 45 to 90% of the cases. So, symptoms and diseases, so if the surgery is done based on this alone, then the symptoms of the disease would frequently relapse and the surgeons would cut a sorry figure. So most of the available tools in our armamentarium provides either a structural information or a functional assessment. But MR difficography helps in assessing both structural and functional details, and therefore is the modality of choice for evaluation of defecatory disorders. Thank you.
Thank you, Dr. Usha Goenka. So we will have the third presentation. And the third presentation will be last will be done by Dr. Rakesh Kumar on PET and its variants in the imaging of GI and liver disorders. Dr. Rakesh.
Good morning, everyone. Thank you, organizers, for inviting me for this talk. So the last word from Dr. Goenka was functional. So we are going to talk about the functional things in the PET-CT. The most common PET-CT what we are using is FDG PET-CT. So FDG is fluorodeoxyglucose, which is marker of the glucose. So any pathology which is showing increased metabolism or upgrading of glucose uptake will show abnormality on FDG PET-CT. I go one by one. Since most of the glucose abnormality is seen in the tumors, so most of my slides will be showing some tumor pathology. So this is a case of carcinoma G junction. You can see there is abnormal uptake, and in addition you can see there were liver lesions. So there is a hypodense lesions here which is not showing any uptake, whereas there is another lesions here which is not very well seen on the CT, though it's a non-contrast CT, but it's showing uptake. The another criteria for the diagnosis of the lymph node metastasis is the size criteria. Anything less than 1 centimeter is considered as a benign, and more than 1 centimeter is considered as a abnormal or metastatic. But that may not be true in real sense. Here you can see in this patient, there are subcentimetric nodes which are showing uptake, and these are metastatic nodes. This is patients with carcinoma stomach. PET-CT was done for pre-operative staging. No problem with primary, very intense uptake. But if you see there is a very small lesion in the liver, so it makes unoperative because of liver metastasis, very small lesion in the liver, so making it a metastatic disease. This is patients with carcinoma bladder, carcinoma common bile duct. You can see dilated CBD, and you can see there is a mass. Intrahepatic radicals are dilated, and you can see intense uptake in the lower end of the CBD. So it was a case of carcinoma CBD. Periampullary mass usually presented with obstructive jaundice, and you can see the stunt is NC2, and you can see abnormal uptake. The advantage is the PET-CT is being functional imaging and being metabolic imaging, there is a good contrast. So that's one advantage. This is how big tumor you can see on the PET-CT. Usually it's the resolution of the machine, which is usually around 4 millimeter. Benign versus malignant is one of the big issue when you are doing it. Here are 2 patients. You can see there is a lesion on the CT, but it's not showing any uptake. Whereas another similar lesion on the tail of the pancreas, and you can see intense uptake. In addition, you can see mesenteric metastatic lesions also on the PET-CT in the malignant lesions. This is one of the work, it was my PhD thesis under Dr. Pramod Garg. So we did this work in chronic pancreatitis, which are presenting a pancreatic mass, and many a time you are not sure whether it's an inflammatory mass or if it is a CA pancreas. In those cases, we found that PET-CT may be helpful, and here are a few examples. So this is one patient, you can see mass with chronic calcification in pancreatitis, and it is showing intense uptake. In addition, you can see liver metastasis also. So it was not benign, it was a malignant mass. Very interesting case, 70-year male presenting with pain abdomen, occult blood was positive, colonoscopy was done, and it was a polypoidal growth in the descending colon. Scope could not go beyond the growth as it was causing obstruction. Biopsy was taken from this growth, and it was well differentiated adenocarcinoma colon. Patient underwent CT scan for the staging, and this was the CCT scan. So you can see there is a growth causing obstruction, there is a dilatation of descending colon, and you can see the rest of the intestine. So CCT report was that there was a circumferential stenosing growth in the descending colon with a large polypoidal intramural component, and it was likely to be neoplastic pathology. So patient underwent left side laparoscopic hemicolectomy, and histopathology was turned out to be adenocarcinoma as clinically it was, and peritoneal lymph node status was known metastatic. All 9 nodes were negative. Omentum was negative. However, patient had pain again after surgery, and patient underwent PET CT scan. Now in the PET CT scan, we found something else. So there was one pathology in the ascending colon also. So there is an intense uptake. There was a growth in the ascending colon also. So it was missed because that descending colon growth was obstructing, and it was not done colonoscopy up to this lesion. So retrospectively, it was, they thought we should do CCT also. PET CT may be falsely positive. So CCT was done, and now we can see there is a growth on the CCT also. So retrospectively, we went and we tried to find out. This was the pre-operative CCT. So you can see the growth, you can see descending colon, and at that time there was a growth. But since it was not causing any obstruction and there was no contrast here, barium was not there, so it was missed on the first CCT scan. Okay, so patient had FNAC, and final diagnosis was multicentric adenocarcinoma of colon. Patient had second surgery because it was missed on the CCT scan, and again right hemicolectomy was done, and patient now they like PET CT, they want to make sure everything is okay, and now this is post-operative second surgery PET CT scan, which is normal now. What about the hepatocellular carcinoma, role of PET CT scan? These are the PURI 2 recommendation. I was part of these paper. So there is a limited role of PET CT scan in well-differentiated HCC, but there is definite role in poorly differentiated HCC, especially when you are looking extrahepatic diseases, and if there is a high uptake on the PET CT, it can prognosticate these patients. More uptake means poorly differentiated tumor and poor prognosis. So this is a few examples. You can see there is a hypotense lesion on the CCT, and you can see intense uptake. In addition, there are node also. So extra hepatic disease. This is another patient. You can see multiple lesions. Intrahepatic radicals appears to be dilated, multiple hypodense lesions showing all uptake. In addition, they are retroperitoneal, peripancreatic, and cervical lymph nodes also. This is another patient. You can see, in addition to the primary disease, you can see there is a inferior vena cava or thrombus uptake also. So if it is a metastatic disease and thrombus, so it can show uptake in those cases also. Moving to another PET CT, now initially we were thinking that tumor is only having the tumor cells, cancer cell, but now there is, other than tumor cells, there is a lot of other things that is known as stroma. So stroma is making 90% of the tumor part, and now there is a seed and soil theory. Previously, people were thinking if seed is good, the tree will be good. Now, soil should be good. So that is why, the another PET CT imaging is coming. That is known as FAPI imaging. So that is helpful in patients with well-differentiated HCC patients also. Like here, you can see the first image is FDG, a lot of brain uptake, but hardly any uptake in the tumor. But if you see the FAPI, you can see uptake in the FAPI images. So no brain uptake means FAPI images. So there is no physiological uptake of the FAPI in the brain. This is patients with gastric cancer, and especially when there is a tumor volume is not that much, like mucinous adenocarcinoma, signet ring cell. In those cases, FDG may not be good. In all those cases, FAPI may be useful. Like in this case, if you see, this is FDG and this is FAPI. So FAPI PET scan is showing uptake. Similarly, like this is FDG PET scan, and you don't see much here, but you can see ascites on the CT, but there is a lot of disease on FAPI PET CT imaging. So this is a new thing. The another PET CT imaging is the somatostatin receptor imaging PET, and we here target somatostatin receptor type 2. There are 5 types of the receptors, and this is like very useful in neuroendocrine tumor, and this is all that WHO classification of 2019, GP neuroendocrine neoplasm now, and this is there are 3 PET CT used for molecular imaging of neuroendocrine tumors. So one is DOTANOC PET CT scan, another is fluorodopa PET CT scan, and FDG PET scan when it is poorly differentiated. So well differentiated neuroendocrine tumor, that is grade 1 and grade 2, those DOTA scan is useful. If it is grade 3 or neuroendocrine carcinoma, it is FDG which is more important. So clinical indication is early diagnosis, staging, treatment response evaluation, and diagnosis of recurrent disease, as well as for the prognostications. I go one by one. This is one of my colleagues' father. He's an 80-year male presenting with diarrhea, raised gastrin level, endoscopy was normal. And you see very small thickening here and very intense DOTANOC uptake. You can see very little abnormality on the CT, but very high contrast on the PET CT scan. So on FDG, it was normal because it was grade 1 neuroendocrine gastric carcinoid. Another patient referred by Dr. Anup Saraya. He was a physician, 55-year physician, raised gastrin level. Patient was classically having diarrhea, but endoscopy was normal. And here you can see on the PET CT, there is minimal thickening. Dr. Ankur showed a lot of cases with, intestinal thickening. Many times you have good that there is a thickening, there is a contrast enhancement. In addition, if there is a expression also, it is giving you good diagnosis. And in addition to that, you can see 2 metastatic liver lesions also in this case. So primary of unknown origin is a big issue. This cartoon is like you do everything and after that you say good news, exploratory surgery turn out to be negative. But it may not be truly negative. You can see we have published a lot of literature on this. So this is with the international collaborators. Here you can see very small in about 2 millimeter, 3 millimeter lesions here on the MR, and you can see good contrast on the DOTANOC scan showing abnormality. Another, you can see in the duodenal part 3 or 4, you can see very small lesions here, and there is a good uptake here. Another patients with ileal carcinite, you can see this is primary in the ileum, then mesenteric node and liver metastasis. This is patients with multiple lesions in the pancreas and liver metastasis. And if you see this CT scan is normal, but you can see very small marrow lesion also. So sensitivity is excellent. It is picking up marrow lesions also. Predictive value for the DOTANOC scan in the suspicion neuroendocrine tumor, it is having sensitivity, specificity, and accuracy of 90 plus in all those cases. So here is one, my PhD thesis case. This is pancreatic tumor. You can see good uptake here in the primary, and we demonstrated that DOTANOC scan is very useful. And this is FDG, which is falsely negative, but this is DOTANOC scan with liver metastasis also in this case. This is, we did work with Professor Govind Makharia. This is, we compared with contrast enhanced CT with CT angiography and gallium DOTANOC with in the gastropancreatic tumors, and we demonstrated that's very useful. Here are a few examples. This is 45-year female with a neuroendocrine tumor and liver metastasis. You can see here the third part of the duodenum, you can see very well increased uptake, and we have given this peanut sign. This is patient's 52-year male presenting with bleeding per rectum, and this is like fart holding technique. If any rectal suspicious tumors are there, we ask the patient to hold, not to pass the gas, and you can see the cartoon. President Bush is very happy, and his defense secretary is not happy with that. So Dotanox scan is very useful in evaluation of treatment response also. This is pre-treatment and this is after treatment, and very useful. This is lutetium Dotanote. We treat these patients neuroendocrine tumor, those well-differentiated tumor. This is like pre-treatment. You can see liver lesion, primary lesion in the pancreas, and after lutetium dotatate therapy, this is showing good response. This is for the prognostication. It's very useful in these cases also. This is very good case referred by one of the gastroenterology colleague. This is presented with fever of unknown origin with multiple liver metastasis. Here is the primary showing Dotanoc uptake, but this is FDG showing metastatic uptake. So primary is well differentiated neuroendocrine tumor and metastatic are poorly differentiated neuroendocrine tumor. Patient received chemotherapy and showing good response, but since it was poorly differentiated, patient had a recurrence of again disease and patient died within 6 months of the disease. This is guideline is showing that somatostatin receptor imaging is useful in neuroendocrine tumor and should be used. So this is like conclusion slide. If it is well differentiated, you should use Dotanoc scan. If it is poorly differentiated, you should use FDG. So Dotanoc scan is useful for the very high accuracy for detection of neuroendocrine tumor, and it should be guide the treatment whether sandostatin or lutetium. Thank you very much for your kind attention.
Use the mic in front. Yes, sir.
This question for Dr. Rakesh, please. I have two queries. One is regarding the use of PET in indeterminate biliary strictures, where the biopsies are difficult or negative, but we still suspect malignancy, especially in hilar strictures, where biopsy itself. That is one question. Second is we have lots of patients with diarrheas, old age, and we have to exclude a neuroendocrine tumor. But most of them have received a proton pump inhibitors, and they have a relatively high gastrin levels. Yes. So would you suggest some cutoff of gastrin levels beyond which we should go for a PET CT scan?
We get many of these patients. Like most of the time, gastrin levels what we are getting is more than thousands. And we usually get Gould yield. If gastrin level are more than 1000 or 800, I'll say yield is around 90%. So 90% patients, we tend to pick up the lesions in the small intestine or in the duodenum or in the stomach. So that's my experience. Regarding your first questions, biliary strictures, if there is any abnormal uptake, it is most likely more than 90% it's a neoplastic. If it is a benign, then we don't see uptake in these cases.
One more question, sir. You said SOL pancreas in chronic pancreatitis patient and you can differentiate in PET scan. So what is the role of this PET scan in the group pancreatitis? Because it is the one of the gray zone where you have to differentiate it between group pancreatitis and the carcinoma of pancreas. So the role of PET scan. And one more question, when you have unknown of primary, in such cases you should go for the FDG PET scan or DOTA PET scan, because you don't know whether it is NET or the other tumor.
Yeah, for the unknown primary, if they are liver metastasis, most of these patients coming to us are with the diagnosis of neuroendocrine tumors. you have the lesions on the liver. Most of these are presenting with liver metastasis, and FNACs has been done, and now you are having neuroendocrine tumor diagnosis. So we are looking for the primary. In those cases, we are doing Dotonox scan. And if it is unknown primary, we do the FDG first if there are no liver metastasis. The first question regarding your pancreatic mass, usually we are getting big, especially chronic pancreatitis, or those pancreatic lesion or with strictures, periampullary lesions. We do FDG, no role of Dotonox scan in those cases, and we go by increase uptake. So if it is a high uptake, then it's neoplastic. Many times, those benign tumors can cause strictures, but they are no uptake on FDG.
No, but group pancreatitis, again, which is the one of the difficult situation where you can't differentiate between the carcinoma of pancreas or it is the benign condition like group pancreatitis. So is there any role of PET scan in such condition specific?
I don't know correctly this answer, but I'm not sure. I'm sorry, I don't have that much.
Please could you come to the mic? We cannot.
These cases, PET scan can help because if you find some latent metastasis.
Yes, if you're talking about primary, I really can't make it. But yes, if it is like staging these patients, we definitely can look for the metastatic.
With the permission of the desk panel, can I just add a point to the question that was asked? I think EUSFNA would be a better choice over thinking of a PET scan in cases where we are suspecting a mass in the head of pancreas or groove pancreatitis. That is the point that I wanted to add.
I think diffusion weighted MRI is a very good solution for this because it helps in differentiating. There would be restricted diffusion if it is a malignant tumor versus a groove pancreatitis.
Inflammation will not produce any restriction.
No, it would not produce that degree of restriction that it becomes absolutely white on a diffusion weighted image.
So I'll just add to that.
The degree of restriction.
I'll just add to that. There are few things which can be picked up better on MR. So once we see a mass which is epicentered in the head region of the pancreas, right? And patient is an alcoholic and we have some suspicion based on CT or the history that this might be inflammatory and not malignancy. So when we do MRI, we look for the epicenter of the lesion. We look for wall thickening in the medial wall of the duodenum. We look for tiny cysts which become apparent on the heavily T2 weighted images on MRI. And we look for the displacement of the gastroduodenal artery. So if it is located in the groove, then GDA can be traced, displaced medially towards the pancreas. On the other hand, a pancreatic head lesion usually displaces it towards the duodenum. And as ma'am said, diffusion weighted MRI and contrast enhanced dynamic MRI. So these are multiple paradigms. And of course, even with all these things, sometimes we don't know what is going on and we rely on EUSFNA. That is there.
Secondly, ma'am, I have a question for the panel again. Pardon me, it's a question in two parts. First is, what are the common indications and thresholds for getting an MR defecography in a routine practice in a second-tier city? Secondly, does MR defecography affect the management of solitary rectal ulcers? So, how, if it does, and how, if so, how?
So, answering your first question first, as I said that MR defecogram can be done for any kind of pelvic dysfunction. It can be done for evaluating the cause of constipation. So in constipation, I think all the institutes first do a transit study. If that is abnormal, then it's a transit disorder. But if you're suspecting an obstructive defecation disorder, then MR defecogram helps. Then for anal incontinence, it can help us in knowing exactly what's happening by the dynamic Cine loop sequences. And also the prolapse of the various organs like the bladder, the vagina, and because these also perpetuate a defecatory disorder. So basically it gives a very holistic picture of the pelvis as to what is happening and also the functional details. So in our institute, we have a package for anorectal manometry plus a MR defecogram. which is not a costly package. It's about, say, 5,000-6,000 rupees. And in all our constipation patients, we would do both the studies because we find both of them complementary.
I think there is time is up, and I think we should close it now. Thank you.
One last last question to Dr. Ankur. I mean, there's a huge implication of detecting inflammatory and a fibrotic stricture on radiology, because sometimes, because I'm a pediatric, sometimes we cannot do a spiral or capsule always in pediatric patient. So how confirmatory by radiology, by your MR enterography, CT, if you can manage one by NG tube and under anesthesia, we can do the imaging. So how confirmatory that it's an inflammatory or a fibrotic, because that changes the treatment and the interventions also.
So as I showed few examples, the findings which suggest active inflammation include presence of stratified pattern of enhancement in the bowel wall, presence of engorged vasa recta, that is increased mesenteric vascularity, presence of submucosal edema. So those are the things we rely on CT. When we are doing MR, then we have additional paradigm. So on T2 weighted sequences, we can look for hyperintensity within the submucosa on the T2 weighted sequences. So that is like definitive of submucosal edema. And of course, the features which were seen on CT will be seen better on MR. And the lastly, presence of diffusion restriction. So diffusion restriction also goes in favor of active inflammation. There are some investigational sequences also like magnetization transfer, which have been shown that they correlate with the degree of fibrosis. So as per your real question that how accurate these things are, although many of the cases will not be in black and white. So we have around 70 to 80% accuracy in detecting disease activity. And as all of you will agree, it's never pure active inflammatory and pure fibrotic. There's always a predominance of one and both are there. So many times we will be able to pick that predominance of active inflammatory, and when those features are not present, we would say this is likely to be fibrotic.
Thank you very much. We'll close the session now. Thank you.
Thank you, sir. For the next session, may I please invite Dr. Kartar Singh, Dr. Shrikant Mukhevar, and Dr. Dinesh Agarwal to please chair this session on gastroparesis, intestinal pseudo-obstruction, colonic inertia. Are they under-recognized?
Warm welcome to the pre-lunch session. And we go on to the topic which is, I think, is the most neglected and underdiagnosed. So probably without wasting time, I invite the first speaker, Dr. Nitesh Pratap. Dr. Nitesh Pratap is a gastroenterologist working in KIMS, Hyderabad. And I would say that he's son of my close friend, Dr. Bajrang Pratap. Over to you, Nitesh.
Thank you, sir. Good afternoon, everybody. Today I will be talking about how to evaluate gastroparesis, colonic inertia, and intestinal pseudo-obstruction. These are, I think, three different topics, so I will be dealing with it separately. So we all know that gastroparesis is nothing but an objectively delayed gastric emptying in the absence of mechanical obstruction. This is mostly commonly seen in females when compared to males. The most common causes are idiopathic, almost in 40% of the patients. It is diabetic in around 37%, drug-induced. Other causes include post-operative cases, collagen vascular diseases, and post-infectious with cytomegalovirus or varicella zoster virus. Now, these patients normally present with nausea, vomiting, early satiety, postprandial fullness, abdominal pain, and with time, they have a significant weight loss. Now, when you are evaluating a patient with gastroparesis, our main goal is to exclude an mechanical obstruction. You have to correctly diagnose whether it is gastroparesis and do a etiological workup. So for excluding mechanical obstruction, we'll do an upper GI endoscopy in these patients, which will rule out a mechanical obstruction. And normally when we do endoscopy in these patients, there will be food residue despite overnight fasting. When we come to assessment of gastric motility, you can use scintigraphy, breath test, or the SPART pill, that is a virus capsule motility. Now, gastric emptying normally is done with a standard egg meal. In India, we use roti, or in South, we use idli with technetium sulfur colloid tagged. We do scans every hour for 4 hours. It is very important that the patient should not be on any medications affecting gastric emptying for at least 2 days before, and the sugar should be less than 180. Now, you label these patients as delayed emptying if there is more than 60% retention of activity at 2 hours or more than 10% at 4 hours. And based on the amount of activity left, if it is 10 to 15%, you label them as mild, 15 to 35% moderate, and more than 35% severe. Other test is the C13 breath test, in which octinoic acid or spirulina are tagged to carbon isotope 13 and incorporated into meal. In these patients, you will do the breath test to look for the C13 activity, and you will demonstrate how much increase is there from the baseline of this isotope. The main limitations are in patients with intestinal malabsorption and patients with COPD and liver problem. The third thing to assess the motility of the stomach is the wireless capsule motility. This capsule records pH, temperature and pressure after oral ingestion, and this is transmitted to an external wireless receiver. So in this, once the patient ingests it and it moves from the stomach to the duodenum, there is a change in pH. Normally, the gastric retention time is less than 5 hours. If the wireless motility capsule or the smart pill remains in stomach for more than 5 hours, it indicates a delayed gastric emptying. Apart from this, it also looks at the pressure. And if the amplitude of contraction is low in the antrum, that indicates a myopathic cause for gastroparesis. The sensitivity and specificity is around 60 to 80% as compared to scintigraphy. So these three tests that are mainly used for diagnosis of gastroparesis. Apart from this, other supportive tests include electrogastrography, in which you put electrodes along the long axis of the stomach and you look at the slow wave frequency. Abnormal dysrhythmias in the form of tachygastria or bradygastria is seen in around 75% of patients with gastroparesis. Antroduodenal manometry, you pass a catheter transnasally and position it beyond the ligament of teats under the fluoroscopic guidance. Normally you have a recording time of 6 hours. 4 hours is in the fasting, then you give a standard meal and report for another 2 hours. So you are looking at antral hypomotility, pyloric dysfunction, and duodenal dysmotility. So antroduodenal motility, it helps us to characterize the gastroparesis into myopathic pattern or neuropathic pattern. In myopathic pattern, what happens is, because it is predominantly affecting the muscles, the MMC are preserved, but the amplitude is very less. The amplitude of contraction is less than 20 mm of Hg. While in neuropathic, you have got normal amplitude wave, but they are not coordinated. So if we summarize gastroparesis in a patient who has got symptoms of gastroparesis, you do a basic blood test, you do an endoscopy or an enterography to rule out an obstruction. For diagnosis of gastroparesis, we will do a gastric emptying study or breath test or wireless capsule. And for further differentiating, you will use electrogastrography or antroduodenal manometry. So the second topic I'll be covering is colonic inertia evaluation. This is also known as the slow transit constipation. It is the inability of colon to move stool from cecum to sigmoid at least once every 3 days. Colonic inertia makes up to around 13 to 37% of idiopathic constipation. Now, these patients typically present to us with constipation with stool frequency of less than 1 per week. More common in young women, they have lack of desire to defecate and abdominal distension. So the evaluation of colonic inertia includes basic blood tests like a complete blood picture, random blood sugar, thyroid. You do a radiography, X-ray, you do a colonoscopy in patients of constipation who have age group of onset more than 45 years, or in those patients in whom alarm features are there like anorexia, unintentional weight loss, rectal bleeding, iron deficiency anemia, or family history of colon cancer.
Now, to assess for the colonic transit, you can use radiopaque markers, wireless capsule, or scintigraphy. So in radiopaque markers, there are 2-3 methods. The conventional is you give 24 radiopaque markers on day 0. You have to stop laxatives or any medicines affecting the GI motility for 2 to 3 days before and during the study also. You take an X-ray at day 1, day 3 and day 5. Normally, 80% of these markers are eliminated by day 5. If there is retention of more than 5 markers at day 5, it is considered as abnormal. And even based on the pattern, we can decide whether it is slow transit or dysenergic, because if you see this image, in patients with slow transit, the markers are scattered throughout the colon, while in patient with dysenergic defecation, the markers accumulate more in the rectosigmoid. Ghoshal sir has also come up with a protocol because of difference in the transit between the West and India. He has used 20 markers administered at 0, 12 and 24 hours and with an X-ray taken at 36 and 60 hours. If there is more than 14 markers retention at 60 hours, it has got a sensitivity of 95% and specificity of 100% for diagnosing slow transit constipation. So colonic, apart from the radiopaque markers, other tests we can do is wireless capsule motility, which has sensitivity and specificity similar to the markers, but it's more expensive. Scintigraphy, in scintigraphy, use a pH sensitive resin coated containing indium labeled charcoal particles. Here you image at 48 hours, 72 hours and at 24 hours. And here you can see either this total decrease in the transit or right-sided retention or rectosigmoid retention. Colonic manometry can be used in patients with slow transit constipation who are not responding to medical disease and in those patients who have got a megacolon and a megarectum. Colonic manometry usually evaluates 3 physiological responses. It looks at the high amplitude propagating contractions. It looks at gastrocolic response, that is response after the person takes food, and colonic response to awakening. Now, based on the presence or absence of all the 3, if all the 3 are present, then the motility is normal. In neuropathic colon, 2 of the 3 responses are absent, while in myopathic, all 2 of the 3 are present. But in myopathy, most of the motility studies will show attenuated pattern of contraction. Barostat can also be added to motility manometry to assess the rectal sensation and compliance. So another important thing in patients with slow transit constipation is presence of pelvic floor dyssynergia. Slow transit is associated in almost 1/3 of the patient. And the Rome-4 criteria says that for us to diagnose pelvic floor dyssynergia, you should have 2 of the 3 should be positive. Either you should have an abnormal anorectal manometry showing an incomplete relaxation or a paradoxical contraction of the external sphincter, an abnormal balloon expulsion test, or an abnormal defecography. 2 of the 3 is required for diagnosing. So if we come to colonic inertia, our summary is that in a patient who has got constipation, stool frequency less than 3 per day, in these patients you have to look first radiopaque marker study or other colonic atelectasis, and also you can look at the colonic manometry. The last topic is the chronic intestinal pseudo-obstruction. These are those patients who have got intestinal obstruction signs and symptoms in the absence of anatomical obstruction. The etiology is most commonly in pediatrics is idiopathic, while in adults, 50% of the causes are secondary to a systemic disease. These include GI smooth muscle disorders, including in patients with connective tissue disorders, presence of nerve-related disorders, endocrine and metabolic causes. So these patients typically present to us with abdominal distension, pain, vomiting, which may or may not be bilious, constipation. In these patients, many of them say that these symptoms are exacerbated by viral or bacterial infections, anesthesia, psychological stress, and malnutrition. Apart from these symptoms, these patients may have malabsorption as well as diarrhea secondary to small intestinal bacterial overgrowth because their intestines are quite dilated and this transit is slow. Another important thing to look at in these patients is the associated urinary bladder dysmotility. This is seen in almost 70% of the pediatric population. This can be in the form of bladder atony with hydronephrosis or vesicoureteral reflux. So if you evaluate here also any obstruction, first rule out a mechanical cause. Second, confirm the GI motility impairment using scintigraphy or manometry and rule out a treatable cause. X-ray might show a dilated air fluid level. Entography will rule out an intraluminal obstructive pathology. Endoscopy can be done in those patients in which you are suspecting a upper gut mechanical obstruction. Now, scintigraphy, intestinal scintigraphy usually use water containing indium DTPA with or without a radioable solid meal. Here you do an imaging at 6 hours. You look at how much tracer has reached the terminal ileum. Normally, more than 40% of the tracer activity progresses to terminal ileum by 6 hours. If less than 40% is there in the terminal ileum at 6 hours, it indicates that the the delayed small bowel transit is there. And even if the activity persists in multiple loops in the small bowel at 6 hours, you label it as delayed small bowel transit. Manometry, additional studies can be done because esophageal manometry is abnormal in almost 50% of the patients with SIPO. And antroduodenal manometry is also abnormal. Suppose a patient doesn't have a dilated bowel and the antroduodenal manometry is normal. It rules out SIPO. Anorectal manometry in those patients in which you are looking at Hirschsprungs, and colonic manometry will show the absence of high amplitude contractions and lack of gastrocolic reflux. So histopathology in these patients is indicated in two subgroups. One is the idiopathic cases with acute onset in which you are looking at a post-infectious pathology. And in those patients in whom there is a very rapidly progressive form which is not responding to therapy. Normally for histopathology, the London classification is used, and based on the abnormality, it can be intestinal myopathies, intestinal neuropathies, or mesenchymopathies. So if I summarize my chronic intestinal pseudo-obstruction, so in patients with the correct scenario who have got distension, vomiting, and you do first rule out a mechanical obstruction, do a basic test like blood sugar, you should do thyroid metabolic workup, viral screen for EBV, CMV. If none is present, then you look for motility, you look for the for the bowel transit, you do manometry, and in correct condition patients, you should look for full thickness biopsy. So I'll conclude by saying that GI dysmotility disorders, they represent a very severe constellation of symptoms because of malfunction of the stomach, small bowel, and intestine. These patients predominantly present with nausea, vomiting, early satiety, and abdominal pain in the upper GI part, and predominantly with constipation in the lower GI motility. The main part of evaluation of these patients is to rule out an organic cause of obstruction. You should confirm the diagnosis of GI dysmotility and do a etiological workup to look for causes which are treatable. Thank you.
Thank you, Nitish. Why don't you join me here? There will be question answer at the end, and we'll take the question answer at the end. We go on to the second topic to be discussed by Dr. Sanjeev Sachdeva. Dr. Sanjeev Sachdeva is Director Professor of Gastroenterology in GB Pant Hospital, New Delhi, and he is a Vice President of INMA. May I invite Sanjeev for the next talk on treatment of gastroparesis, intestinal pseudo-obstruction, and colonic inertia.
Thanks, respected chairpersons and ISG, for inviting me to talk on treatment of gastroparesis, intestinal pseudo-obstruction, and colonic inertia. These are three elite entities, separate yet linked, just like these three superstars in recently concluded World Cup soccer. They all play for Paris Saint-Germain. Similarly, these three entities are linked by severe GI dysmotility, as emphasized by Dr. Nitish. So the first topic for me is gastroparesis. It is truly a multidisciplinary team approach. The first openers for the treatment are us, that is gastroenterologists and dietitians. Key aspects of management include correcting the underlying causes if identified, correction of malnutrition, drugs to control predominant symptoms and improve quality of life, drugs to improve gastric emptying, reserving the invasive therapeutics for refractory cases, and lastly, cognitive and behavioral therapy in selected cases where there is associated depression. In mild to moderate gastroparesis, the nutrition can be managed orally through multiple small frequent meals, which should be low in fats, fiber, and low FODMAPs. They should be well homogenized, small particle size, preferably less than 2 millimeters. And of course, alcohol needs to be avoided because that can lead to delayed gastric emptying. In severe gastroparesis, you either have to resort to liquid oral diet or you have to resort to enteral feedings. Some patients may require either total or partial parenteral nutrition, but that should be discouraged because of complications. The various pharmacological options for gastroparesis are drugs for nausea and vomiting, drugs to accelerate gastric emptying, and drugs for visceral pain. The management should be targeted to predominant symptoms. Metoclopramide is currently the only FDA-approved drug for gastroparesis, and American Journal of Gastroenterology Association recommends metoclopramide as the first drug along with dietary modifications to be given for at least 4 weeks, and in case the patient does not respond, label the patient as medically refractory gastroparesis. The new drugs in the pipeline include various 5-HT4 receptor agonists, ghrelin and mortallin receptor agonists, various antidopaminergics, and neurokinin 1 receptor antagonists. In addition, there are a few drugs which have been launched in the last few years for, say, conditions like chronic constipation or other indications. They have been used now for treatment of gastroparesis. These include procalopride, mirtazapine, buspirone, and icosiamide, which is a fundic relaxant. Procalopride is truly a double record drug. It works in chronic constipation, but in a recent study from the Genentech group in Belgium, it showed that it improves gastrointestinal symptom scores in patients with gastroparesis, along with improvement in gastric emptying. Mirtazapine is a traditional tetracyclic antidepressant which has been used for depression management, but it was used recently in a study published from USA which showed that it improves gastric emptying as well as mean scores of gastric dysmotility at week 2 and week 4. Recent network meta-analysis just published 2 weeks back showed clevopride and domperidone to be the main drugs which are effective for gastroparesis. For individual symptoms, metoclopramide ranked first for nausea, fullness, and bloating treatment. There are various endoscopic therapies which my next speaker is going to talk about. These can be classified mainly as pyloric and non-pyloric. The role of surgery is there in intractable cases. The procedures can be pyloric interventions, gastric electric stimulator insertion, or various forms of gastrectomy. And a surgeon may also be called for either venting or providing enteral nutrition. The gastric electrical stimulation has been approved by the US FDA for refractory symptoms of gastroparesis. It has shown early promise in showing improvement of nausea, vomiting, nutrition, and quality of life. Temporal electric stimulation should be preceding permanent pacemaker insertion. Newer perspectives of therapy include targeted pyloric intervention based on endoflip and manometry, combination treatments like targeting different aspects of pathophysiology, newer endoscopic interventions, and newer drugs, as I mentioned earlier. This is the algorithm for management for patients with gastroparesis as proposed by AGA, which focuses on the identification of predominant symptoms and the severity of gastroparesis, management of the secondary causes. The second topic for me is intestinal pseudo-obstruction. We know that intestinal pseudo-obstruction is a truly enigmatic disease. The disease course is marked by intermittent acute obstructive episodes with moderate to severe interdigestive symptoms in the intervening period. The long-term outcome is poor. The predictors of outcomes in these patients include pediatric onset of the disease, myopathic forms of SIPO, pan-GI involvement, extremes of age, presence of secondary causes, particularly paraneoplastic, dependence on TPN, absence of MMCs on manometry, and poor response to prokinetics. The treatment of SIBO, just like gastroparesis, is multidisciplinary team effort. The main goals of treatment include correcting the underlying causes if identified, controlling symptoms and improving quality of life, correction of malnutrition, and treatment of complications like SIBO. The therapeutic regimens include nutritional management, drug management, GI demoperation, and the role of surgeon in the last. Nutritional support can be achieved orally, enterally, or parenterally. The route of feeding depends on severity of symptoms, the sites of involvement, and the stage of the disease. Oral feeding should be small and frequent. It should be low in fiber and low in fats, just like in gastroparesis. Enteral feeding might be required later, and TPN is a last resort because it is associated with a lot of limitations like thrombosis, septicemia, liver insufficiency, pancreatitis, and glomerulonephritis. This is an escalation algorithm for nutritional management in patients with SIBO, where we start with the oral therapy, we go on to enteral therapy. Here we can take help of drugs like octreotide and erythromycin to promote gastric emptying and GI emptying. And lastly, parenteral nutrition is recommended. GI decompression may be needed in these patients. The first line of GI decompression is usage of nasogastric tubes or rectal tube placements, but rescue treatments may be required in form of colonoscopic decompression, endoscopic or surgical venting. This is the algorithm to manage subocclusive episodes just like acute pseudo-obstruction, where the key elements are use of IV neostigmine, colonoscopic decompression, and in refractory cases you can resort to percutaneous or surgical cecostomy. The pharmacological treatment of SIBO is aimed at treating symptoms and avoiding complications. The main drugs are prokinetics, antiemetics, antimicrobials for SIBO, drugs for relief of pain and distension. Most of these studies, since the disease is very rare, the studies are mostly uncontrolled and small, mostly single-digit studies. And two of the key drugs which have been studied in the last 2 decades have been red-carded by now. The current available good drug options include erythromycin, octreotide, or a combination of the two, neostigmine or pyrostigmine, and procolaprid and other 5-HT4 drugs. Other aspects of pharmacological treatment is treatment of SIBO with cyclical therapy with antibiotics like rifaximin, drugs for visceral pain, drugs for constipation, immunosuppressive medications for inflammatory neuropathy, and paraneoplastic SIBO, people have used rituximab in combination with cyclophosphamide, and IVIG might be used for other tumors like thymoma-associated SIBO. The final frontier, even for SIBO, is surgery, but you need to avoid unnecessary surgeries. Surgeon may be called in to make diagnosis for you in form of full thickness intestinal biopsies. Segmental or localized resections may be needed in very carefully selected cases. Venting, gastrostomy, or enterostomy may be needed. And when all therapeutic options failed, we resort to intestinal transplantation. The indications for intestinal transplantation include TPN-related complications, disease-related poor quality of life despite TPN. The various types of transplant may be isolated small bowel transplant, combined small bowel and liver transplant, and multivisceral transplant. Various challenges are there for intestinal transplantation compared to other reasons like concomitant neuromuscular disorders of urinary tract, multivisceral involvement, chronic use of opioids, and technical problems posed by previous laparotomies. Patient survival rates are reasonable, ranging from 50 to 70% in USA and Europe. This one study from China showed efficacy, just like a magic wand, in improving the symptoms as well as etiological signs in patients, a small series of 9 patients with SIBO. This is a final algorithm for management of chronic intestinal pseudo-obstruction, where I again emphasize on finding and treatment any secondary causes, the medical management, oral and enteral nutrition, which might progress later to requirement of total parenteral nutrition, and ultimately when the complications of TPN occur, then we may have to resort to intestinal transplantation. The future for SIBO seems to be bright with the ongoing research for novel biomarkers, multicentric RCTs or newer and safer prokinetics, combination therapeutics, FODMAP-based dietary interventions, stem cell transplantation for genetic variants of SIBO, and FMT as I have mentioned just now. The third topic for me is colonic inertia. Colonic inertia, as Nitesh has mentioned, it is the severest form of slow transit constipation. Most of these patients, they present to us with intractable or refractory constipation. And there may be overlap in a proportion with dyssynergic constipation, which must be excluded. This is the Indian data of STC from study from Mumbai, where they found that 13% of the patients with primary constipation or functional constipation were slow transit ones. The management strategies for slow transit constipation again include management of secondary causes or aggravating causes, looking for associated dyssynergic defecation if present. The choice of laxative is preferably stimulant laxatives or enterokinetic agents. Non-responders must be tested in case available for breath methane, and if it is elevated, you should use rifaximin as proposed by our society in the recent constipation guidelines. Intractable refractory cases can be managed by surgery or other rescue therapies. The pharmacological basket available for chronic constipation, the things which are for interest for slow transit are basically stimulant laxatives, colonic enterokinetics, and newer drugs in the pipeline like 5-HT4 agonist, velocitrag, and neranopeptide. Prucalopride, in a study from Dr. Camilleri group in 2008, showed efficacy of both doses, 2 mg and 4 mg, in management of severe chronic constipation. But there is a limit where even prucalopride may not succeed in management of symptoms of STC. This is as shown in this study, where the transits become very, very slow. Even prucalopride may not work. This we heard 2 days back from Dr. Ghoshal, where you may need now addition of other agents like stimulants like bisacodyl. So this is a recent network analysis of drugs used for slow transit constipation, which showed that stimulant laxatives like bisacodyl, sodium picosulfate were ranked first at 4 weeks, and prucalopride was the first ranked drug at end of 12 weeks. Another entity is opioid-induced constipation, which is a form of slow transit constipation. Recent meta-analysis showed that PEMORAs, that is peripherally acting mu opioid antagonists like methyl naltrexone, Noxogel, and nalmefene are the frontline drugs to manage opioid-induced constipation. This recent study from SGPGI Lucknow by Dr. Ghoshal showed the efficacy of methane-lowering drugs, that is rifaximin, to improve slow transit constipation. So methane should be tested. Again, there is a study from China regarding the use of FMT in management of colonic inertia or slow transit constipation, which shows promising results, though the study was not that large. Other newer options for management of slow transit constipation or colonic inertia include sacral nerve stimulation, transcutaneous or functional electrical stimulation, inferential current application, and tibial nerve stimulation. Other fascinating options include transanal irrigation or antegrade continence enemas, which are safe options, and they are usually mainly used in context of neurogenic bowel dysfunction. They may be considered as bridge before resectional surgery. Transnasal irrigation can be achieved through tube succostomy. It can be an alternative to loop ileostomy, and it can be achieved endoscopically through PEC. Surgery is again a final frontier even in management of colonic inertia. Refractory slow transit constipation cases with documented colonic motor dysfunction may be offered surgery as management. Opioid-induced constipation and fecal evacuation disorder must be ruled out before you take the patient for surgery. Relative contraindications include major upper GI dysmotility symptoms. Colectomy with ileorectal anastomosis is a standard of care. Loop ileostomy may be used as a bridge. It results in improvement of constipation and quality of life to the tune of 50 to 100%. So this is our final algorithm, which Nitish has already shown. A patient with refractory chronic constipation after due evaluation can be offered stimulant laxative or enterokinetic like prucalopride as the first drug of choice. It can be added with other drugs like sodium picosulfate or bisacodyl. If there is no response, you should test for breath methane if available. And if methane is high, you should use rifaximin. And surgery should be resorted for colonic inertia patients who are refractory to everything. And again, the second star of my slide shows that associated fecal evacuation disorder must be excluded. Thank you.
Thank you, Dr. Sajdeva. Can you please join here? We'll take the questions at the end. May I invite the last speaker for this session, Dr. Roy Mukkada. Dr. Roy Mukkada is a Director of GI Endoscopy and Senior Consultant Head of Gastroenterology at the Lakeshore Hospital, Kochi. He will be talking on endoscopic options for managing gastroparesis, intestinal pseudo-obstruction, including maintaining the nutrition in them. Over to you, Roy.
Thank you, sir. Respected Chairperson and dear friends, first of all, let me thank the organizers for giving me this opportunity to talk on this topic, which is, you know, that there's hardly, I mean, very few things to in the endoscopic management. So anyway, there'll be some overlap of slides. So the plan of discussion is the same things which been the etiology algorithm and the toxins, botulinum toxin, what is the current status, the GPOM. So we know that it's a motility disorder characterized by symptoms and objective documentation of delayed gastric emptying of solid food without mechanical obstruction. Can have upper GI symptoms, has already been mentioned, and the objective evidence of gastric emptying delay and the absence of mechanics. So the commonest cause which we've seen is the diabetes, which is the diabetic gastroparesis, then post-surgical and ischemic gastroparesis and other miscellaneous. So the neurological disorders has already been mentioned. There's been different the viral infections, then the post-viral infection, and Parkinson's, etc. Then mainly the drugs which can cause all these problems. So the symptoms of gastroparesis can be chronic nausea, vomiting, postprandial fullness, blotting, upper abdominal discomfort. So the algorithm says that once you diagnose it, exclude iatrogenic disease like drugs, exclude mechanical obstruction, then you confirm your diagnosis by the spirulina blood test or the motility capsule or something like that. Then you give the dietary modification as small particle, low fat, non-digestible. And then go for pharmacological treatment, nutritional support, and then you go for the endoscopic treatments like GPOM, pyloric injection, then the stimulants like and then the surgical, the venting gastrostomy, etc. So endoscopic intervention, mainly botulinum injection was till the time was given, but now the jury is out. That I will be showing few studies of this, and see this. Botulinum toxin injection was given to the antrum in patients with antral hypomotility and pylorospasm. It blocks the exocytosis of acetylcholine in cholinergic nerve endings and blocks the increased tone or spasm of the pyloric sphincter. So there is one, this was a major study which was in one open label study with 179 patients where intrapyloric botulinum toxin was given, which decreased in gastroparesis symptoms in 1 to 4 months in 51 patients. But 2 double-blind studies showed no difference in reduction of symptoms compared with the placebo. And the randomized double-blind controlled crossover fashion, like 23 patients. Again, here also the conclusion was is not superior to placebo in improving either symptoms or rate of gastric emptying. There's another study with 32 patients, intrapyloric botulinum. They have given 200 instead of 100 units. And here it showed some improvement. However, at 1 month, the benefit of gastric emptying was not superior to placebo at 1 month. Then symptoms did not improve significantly by 1 month after injection. So the current status, intrapyloric injection of botulinum toxin is not recommended for patients with gastroparesis based on randomized controlled trials. It's a strong recommendation and moderate quality of, again, the UEG also says that it does not endorse pyloric botulinum injection toxin. Having said that, there are 2 indications. One is if you're planning a patient for GPOM, and if you give the botulinum toxin, if you show it shows good improvement, then you can say that GPOM can be effective in this patient. Another thing is can be a temporary improvement in symptoms. So coming to GPOM, now the main thing which we are talking about is GPOM. So an advanced endoscopic procedure. This has actually been extrapolated from the POEM for achalasia. I mean, if you take the botulinum, that also been extrapolated from the botulinum toxin which was given for achalasia, where it has given good results at least for short term. So GPOM also the same way. It is also has been principles of esophageal POEM, and first reported by Kashyap et al. In 2013. Now, first the identification of pylorus, then the mucosal incision, submucosal tunneling, identification of the pyloric ring, pyloromyotomy, and end of the myotomy and closing the entry tunnel. Same as it is done in for the same principles as in POEM. And this is a short video where I don't know that. Yeah, this is courtesy to Dr. Amol Bape. So this is one of the patients from this this thing. This first you make a submucosal tunnel, same as like in POEM. See, this is a tunnel which you can see. This is around 5 to 6 centimeters proximal to the pyloric opening, and then you come and then identify the muscle, and then you do a myotomy. That's a duodenal mucosa which you can see here, This is the muscle. Now we're cutting the muscle. So once the myotomy, this is a myotomy being done, and once the myotomy is completed, you come out and close the incision by clips. So the now they say that double myotomy is more useful, because double myotomy means you do a myotomy at 6 o'clock or 7 o'clock position, and then you take another myotomy at around 4 o'clock position, which is 1 centimeter apart. That's a double myotomy. So in double myotomy patients, the study showed that it's got more the symptom relief, and this is how they close the entry point. Now, this is the 2013, the first human gastric peroral myotomy for refractory gastroparesis that I've mentioned, and it's feasible and can be performed by using techniques similar to esophageal endoscopic myotomy. In subsets of patients with refractory gastroparesis benefit from this endoscopic approach to gastroparesis therapy. Now, the technical success is almost 100%, you can see here in different studies, and the functional outcomes also varies from 70 to 80%. And the prospective trial, it shows a significant improvement in the quality of life. Gastric emptying at 3 months shows good response, and the conclusion is GPOM was efficacious and safe for treating refractory gastroparesis, especially in patients with low pyloric distensibility. The first meta-analysis outcome of GPOM in patients with refractory gastroparesis, 7 studies, 196 patients. The mean procedure duration was around 70 minutes, and the average hospital stay was 2 days, 2 to 3 days, and the clinical success was 82%. So the ACG clinical guideline gastroparesis in patients with gastroparesis with symptoms refractory to medical therapy, we suggest pyloromyotomy over no treatment for symptom control with conditional recommendation and low quality evidence. So who will benefit from GPOM? Inferior outcomes of GPOM for diabetic gastroparesis as compared to post-surgical or idiopathic gastroparesis. That's the biggest problem. In diabetic gastroparesis, this is not recommended. However, the first patient they did for type 1 diabetes with long-term symptoms. Then the diabetes and female sex are found to be predictors of failure in univariate analysis and low pyloric distensibility. So prolonged disease is associated with a significantly poorer response. What I mentioned, double pyloromyotomy has demonstrated a superior clinical response in a mean of 6 months follow-up. So GPOM has established itself as an effective, minimally invasive method to treat refractory gastroparesis with an acceptable safety profile. Now, coming to the nutrition in gastroparesis, has already been mentioned, and so this is actually nutrition. The symptoms are chronic nausea, vomiting, postprandial fullness. So once you diagnose, you give small particle, low fat, and low non-digestible food. And the dietary modifications represent the first line of treatment of gastroparesis. Oral intake is preferable for nutrition in patients with gastroparesis. Small, frequent meals. Avoid high in fat and indigestible fibers. So in mild gastroparesis, the same thing is being no need of nutritional support, rarely needed. Moderate gastroparesis, small frequent meals, again caloric liquids, orally, rarely requires nutrition by PEJ feeding. But in severe gastroparesis, the blenderized diet is given more than the frequent other meals, and you require nutritional support most of the time. The last topic, acute colonic pseudo-obstruction, endoscopic option. So you know that it is a massive dilatation of the intestine. The exact pathogenesis remains to be elucidated, and the current evidence suggests an alteration in autonomic nervous system resulting in colonic atony. So risk factors are critical illness, recent surgical procedure, trauma, and metabolic imbalance. So once you diagnose acute colonic distension, whether any surgical cause, correct it. If there's mechanical cause, again you can correct it. And if there's no mechanical cause, acute colonic pseudo-obstruction. Conservative management, then followed by no response, we can give neostigmine. If success, consider low dose. Then the next thing is a colonic decompression. So The endoscopic decompression is reserved for patients with persistent marked colonic dilatation who have failed to respond to conservative measures and refractory to medical management, and there is contraindication to neostigmine. So the ASG guidelines says efficacy of colonoscopic decompression has not been established in randomized trials. However, the benefits of endoscopic decompression extend beyond treatment and allows simultaneous evaluation of colonic mucosa also. So no prospective randomized studies compare this with the pharmacology. So what is the evidence for decompression? In the two retrospective studies independently found colonic decompression to be superior to neostigmine. And the evidence supporting the first-line colonoscopy therapy in managing ACPO is limited. So the endoscopic percutaneous colostomy, just to mention it, it's been not routinely done because of the high complications. It's just like done like in PEG, but here the complications are much more higher. So the it is either done by endoscopy or radiographically. Serious adverse events, wound infection, bleeding, hematoma, perforation, etc. So not done routinely. So for patients with ACPO who are not candidates for conservative therapy or have failed conservative line and have no contraindication to endoscopy, we suggest colonoscopic decompression with decompression tube placement as an alternative treatment. Thank you.
Thank you, Dr. Roy. Would you join me here for the topic is open for discussion. Till there are questions from the audience, let me ask Nitesh. I had a patient who had gastroparesis and the CT showed dilated small bowel as well as dilated colon. So he had PAN and all the routine causes have been ruled out, like thyroid and metabolic factors. So how do you approach to such patient? Do you consider some autonomic neuropathy or something, or how do you approach to these patients?
In these patients, it is not you can't label them as a pure gastroparesis. So they have got a pan GI involvement.
Yeah, speak into the mic actually.
So they have got a pan involvement. So if you are looking at evaluation of these patients, you have got studies like the scintigraphy, in which you can do a whole bowel scintigraphy, in which they look at both the gastric emptying, small bowel emptying, as well as the colonic. Other thing what I told was what we can use is the wireless capsule, motility capsule. That's a smart pill, because this will also give us a clear indication of where it is delayed. So these are the main things which can be used for evaluation.
Now, as far as etiology is concerned, how do you?
So basically, most of these patients are idiopathic. Most of the studies, almost 40 to 50, as you have told, if you have ruled out the basic causes, then in each sector, like if you can have a differentiation between myopathy as well as neuropathic based on the manometry findings. That can help us. So, but most of these patients, almost most of the studies, 40 to 50% are idiopathics.
You want to say?
Yeah, I want to add two things we must exclude in these patients as secondary causes. One is opioids, which is quite common in North India, particularly in Punjab. Another thing is presence of an underlying tumor, which sometimes declare first as a GI dysmotility, actually not as a tumor per se.
So this was a lady of 40 years and she was from Madhya Pradesh and she was not using opioids. And she had a long history. She's been coming to me for the last 6 or 7 years. In fact, with gastroparesis, she had developed an ulcer and underwent gastrojejunostomy. So how to assess the motility in a patient with gastrojejunostomy was also a problem.
Underlying malignancy and this presenting as a paraneoplastic is less likely.
Yeah.
So we reported a case in 2005, Dr. Ghoshal reported a case where a lady had declared with GI dysmotility. We had an extensive workup of that patient. The case was published. And later, after 6 months, the same lady presented with obstructive jaundice, hilar mass. So here the paraneoplastic manifestation was GI dysmotility 6 months before the actual malignancy. Okay. But in your case, since it is 6 to 8 years, so malignancy should not be going on for 8 years.
Please.
I've been doing colon transit time for a sufficient time now. And one of the most common risk factors for slow transit constipation is use of traditional laxatives. So how do you suggest as a society, we should go ahead with approaching these patients? There's just no work, no guidance. Do we just pick up anything and treat? Do you compare this with opioid like constipation? How should we approach this?
Sanjeev.
If a patient is undergoing a CTT or colonic transit study, ideally 72 hours or at least 72 hours, if not 1 week, all these agents which can either affect the motility in positive or negative ways should be avoided. So your question, that patient has been on laxative abuse for several years.
Yes.
So it is difficult. I agree, it's difficult to stop their laxative even for 1 day. So that's quite an important practical problem. But in case you continue with your laxative, either advertently or inadvertently, your results of CTT is not going to be reliable. That's for sure.
No, it is not during the test. What I'm saying is, I could tell them to stop their laxatives. I could document slow transit till almost 5 days. Now, how do I treat them? Is there any approach
He wants to know the approach to treatment in slow transit.
Yeah, these are so-called, I think, maybe moving towards a colonic inertia. And as I've shown the slides, the drugs like prucalopride, it has also got a limit. In case the clonic transit is too much slow, even prucalopride is not going to work. So there is a need of the top-down approach, which we discussed 2 days back, where we can combine 2 stimulant and enterokinetics agents together. And even when this is not working, then you have to go to the next step.
We don't have work on this in the Indian context. That's why I thought I should bring it up.
Transanal irrigation is an option which has not been exercised very frequently in Indian scenario. That can be used. We do not have the luxury of sacral nerve stimulation and other techniques as of now in India. And of course, surgery remains the last stop.
Of all the available drugs which are there, which are predominantly acting on the stomach as well as on the colon?
Prucalopride is, as I showed, is a double-decker drug. So initially it was launched in 2008, like in a New England study from Dr. Camilleri. So it was used for chronic constipation, good drug, reasonable drug. And now the studies have appeared for functional dyspepsia, particularly the delayed variety, PDS variety. And the same thing now is applicable for even gastroparesis. The recent study from Dr. Jan Tak shows that it is effective. So in case a patient has got both constipation as well as gastroparesis, the go-to drug is prucalopride.
So one more I would like to add, sir, that as you have asked, we have got multiple prokinetics in the market.
Yeah.
So domperidone, metoclopramide, etopride, citalopram, these predominantly act in the upper GI. The only pan-GI what we are having right now is prucalopride.
Yes, there is a question.
My question is to Nitesh. Nitesh, you mentioned a lot of investigations for gastroparesis like EGG, smart capsule. So what are they available in India and what are you using frequently in your
What is the
clinical
gold
practice?
standard?
See, basically what we use is mainly we use scintigraphy. That is the most commonly thing what we are using. We have not used much of wireless capsule. We do not have that.
Is this smart capsule available in India?
Uday, can you take up that? And since you're coming to the mic, do you have a statistics of which is the commonest cause of gastroparesis in the Indian subcontinent?
Yeah,
if there are any studies, can
So
take up that question.
Smart
also.
capsule is not available in India currently. Obviously, if you want, it can be made available with DCGI approval, but it's very expensive, $300 to $400 per capsule. So therefore, I would not recommend it. As Nitesh said, it is a gastric emptying solid, not liquid. Now, Sanjeev has done a lot of work with saline load test, very simple test. So saline load test you can also do. Now, other than that, CTT has been already mentioned. Many of the patients who have pan-GI motility suspected, we do motility study of every part. We do an esophageal manometry, we do a gastric emptying study. In our system, we have electrogastrography, so we do electrogastrography. We use another form of capsule called Atmo capsule. Atmo capsule gives us 3 things. One, it gives us temperature from which we know when capsule entered and when capsule went out of the anus. It gives us pH by which we know that when it entered colon, when it came out of the stomach and went to the duodenum. And it also gives us gas concentration inside the gut by which we diagnose small intestinal bacterial overgrowth. About your question, that what is the commonest cause of gastroparesis. We know India is the diabetic capital. Therefore, that is the commonest cause. After diabetes, it is idiopathic is the most common. And about one more thing, that in constipation, there are no studies on this. Yes, there are multiple studies, including you have a consensus, like even there are randomized controlled trial of tegaserod, which was a colonic prokinetic. So colokinetic include tegaserod, cisapride and procalopride. Of this procalopride we have. So in the patient in which you spoke about, I will combine the drugs which have two different mechanisms of action. I will combine procalopride, which works through serotonergic system, and I will work another which stimulate high amplitude propagated contraction such as bisacodyl or sodium picosulfate. Now the moment you find even if those are not working, the patient need colectomy. So colectomy and underused in India. Many patients who have slow transit constipation, refractory to all these drugs, they really require colectomy.
Still, of all the armamentarium which are available, still only 50% of the patients are satisfied with the medical line of treatment. That was the statement of Michael Camilleri.
Yeah, that's right. Basically, you have to go more. Recently, we have got a G poem done in a patient who was really like pan-GI hypomotility, but she is really doing well after G poem, you know, doctor.
Yeah. So I think we'll have to last two questions.
This is a
Dr.
question
Patnaik
for anyone in the panel. Now, gastric scintigraphy is being talked about so much, but do we have a really standardized technique in India? In South, we use idlis. In North, we may use some egg whites. In Western population, it's something else. So, but we really lack a standardized test, and I would like you to elaborate what do you use in your unit, and second, is there a role or is there a test to look at small intestinal dysmotility in patients with pseudo obstruction?
Basically, if you are looking at Indian series, there is a series from SGPGI by Dr. Gambhir, in whom they have used rotis which were tagged with technetium, and in South normally we use idlis, because basically these have to be cooked with technetium so that it gets tagged to the substrate. So that's the thing what we normally use.
Yeah, Doctor.
Before all these investigations were available, in fact, Shrikant may be remembering that we used to go for barium studies. If there is retained barium in stomach for more than 6 hours, we used to call it gastroparesis. Because as you know, in India, most of the peripheral centers may not be having all these facilities. And how do they diagnose? All patients cannot be managed by the tertiary care center. So do you have any idea on this old technique which can at least suggest that it is a gastroparesis?
I mean, the sensitivity, specificity of this barium is, I think, quite low.
It's the sensitivity is low. I don't remember the exact.
Yeah. So that's the problem with barium, you know. If there are none, I think I should close this session, and I'm thankful to all the participants, those who have initiated the discussion, and thank you so much.
Thank you, sir. Thank you, sir. We now have the lunch break, which will be the lunch will be served at the lawns as yesterday, and we will resume the session at 2 p.m. Thank you. Good afternoon, and welcome back to the session. For the next session on inflammatory bowel disease, may I please invite Dr. Sandeep Pal, Dr. Rajat Shukla, and Dr. Davesh Yadav to please chair this session.
So the first talk will be delivered by Dr. Saurabh Kedia. He is assistant professor at Department of Gastroenterology and Human Nutrition, All India Institute of Medical Sciences, New Delhi. And the topic is thiopurines is still a major role. Dr. Saurabh Kedia, please.
Thank you, sir, and good afternoon, everyone. My sincere thanks to ISG Organizing Committee for this opportunity. And I've been asked to answer this question. Thiopurines in IBD is still a major role. Now, why is this question? So, we look at the timeline of IBD therapy. It started off with the corticosteroids, followed by sulfasalazine and 5-ASA, and then thiopurines, which which were launched for IBD in the early 1980s. And then 1998 was the transition point when infliximab, the first monoclonal antibody for IBD, was launched, and this has been followed by a number of monoclonal antibodies and small molecule agents, which have redefined the therapeutic landscape of IBD. And with the advent of these newer therapies, the questions have been raised on both the efficacy as well as the adverse event profile of azathioprine or thiopurines in inflammatory bowel disease. So the next 10 to 15 minutes, let us revisit the evidence related to the efficacy as well as the side effects of azathioprine or thiopurines in IBD. So the formulations which are there for clinical use include azathioprine, 6-mercaptopurine, and 6-thioguanine, which has a limited use as of now in patients with IBD. And if you look at the indications of thiopurine therapy in IBD, then as a monotherapy, it's used for steroid-dependent ulcerative colitis, and after steroid-induced remission in patients with acute severe ulcerative colitis, used for maintenance of patients with in Crohn's disease, and as also for prevention of postoperative recurrence. And as a combination therapy, it has a definite role in combination with infliximab, a questionable role with adalimumab, and as of now, no definite role with vedolizumab or ustekinumab. For the next part of the talk, will only deal with the role of thiopurine as a monotherapy in IBD. So let us first look at the evidence on the efficacy of thiopurines in IBD. So the two Cochrane reviews on ulcerative colitis as well as Crohn's disease showed that the AZA as well as 6-MP was better than placebo in the maintenance of steroid-free remission. However, they were limited by the small sample size of RCTs, short follow-up duration, bias, and therefore they concluded that larger studies are required for definite conclusions. If we look at the real-world recent evidence on the role of thiopurines in IBD, then two retrospective cohort studies from UK and Netherlands of more than 10,000 and 1,000 patients respectively, which have shown the efficacy and as well as the safety of thiopurine with as long as 16 to 17 years of use, and up to 50% of patients maintain the efficacy over 3 to 5 years of follow-up in both the cohorts, indicating that thiopurines still are efficacious in patients with IBD, although in the UK cohort, the thiopurines were more effective in UC as compared to Crohn's disease. If you look at the Indian evidence, then the study from Ludhiana by Dr. Sood included 150 patients, median follow-up of 18 months, and there was median reduction in steroid frequency, and steroids could be discontinued in 80% of patients, and again up to 50% patients could maintain the efficacy till 4 to 5 years of follow-up. And another study from Ludhiana also showed the efficacy of azathioprine and sulfasalazine combination as compared to sulfasalazine combination alone in maintenance of remission in patients with severe ulcerative colitis. Looking at the evidence from Northern India from AIIMS, we recently compiled our data of about 1,000 patients with a median treatment duration of 120 to 150 months. And again, at 10 years, up to 60 to 70% patients of ulcerative colitis as well as Crohn's disease could maintain the long-term efficacy. Again, in this study also, it was more efficacious in UC as compared to patients with Crohn's disease. Its role in prevention of postoperative recurrence, in the Cochrane review, it was better than placebo in prevention of recurrence. And in the network meta-analysis, the 5-ASA, azathioprine and biologics were efficacious than placebo. Anti-TNF was the most effective agents. So to summarize, azathioprine was more effective than placebo and 5-ASA, less so than infliximab, and could be considered in moderate risk patients. Both the ECO as well as the AGA guidelines suggest that the choice of therapy could either be thiopurine or anti-TNF for prevention of postoperative recurrence of Crohn's disease. Now, is thiopurine an option in patients who have aggressive disease, especially in the resource-constrained areas where biologics cannot be afforded or not an option? So if we look at the evidence in structuring Crohn's disease, then a study from Northern India of more than 100 patients showed that the cumulative probability of maintaining remission without treatment failure at up to 2 years was about 40%, although it dropped down to 20% at 5 years of follow-up, but still a reasonable proportion of patients could maintain only on azathioprine, so could be an option in patients with specializing Crohn's disease as well. In 65 patients with perennial CD, 36 were treated with immunomodulators. Up to 40% patients could achieve a response which was maintained up to 4 years with a relapse rate of less than 40%, and the long-term effect was better than surgery, although less so than infliximab. In patients with steroid refractory acute severe ulcerative colitis, a joint study from Ludhiana and AIIMS of 80 patients who achieved remission after infliximab induction. These patients could sustained remission on azathioprine alone over the follow-up of 6 years, and by 6 years, up to 1/3 of patients could sustain steroid-free remission without any additional dose of infliximab. So this indicates that in aggressive disease such as fistulizing disease, stricturing disease, or steroid-refractory acute severe colitis, thiopurine still have a place if biologics are not an option. Then, does it affect the natural history of IBD? So in the UK cohort study, the patients who tolerated thiopurine and used it for a longer duration had a lower risk of colectomy as compared to the intolerant patients. Similar results in other cohort study published in Gut. Again, the risk of colectomy, hospitalization, and disease progression was lower in azathioprine tolerant as compared to intolerant patients. And in patients with Crohn's disease, this meta-analysis showed that early use of azathioprine was associated with lower risk of progression to surgery. Word about 6-thioguanil. It's an end product of thiopurine metabolism and is option in shunters. I will come into it later. What are shunters and what are how is 6-TG better in this proportion of patients? The dose is up to 20 milligrams per day. In a recent systematic review, TG treatment after AZA6-MP failure showed clinical improvement in up to 2/3 of patients. So now we have discussed that thiopurine still is efficacious on long term and reduces the complication in patients with inflammatory bowel disease. So in patients who don't respond, can we increase the efficacy by optimizing thiopurine therapy? Before going on to it, let us just revise the thiopurine metabolic pathway. So azathioprine is converted to 6-mercaptopurine, which is in 3 routes. It can be converted to 6-MMP by the TPMT enzyme. It can be converted to 6-thiouracil by the xanthine oxidase enzyme. And through the HGPRT pathway, it can be converted into the active metabolite, which are the 6-thioguanine nucleotides. So in patients who don't respond to thiopurine, there could be 2 scenarios. Either the patient is on a lower dose of drug or is a non-adherent, or patient is a shunter, wherein the more 6-mercaptopurine is metabolized to 6-MMP, so less of it is available for conversion to 6-TG, which is the active metabolite, and hence the patients do not respond. So this can be, so how do we optimize the thiopurine dose then? We need to put the patient on optimal dose, which is 2 to 2.5 mg per kg for azathioprine and 1 to 1.5 mg per kg for 6-MP. Although lower dose is effective in Asians, and in the AIM study also, median AZA dose was 1.5 milligrams per kilogram per day. And we can also use therapeutic drug monitoring with the measurement of 2 metabolites, the 6-thioguanine and the 6-MMP. And how do we decide our decision based upon these metabolites? So there could be 4 scenarios based upon this metabolite measurement. So both 6-TGN, and if both 6-MMP and 6-TGN are low, patient is underdosed, so adherence needs to be checked and dose needs to be increased. If the patient's 6-TGN level is low and 6-MMP is high, it indicates that patient is a center. More 6-MP has been metabolized to 6-MMP, so allopurinol can be added, which inhibits the xanthine oxidase and thereby shunts directs the 6-MMP towards the metabolism of 6-TG metabolites. If the 6-TGN levels are normal and 6-MMP levels are low, it indicates that the doses are therapeutic, and if the patient is not responding, the therapy needs to be switched. And if both the levels are high, it means that the drug is supratherapeutic and we need to decrease the dose. After optimizing the therapy and discussion on the optimization of therapy use, a word about the adverse events. So adverse events can be dose dependent, which is myelosuppression, which occurs because of increased 6-TG levels, seen in up to 20 to 30% of patients. Hepatotoxicity, which occurs because of the 6-MMP. It could be idiosyncratic, such as pancreatitis, allergy, and GI upset. And the long-term adverse effects of immunosuppression includes risk of infection and the risk of malignancy. How do we mitigate these adverse events? So the role of pharmacogenomics. So we have already discussed about the thiopurine metabolic pathway. So there are 2 important enzymes, the TPMT and the NUDT15. So low levels of TPMT enzymes, because of the genetic polymorphisms, it direct 6-MMP towards 6-TG pathway, increasing the 6-TGN levels and causing myelosuppression, as well as low levels of NUDT15 will decrease the formation of inactive metabolites of 6-TG-TP, again increasing the 6-TG levels and causing myelotoxicity. Of these genetic polymorphisms, TPMT is more common in Caucasians and NUDT15 is more common in Asians. If you look at again the Indian evidence, 3 studies from India, from AIG, Mumbai, and a meta-analysis by Vishal from PGI Chandigarh, will show that NUDT15 is more frequent than TPMT polymorphisms in South Asian and the Indian population, and is more frequently associated with adverse events. TPMT heterozygotes are seen in about 5 to 7% patients, no homozygotes, and these heterozygotes are not associated with adverse events such as leukopenia, and NUDT50 testing is sufficient in the Indian population. How do we decide? In patients who are homozygotes, azathioprine should be avoided. In heterozygotes, half the dose should be given, and in patients who are null or who have no polymorphism, full dose can be given in these patients. Further, does this pharmacogenomic approach reduce the adverse events? So we have two RCTs from Asia, from Korea and from China, which showed that patients who had NUDT15 genotype guided therapy versus the conventional therapy, the risk of myelosuppression was lower in the intervention group, which received the therapy as per the NUDT15 genetic polymorphism results. How do we mitigate the other adverse events? If the patient has pancreatitis, Aza and 6-MP cannot be given. However, 6-TG can be an option in these patients. Patient with hepatotoxicity, which occurs because of increased 6-MP levels, again, azathioprine allopurinol combination can be given, or 6-TG is an option. And in patients who have GI upset, we can switch between azathioprine and 6-paracapripurine. And this switch approach has also been shown to achieve the response rate up to 50% of patients. The other concern with the long-term azathioprine use is the risk of malignancy. There's a recent ECO guideline on IBD and malignancy was published last month in JCC, which describes the risk of malignancy with all the therapeutic agents in IBD. So with thiopurine, the absolute risk is highest in the elderly. The relative risk is highest in EBV negative young males, and risk increases with the combination therapy. However, is the risk same or lower in Asians? So this retrospective cohort study from AIIMS of more than 1,000 patients showed that myelosuppression was a common adverse event and there was no malignancy. Similarly, in this study from Japan, again, there was no increased risk of lymphoma with the thiopurine therapy regardless of the dose and duration. And the possible reason could be the role of geography and ethnicity, because in a recent meta-analysis, the geographic distribution was associated with the risk of malignancy with the thiopurine use. And in the global epidemiology study of lymphoma, the increased incidence and death rates were one of the lowest in patients from South Asia. So what about withdrawing thiopurines? In this study, the thiopurine withdrawal led to a relapse rate as high as 50% over 5 years of follow-up. Although it was lower in patients with azathioprine use of more than 4 years, but the relapse rate was still there. So if a patient is tolerating azathioprine, is maintaining good remission, azathioprine can be continued. Finally, about the recent advance in the 6-thiogurine therapy. So it has been shown that the gut microbiome metabolizes the 6-TG into active metabolites in the gut. And a recent study from Netherlands showed that the thiopurine suppository as well as enema led to good response without increased 6-TGN levels in patients with ulcerative colitis. So finally, the answer to the question, do thiopurine still have a role in IBD? Both with regards to efficacy and adverse events, yes. The efficacy has been shown to be good on long term. It reduces the complications. It can be an option in aggressive disease, and therapy can be optimized. The adverse events can be reduced with optimal screening, vaccination at possible opportunity, pharmacogenomic approach, and possibly low risk of malignancy in the Asian population. So I would end with these two titles of the two editorials, that with the thiopurine therapy, making new friends should not lose meaning old ones. And with the personalized implementation science and the therapeutic drug monitoring, thiopurine still have a place in IBD. Thank you.
Thank you, Dr. Saurabh. So we'll have the question answers in the end. So may I now invite Dr. Anita Afzali for her talk on expanding IBD medicine cabinet positioning of therapy.
Wonderful. Thank you so much for the course organizers for the invitation to be here today. And so I have been charged with 15 minutes to teach us everything we need to know about how to position all the therapies in the medicine cabinet. So I'm going to walk us through that. Here are my disclosures. So what I'd like to do is I'd like to make sure we highlight both patient as well as disease-related factors when we're determining how and what we would like to select as a treatment strategy for our patients. We're going to review some of these treatment options and then also determine how to appropriately position these therapies. First, I'd like for us to take a step back and recognize anytime we're reaching into that medicine cabinet, we're looking at both drug-related factors as well as patient-related factors. Drug-related factors, of course, we want medications that are safe, that are effective. And then patient-related factors, we want to identify each individual patient's disease, Crohn's disease, ulcerative colitis, what type of disease behavior do they have? And then, of course, do they have extraintestinal manifestations? What's their age, medical comorbidities? We have to look at all of these factors specifically when we're determining what we're going to choose from that medicine cabinet. Now, certainly we know that there are predictors that highlights for us which of our patients are at a higher risk for disease progression. And you can see that younger age of onset or more extensive disease in Crohn's disease, a stricturing penetrating phenotype, or prior surgery places a patient at a higher risk. And similarly for ulcerative colitis, we've identified different factors which places our patients at a higher risk for disease progression. So for both the patients with Crohn's and ulcerative colitis, when we're positioning our therapies, we're looking at these prognostic factors to determine what's the appropriate therapy for particularly the patient with aggressive disease. Now, you're familiar with these different immune biologics that we have as far as the immunologic targets in inflammatory bowel disease, the TNF inhibitors, we have vedolizumab, we have ustekinumab, and then our JAK inhibitors, which are our oral small molecules. And the first oral small molecule was tofacitinib, which I know that is also available here in India as well. Perhaps our most familiarity is with our TNF inhibitors. And unfortunately, the problem is that about a third of patients are primary non-responders to TNF, and about 50% of patients within 1 year's time period will require either dose optimization or changes. And this is probably related majority of the times because of the antibodies or immunogenicity, but then potentially there's other immune pathways that are guiding or leading or driving this inflammatory cascade. This was recently a great article that describes that potentially that's just it. Potentially what has been identified is that tissue signature cytokine specific pathways, and specifically IL-23, might be more specific for gut disease, the bowel disease, as well as the skin disease. So when we're talking about how do we position our therapies, once again, it's important to recognize what type of disease behavior, the prognostic factors, extraintestinal manifestations, and specifically if we're looking at gut and skin, maybe our P19 antibodies or IL-23 antagonists might be the most appropriate pathway when we're selecting therapies. Now, we also know that unfortunately, if a patient has been previously exposed to a TNF, and then we now give them a non-TNF with the older therapies, if you will, whether it's vedolizumab, ustekinumab, or even tofacitinib, what we're finding is that there is a unfortunate decrease in response as compared to the TNF naive patient. So again, when we're positioning therapies, when we're reaching into that medicine cabinet, think twice about why we're reaching in for a TNF agent as compared to a non-TNF, recognizing that potentially the remission and response rate reduces once a patient has been exposed to a TNF agent. So let's look at some of the newer pathways and categories that's in the pipeline or now approved and that we're actually utilizing. I mentioned the JAK inhibitors, the P19 inhibitors, or excuse me, P19 antibodies are your IL-23 antagonists. There's additional anti-trafficking agents in the pipeline. And then we also have the S1P modulators, which is called ozanimod, that we have available. And there's additional ones that are also in the pipeline. Specifically, our P19 antibodies. So you're familiar with ustekinumab, which is an IL-12/23 antagonist. And now we have the P19 antibodies available, risankizumab specifically in the United States and elsewhere, as an option that's more recently been approved for Crohn's disease and also in the pipeline and evaluation for ulcerative colitis. Once again, we're being asked, how do we position the therapy? So when you're reaching into that medicine cabinet, there's several factors that I'd like for all of us to consider. Again, looking at the disease endoscopic severity, the ulcer severity that's happening. Look at biochemical markers, whether it's the CRP, calprotectin, albumin level. Is the patient knocking on the hospital door or are they hospitalized already? These are different types of patients that you will be selecting a different type of therapy perhaps. Likewise for perianal disease, extraintestinal vessel manifestations, and medical comorbidities. So, of course, when we also look at therapies, we know steroids are the worst. They're not safe. But when we're looking at the rest of these therapies, when we're positioning and basing it off of safety alone, vedolizumab, ustekinumab, and risankizumab are likely our safest to date. Ozanimod is probably safe, maybe requires a little bit of additional monitoring. And then our TNFs, upadacitinib is a more selective JAK and potentially a little bit more safer profile, but more longer term studies necessary. And then thiopurines, my colleague just presented on, and then tofacitinib is lower as far as its safety, recognizing that there's been the additional concerns with VTE as well as mortality. So when we look at relative efficacy, that's safety. What about relative efficacy? Now, only 2 completed head-to-head trials have been performed to date. There are more in the pipeline, and we're hoping to publish these here soon, and more to come, of course. Varsity was a comparison of adalimumab compared to vedolizumab for moderate to severe ulcerative colitis, and you can see based off of the primary endpoints and results, vedolizumab was superior to adalimumab for moderate to severe ulcerative colitis. The other head-to-head trial was CVIO, and this was ustekinumab compared to adalimumab in moderate to severe Crohn's disease, and really based off of either clinical remission or steroid-free clinical remission, it was comparable. So these are the 2 head-to-head studies that we have, and more in the pipeline to come. Unfortunately, we talked about safety, we talked about efficacy, but certainly there's additional factors we need to consider, and that is related to patient-specific factors, and also, of course, to access to care, cost, insurance, etc. When we look at patient-specific considerations, again, if there's a higher disease burden, a fixed dose with a subcutaneous biologic may not be ideal, and more of an infusion when you're selecting and positioning your therapies, and you could potentially optimize the dosing of your infusion, potentially that might be more ideal. If a patient has previously failed, or I should say previous medicines have failed them, a TNF, again, as I mentioned, the TNF failure patient predicts a poor response to any of these additional therapies. So bear that in mind. Now, when a patient has medical comorbidities, specifically liver disease or kidney disease, you have to be concerned about the small molecules and maybe not as much with the biologics. And then the comorbid conditions. And so if a patient has inflammatory bowel disease and rheumatoid arthritis, as an example, TNF antagonists and a JAK inhibitor are probably your best options because you're dealing with 2 disease indications and only 1 drug. Psoriasis, as I mentioned, the gut and the skin. So now you're using that pathway of the IL-12 or 23, and so ustekinumab or risankizumab would be appropriate. For someone who has multiple sclerosis or heart disease, again, avoid your TNF antagonist. Someone who has multiple sclerosis, you can consider an S1P modulator, recognizing, again, that's ozanimod, again, for both indications of their bowel disease as well as multiple sclerosis. If a patient has significant cardiac disease, I'd avoid your JAK inhibitors and even potentially your S1P, given the concern for possible conduction delay issues or other issues related to their heart. If a patient has a strong history of smoking, tobacco smoking, we know venous thromboembolism plus smoking is bad because it further increases your risk. So I would encourage you to avoid the JAK inhibitors if you can. So let's take a step back and look at how do we position this all. For that naive patient, not previously been given any therapies, of course, in the United States, we base it off of insurance, but for that severe ulcerative colitis patient that's knocking on that hospital door or already hospitalized, if you can, I would do a JAK inhibitor, upadacitinib or tofacitinib, or infliximab is and these are all my recommendations. We could discuss this at the panel, but I would recommend infliximab in combination with an azathioprine or cyclosporin. For a patient who's an outpatient with moderate to severe disease, not knocking on the hospital door, if they're at greater than the age of 60, I'm not saying that's old, but greater than the age of 60, because we're concerned about medical comorbidities, infection, and cancer, this first line, I would position vedolizumab or ustekinumab monotherapy. And even if they're younger than the age of 60, again, I would position vedolizumab as the most appropriate. For Crohn's disease, greater than 60 years of age, again, I would position risankizumab or ustekinumab and then vedolizumab vedolizumab, and if they're less than 60 years without other medical comorbidities, I would still position risankizumab or ustekinumab. And again, because I'm trying to avoid TNFs, recognizing that their response changes over time. What about that experienced patient, not the naive patient, but now who has previously experienced therapies? Now you have to look at the treatment history and what happened when they were exposed to their prior therapies. If they lost a response to a TNF because of antibodies, switching from, if they've lost a response to a subcutaneous TNF, such as adalimumab, you can consider your infliximab or risankizumab, ustekinumab, upadacitinib, etc. If they've lost a response to infliximab, this is the situation where I would consider a JAK inhibitor as your most appropriate next choice. And then again, recognizing that I don't typically switch in a TNF from an IV to a sub-Q. If they're a primary non-responder, meaning that they didn't develop antibodies, they had therapeutic drug levels, in this situation, I would switch to a JAK inhibitor or UC or RIZA or vedolizumab. What about the naive or experienced patient based off of the scenario, if they have extraintestinal manifestations? Again, if they have extraintestinal manifestations that parallels bowel inflammation, you can really consider any therapy. You control the bowel disease, you control their extraintestinal manifestation. But there are some EIMs that do not parallel bowel disease activity, and in those situations, you would have to find one such as anti-TNF that would be for both or dual indications. For pregnancy, I'm fine with all of your biologics, and I'd be more cautious with your oral small molecules, your JAK inhibitors, and then we need more data with ozanimod. So this is the final slide in a sense of how will we look at specific scenarios. Again, greater than the age of 60, 65, take your pick. Because we're worried about medical comorbidities, infection, malignancy, my go-to in the United States would be risankizumab or ustekinumab or vedolizumab thereafter. Again, a prior history of cancer or lymphoma as listed out there. Pregnancy, I'm fine with all of the biologics. For perianal fistulizing disease, my go-to is still a TNF and infliximab in combination with the thiopurine. For psoriasis, skin disease, gut disease, go with either risankizumab or ustekinumab. For extraintestinal manifestations, arthritis, I would go with either a TNF inhibitor or a JAK inhibitor. Someone who's previously failed a TNF agent, if they have Crohn's disease, in that situation, I would go immediately to risankizumab for Crohn's disease or ustekinumab, then thereafter vedolizumab. If they have ulcerative colitis, I would go with a JAK inhibitor. If they've previously failed a TNF, then vedolizumab or ustekinumab. If you're worried about antibodies, compliance, adherence, maybe choosing an oral small molecule is the right option, because in that situation, you're not worried about immunogenicity or developing antibodies, because that doesn't happen with our oral small molecules. And then there's that HLA-DQA105, which has been associated with telling us that perhaps our patients who are carriers of this are at a higher risk of developing antibodies to the TNF antagonist. So in these patients, potentially avoiding your TNF antagonist altogether would be appropriate, and in which case you would either consider risankizumab, ustekinumab, or vedolizumab. So with that, I thank you for your attention, and I look forward to our panel discussion.
I think we'll keep all the question answers for the end. I'll now request the panelists and the discussant, Dr. Arshdeep Singh, to kindly come and present the cases. Request the panelists, Dr. Simon Travis, Dr. Anita Afzale, Professor Vineet Ahuja, and Dr. Vandana Midha to kindly come up on stage. I think there are only 2 chairs there. 2 of them can join us here. Chair.
Ladies and gentlemen.
So good afternoon, everyone. We'll be discussing one case which we thought that it was a bit difficult to manage. So not wasting much of your time, we'll start. This is a 31-year-old female presented in March 2022 with the increased frequency of stools for 2 weeks, blood mixed in all stools, anorexia, treated at periphery and did not respond to antibiotics. 1 month later, she undergoes a sigmoidoscopy, diagnosed as ulcerative colitis, extent of at least E2 disease, started on oral corticosteroids and 5-ASA. Over the next 2 months, the corticosteroids were tapered and stopped. She was just continued on 5-ASAs. And in July, that is 1 month after stopping of corticosteroids, presented with again increased frequency of stools, blood mixed in all stools, significant weight loss of over 10% in the past 8 weeks, anorexia, low-grade fever, and was admitted to us. So on examination, she had a pulse rate of 98, BP of 110/70, respiratory rate of 16. She was afebrile, anemia was there, abdomen was soft, no distension, bowel sounds were present, and chest and cardiovascular examination was normal. She underwent a nutritional assessment. She had anorexia, weight loss, and complained of fatigue. Her BMI was 17, mid-arm circumference was low, and hand grip strength was also low. The baseline lab investigations revealed anemia, hemoglobin of 8, TLC count was normal, mild thrombocytosis with a platelet count of 4,64,000. The renal functions and electrolytes were normal. ESR was 47, CRP 63, and albumin was low, 2.9. Underwent the X-ray chest. This was normal, and this was the X-ray abdomen, which showed the absence of stool in the colon. The sigmoid colon and the descending colon showed loss of ostrae, and we can appreciate the thumbprints in the transverse colon. So for the residents and the young gastroenterologists, the X-ray abdomen plays a very important role in patients with IBD. It can tell us about the extent of the disease as well, because the diseased segment will not have stool in it. So as we can see that the transverse colon here does not have stool, so we can expect that the extent of disease is E3. She underwent a sigmoidoscopy as per the protocol for clinical suspicion of acute severe ulcerative colitis, and the vascular pattern was completely absent. There was mild luminal bleeding and deep ulcers could be appreciated, giving a UCIS score of 7 and an endoscopic Mayo score of 3. So she was diagnosed as a case of acute severe ulcerative colitis based on the Truelove-Witts criteria. So any patient who presents with acute severe ulcerative colitis is mandatory to undergo a battery of tests, because we need to decide upon the therapy if she doesn't respond to corticosteroids. So CMV was negative. It is a routine test done for workup of infections. The IGRA and tuberculin skin test was negative. Chest X-ray we have seen was normal. The viral markers was negative. EBV IgG was positive. This we do because if EBV IgG is negative, that is a person is seronegative for EBV, thiopurines are contraindicated because primary EBV infection, if occurs, can lead on to development of malignancy, that is lymphomas. So EBV IgG should be done in a patient where we are considering use of thiopurines. The TPMT, NUDT, lipid profile, magnesium, stool tests for infection were negative, but stool C. diff, both GDH and toxin A and B were positive in her, and COVID-19 RT-PCR, which was done because of the hospital protocol during the COVID pandemic, turned out to be positive. So she was shifted to COVID-19 isolation. Enteral nutrition in the form of soft diet from hospital kitchen was started. IV fluids for maintenance of hydration. Corticosteroids, hydrocortisone 6 hourly, 100 milligram intravenously. Low molecular weight heparin for DVT prophylaxis, vancomycin for treatment of C. diff, and GI surgery team was involved. So my first question to panel, Professor Anita, is that what is the diet that you usually prescribe for patients with acute severe ulcerative colitis?
So I think first and foremost, it's important for us to emphasize how ill this patient is and is already ready or should be ready and getting prepared for surgery, a colectomy. Having said that, when we talk about diet, in the past we used to say bowel rest, meaning don't feed them anything and get them prepared for surgery. Now at our organization, we actually do a very short early course of TPN or tube feeds as additional supplement, recognizing that unfortunately patients don't typically or are not able to typically take in much given their bowel distension, discomfort, and pain.
Yeah, so what we practice in our hospital is that we usually give the soft diet orally from the hospital kitchen.
Yeah.
And if the patient is unable to tolerate or there is significant abdominal distension or vomitings or pain, then we move on to the parenteral nutrition. Professor Travis?
So, Ashdeep, I completely agree with Anita that this patient is sick and that you need that. That is absolutely foremost. But of course, if you're going to give parenteral nutrition, you've got to give it safely, and you can't always give it safely. I'm sure you can in Cincinnati, but it's. I think the results of the AIMS study published last year on exclusive enteral nutrition, I think, are encouraging, and certainly we will give enteral nutrition not just from the hospital kitchen, but we will give an oligomeric feed and in order to support the nutrition, bearing in mind that if they come to surgery, you may be on the back foot if they've been undernourished.
Yeah, I agree with Dr. Travis, but I mean, the AIMS study did show that as an adjuvant, exclusive enteral nutrition, if given with steroids, did decrease the corticosteroid failure rate. But in our experience, we have tried this exclusive enteral nutrition, but the semi-elemental formulas, it is very difficult for patient to tolerate at times. So tolerability and acceptability by the patient again remains one issue.
Yeah, it's a very fair comment. Although they must have good dietitians at AIMS, because your withdrawal rate, I think, was only 3 out of the patients randomized to the enteral nutrition in the 62 patients.
Yeah. So moving on, we have discussed the importance of doing a good nutritional assessment and providing good nutritional support to this patient admitted with acute severe UC. So this patient also had concomitant C. diff infection, that is Clostridioides difficile infection. So Professor Vanna, how commonly do you see CDI in association with ulcerative colitis, especially the patients who present with acute flares?
Well, this is a very pertinent question, and we all know that there is enough evidence that CDI is increasing in patients with IBD. I would like to share the experience from our center that we have been seeing increasing prevalence of CDI in these patients, and over the last 1.5 years, in 110 patients we looked into, the infection, both GDH positivity as well as toxin A and B positivity, was seen in as high as 21 patients, amounting to about 19%. So which is significant. And I think majority of the studies from our country, except for 1 or 2, have shown a prevalence varying from 8% to 20% as far as CDI is concerned. But the take-home message, what I would like to say is that the soft stool, it should be immediately sent to the microbiology lab for examination, because the delay would cause a falsely negative test in these patients.
Yeah, we used to have a lot of C. diff in the UK, and we audited our acute severe colitis probably almost 10 years ago. It was 13%. It's almost vanished now. And so when last week we looked, it was only 3%. So we have, that is due to a massive effort on the hospital authorities of trying to reduce C. diff. And but the point you make, Vandana, about if you've got C. diff and acute severe colitis, the outcome is worse. Therefore, you've got to be on the ball, and you've got to be on the front foot as far as treatment is concerned.
And really emphasizing the importance that it's okay to treat both the infection as well as the bowel disease.
Yeah. So the message here is that what we have seen over the last 3 years is that C. diff incidence is increasing in acute severe ulcerative colitis, and it should be checked in all the patients who are hospitalized with acute severe UC. So for these residents, the testing of and diagnosis of C. diff involves doing a sensitive test initially, which could be a GDH or a NAT. And if any of these is positive, then we go on to the testing for toxins. So if toxin is then present, then the patient is diagnosed to have CDI. And there are now commercially available kits which do both the GDH and the toxin in the same sitting, which is available at institute. And the turnaround time is also 1 day. So you get a quick results with those kits. Regarding the point raised by Professor Anita that we need to treat both C. diff as well as treat for ulcerative colitis in these patients. So moving on to the patient, started on corticosteroids and vancomycin. Day 3, the histology is available. We can see there are changes of chronicity. There is cryptitis with crypt abscess. The crypt architecture is distorted. Pseudomembranes were not appreciated, though the patient was positive for C. diff. There are no viral inclusion bodies, and IHC for CMV and Eberish. The CMV was negative, and Eberish showed 2 cells
So, Ashley,
positive.
what on earth? I mean, yes, you're looking at it, it's Epstein-Barr virus.
Yeah.
Why are you checking for Epstein-Barr virus?
So this has been the protocol over last 6 months to 1 year at our place. We are actually looking into the prevalence of EBV in the biopsies, and we are trying to correlate whether EBV colitis is leading on to the
That's
clinic.
interesting. I thought it might be something to do with azathioprine, but that
Yeah, no.
I'm educated. Thank you.
So, in brief, the patient had acute severe ulcerative colitis. Day 3, her stool frequency decreased to 8. CRP was 49. Fecal calprotectin was 880. Day 5, stool frequency again got up to 10. CRP was 48. There was mild abdominal distension. We got the potassium level, which came out to be 3.2. The abdominal X-ray done again showed thumbprinting, but the point here is this loop of small bowel which appears to be dilated and a small loop over here. So if you see dilatation of small bowel on X-ray in a patient with acute severe ulcerative colitis, it is indicative of impending megacolon. So in view of this X-ray finding, impending megacolon, we planned for rescue therapy. And these are the corticosteroid refractoriness indices that we use. The Oxford index is the Professor Travis was the pioneer behind this, and if the stool frequency is more than 8 on day 3 or between 3 to 8 and CRP of more than 45, there is 85% positive predictive value for colectomy. The Ames index, baseline UCIS of more than 6 and a calprotectin of more than 1000 on day 3 was 100% predictive of colectomy. And then there are Lindgren index and Hose index, which also predict the corticosteroid responsiveness. So Professor Travis, this patient is corticosteroid refractory. She needs a rescue therapy. So what do you think would be the most appropriate therapy for her, considering she is positive for both COVID and C. diff?
Thank you. My question, if I can return it, is what are you waiting for? You're day 5. Why weren't you thinking and acting on day 3? But that's leave that to one side because we're where we are. So what would I choose? You've got a choice between cyclosporin, infliximab, and tofacitinib. And okay, tacrolimus. Thank you, Ashdeep. If you really, I know you use it a bit here. I must say we don't in the UK because it's another calcineurin inhibitor, a bit like cyclosporin. But the advantage of cyclosporin is that it gets out of the system early, and if she comes to colectomy, which she could very well come to colectomy, you've got an ileus there as well as incipient megacolon, and I haven't measured the transverse diameter, then I personally would favor cyclosporin in these circumstances rather than infliximab. But I think that the reason for not avoiding infliximab, she's got hypoalbuminemia. Okay, you give a bigger dose, but it hangs around in the circulation for weeks, and there's a 25% complication rate after emergency colectomy if she comes to surgery. And if you look at the 2 randomized controlled trials of cyclosporin versus infliximab, they were identical in short and long-term outcomes with no difference in adverse events. So personally, I would have gone for cyclosporin in these circumstances.
Professor Anita?
Yeah, I would agree as well in the sense of
I would agree as well. Cyclosporin, again, looking at oral small molecules because of the absorptive capacity, you need drug in the system fast. And I don't know, access to your JAK inhibitors here, such as tofacitinib or even upadacitinib, would be a consideration.
But you would need to have a strategy for maintenance therapy thereafter. And one of the things which hasn't come up is the cyclosporin followed by vedolizumab strategy, which I must say we've used to success in Oxford.
Yeah, so the point is well taken that cyclosporin is a good option for patients in whom we are contemplating that a surgery may be required, but she was positive for COVID-19.
Dr. Arshdeep, may I interrupt just for a minute? I think outside there were 2 cases listed, and this is only your name in the booklet. So, are you going to continue?
Yeah, it's only one case which we are taking.
Fine, thanks.
So this patient had a concomitant COVID-19 infection, and as per the guidelines that were laid down during the COVID pandemic, that our patient, this is the first line medical therapy, received intravenous corticosteroids, but as a rescue therapy, patient with COVID without pulmonary symptoms, the cyclosporin is actually not recommended, and the recommendations are for continuation of corticosteroids, but we give infliximab as the rescue therapy. So just a brief word about the COVID vaccine response based on the IBD treatments. And for both the mRNA and the adenoviral vaccines, it has been shown that though seroconversion occurs, but the antibody titers are low in patients who receive anti-TNFs and JAK inhibitors. So what we did in this patient was we gave her infliximab, 7 milligram per kg, responded to infliximab by day 10, and she was discharged on azathioprine with a dose of 25 milligrams and planned to gradually build up the dose. She received the infliximab induction infusions at week 2 and week 6. So why we gave a slightly higher dose? There are 2 strategies to optimize the dose of infliximab. One is the dose augmentation. That is, in patients who have hypoalbuminemia, you give a higher dose of 10 milligrams per kg. And the other is the dose acceleration. That is, the second infusion is given before week 2, or you complete all the 3 doses within the 3 weeks, within 21 days. So these are the 2 strategies to optimize the infliximab dose, and we gave a dose of slightly higher, that is 7 milligram per kg. So to summarize, in March she was diagnosed as, she had onset of symptoms, April diagnosed as ulcerative colitis, responded to corticosteroids, July again presented with worsening of symptoms, diagnosed as acute severe ulcerative colitis, which was corticosteroid refractory, received infliximab as rescue therapy, and in August she completed the infliximab induction regime and was in symptomatic remission. So that was not the end of the story. In September, though her GI symptoms were under control, her partial mu score was 0. She was on 5-ASA and azathioprine. She had gained 1 kg of weight, but she presented with high-grade fever, chills, night sweats, and cough with expectoration. The chest X-ray showed a small opacity in the right upper lobe. CT chest done showed lobulated nodular lesion with breakdown and cavitation in the right upper lobe. Her sputum was positive for acid-fast bacilli, and we diagnosed her as reactivation of pulmonary tuberculosis, and she was started on antitubercular therapy.
Do you think that would have happened if she had received cyclosporin? I don't know the answer, to be honest with you, but you've got much more experience about TB than I have.
Tuberculosis with cyclosporin is not actually reported. The risk is with anti-TNFs because the granulomas that contain the bacilli.
No, I understand that about the infliximab. But if she had received cyclosporin, do you think that she would have had, she would have acquired TB?
Less likely to acquire tuberculosis. But actually, this is whether it is a reactivation or it is a new infection. That's a question we cannot answer actually. So this patient underwent screening for tuberculosis at baseline. We did a chest X-ray, we got an IGRA and a tuberculin skin test both, but still went on to develop reactivation of tuberculosis. So my question to Professor Anita and Professor Vanna, because we like to have viewpoints from East and West both, that do you use a CT chest as a screening tool before starting biologics?
So we don't in the United States, and again, we're looking at the risk, and in high risk endemic areas, certainly that would be potentially a consideration, but not something that we use. Now, serial, likewise with the serial testing, also we don't unless they have risk factors, exposure, institutionalized, recent travels or ongoing travels, that we would check the IGRA as well.
Professor Vanna?
I agree with Dr. Anita. As far as the serial IGRA is concerned, even in our center and even in our country, we are not using serial IGRA. As far as the serial IGRA is concerned, it would be of relevance only if there is negative IGRA prior to the initiation of anti-TNF. And there are no specific recommendations as to how frequently and how much time we need to do it. So practically at our center, we are not following it. Even for CT chest, as far as CT is concerned, the protocol, what we follow for diagnosis of latent tuberculosis, apart from history, the past history of TB or a close contact with a TB patient, it is the concomitant TST, the tuberculin skin test, MON2 test, as well as the chest X-ray and IGRA test. But as far as CT is concerned, only in conditions of high index of suspicion that it is being done. We are not regularly doing it as of now.
And Anita, do you worry about histoplasmosis in Cincinnati?
I've definitely learned about that and have checked and worry about that. I didn't in the West Coast, but in the Midwest I do with histoplasmosis, your fungal infections.
So just a brief word about infliximab-induced tuberculosis. The first report from our country was published in 2017 with 3 centers, and out of 80 patients who received infliximab, 7 developed tuberculosis, that is 8%, and approximately 40% of these patients had extrapulmonary or disseminated disease. This is a systematic review from Professor Vineet's group, and they found that the burden of tuberculosis was independent of the disease and the treatment type, but it was dependent on the local burden of the tuberculosis. So higher the endemicity of tuberculosis, the greater the risks of developing tuberculosis on infliximab. CT test has been proposed as a criteria for screening for latent tuberculosis before starting anti-TNFs. This is again from Dr. Vineet's group, and where they found that if CT was regularly incorporated into the screening, more number of patients were picked up as latent tuberculosis, they were treated, and the ultimate rates of developing tuberculosis on infliximab were lower. But again, even if CT was done, like in this study, again from the AIMS group, even if CT was done, more than 80% of the patients ultimately went on to develop tuberculosis, even if the CT test was negative. So a question which we were discussing, whether it is reactivation or a new infection because we live in a tubercular endemic region, is a question that we don't know the answer to. The Asian guidelines recommend that in patients who don't have any history of tuberculosis in past or contact with tuberculosis, with a normal chest X-ray, we do a either test positive strategy, that is either do a TST or an IGRA, and if any one of these is positive, you take them as latent tuberculosis and treat. But mind you, IGRA has to be done before the tuberculin skin test for accurate results. Again, for serial monitoring of IGRA, the maximum conversion rate is seen during the first year of therapy, but there are no recommendations on how frequently to do and how long do we follow these patients. So she was started on 4-drug ATT, but 1 week after starting ATT, she developed nausea, found to have ATT-induced hepatitis. The ATT was modified. 3 weeks later, her liver enzymes were normal and isoniazid was reintroduced. And throughout this month of September, her bowel symptoms were under control with a partial Mayo score of 0. That is still not the end of the story, because in October, Though her bowel symptoms were under control, but she presented with severe pain and swelling in the left leg and buttock. We hospitalized her with the clinical suspicion of DVT, which was confirmed on the Doppler study, and we treated her for deep vein thrombus of the lower limbs with low molecular weight heparin for 10 days, and then maintained on DOAX dabigatran for 150 milligram twice daily. So, Professor Travis, this patient we mentioned received DVT prophylaxis during her hospitalization for acute severe UC, but still went on to develop DVT. So, could we have done anything different to prevent this episode?
Yes. Extended thromboprophylaxis after discharge would have been a reasonable decision. When this happened to me about 8 or 9 years ago, I set up a study with a research fellow looking at the doing thrombophilic screening on platelet function using ROTEM at serial intervals after patients were admitted with acute severe colitis, and their prothrombotic state lasted for 6 weeks after discharge. So our practice now is to give extended thromboprophylaxis, not obviously give every patient thromboprophylaxis, but extend it after discharge in patients who've had a particularly severe episode, who've had surgery, or who have had a previous episode of DVT. What's a little bit unusual about this lady, who's 39, is that there was no previous history that you mentioned, and it's 2 months after she was discharged, but I suppose she'd also had the TB as well. So I think it was it's a difficult call, but we will give low molecular weight heparin for 6 weeks after discharge.
I believe that even the presence of COVID, one needs to keep that in mind. That's a prothrombotic.
Thank you, Vandana. Very, very, very important point.
So patients with IBD are at increased risk for venous thromboembolism, and inflammation per se is a major risk factor. Active disease, extensive disease, use of corticosteroids, and malnutrition all are risk factors. The international consensus recommends that any patient with IBD who gets admitted should receive DVT prophylaxis, and patients who are managed on outpatient basis, if they have risk factors, should be treated with anticoagulation. And duration of anticoagulation is variable depending upon the clinical presentation. Regarding the extended prophylaxis, as Professor Travis said, so there have been identification of few risk factors which warrant that prophylaxis for VTE should be extended for at least up to 8 weeks after discharge. And these include C. diff index admission, longer hospital stay more than 7 days, ICU admission, previous thromboembolism, comorbid illness, and COVID-19. So this was the last follow-up of the patient in December. She is in symptomatic remission with a partial mu score of 0. She is continued on 5-ASA and thiopurines. Her liver function tests are normal on modified ATT. Her swelling and pain in the left leg have decreased, and the ultrasound Doppler shows that there is partial recanalization of the popliteal vein. She is continuing on anticoagulation. Professor Travis, now this patient is currently in symptomatic remission, but she had a very severe disease to begin with. So what are the chances that she'll likely to relapse, because she's just on 5-ASA and azathioprine? And in case she relapses, what would be the best treatment for her?
I have to say that, well, our work shows that after admission with one episode of acute severe colitis, you've got a 36% chance of being readmitted, and you have a lifetime colectomy risk of 40%. That's enough for me to keep the optimal therapy long term. And I don't think that 5-ASA and azathioprine is optimal therapy. I believe that, yes, I would have continued anti-TNF therapy. Appreciate there are cost issues, but then you had the TB, and therefore in this patient, I have to say I would opt for an anti-integrin and vedolizumab, because I think the risks of her relapsing are high, and a further episode of acute severe colitis, then she is likely to lose her colon.
Professor Anita?
I agree.
Or TOFA, except you can't use TOFA because she's had a DVT.
Yeah, and tuberculosis also.
Dr. Asdeep, was she vaccinated for COVID-19?
Was the patient vaccinated prior for COVID-19?
Yeah, she had received 2 doses of vaccine at that time.
Can it be vaccine-induced thrombosis, vaccine VITT?
Could be a possibility, but she also had COVID-19 RT-PCR again positive during the admission. So we cannot ignore the vaccine-induced.
How much time? When she was vaccinated before thrombosis, development of thrombosis?
I am not sure of the exact time, but she was
This is an
vaccinated.
important history to take the vaccination history because after a few days or few weeks, patient can develop, I think, VITT, vaccine-induced thrombocytopenic thrombosis.
Yeah, but definitely she was vaccinated before March because since March she has not received any of the treatments or vaccines for COVID because she was busy with her ulcerative colitis. So to summarize, the key learnings for all of us are early recognition and hospitalization of patients with acute severe UC is very important. Look for precipitating factors, especially C. diff, which is upcoming in a big way. Focus on nutritional therapy. Optimized timing and dosing of rescue therapy. Infliximab is safe in COVID. Always think of tuberculosis reactivation in patients with TNFs. What we practice is that any fever which occurs in a patient on anti-TNFs, we look out for tuberculosis until and unless we are sure that tuberculosis is not present. And do not forget prophylaxis for DVT. And in high-risk patients, please give a prolonged prophylaxis. Thank you.
Thank you, Dr. Arshdeep, and thanks to our esteemed panelists. I don't think we have time for any question answers because it's already 3 o'clock and time for the next session. Anybody from the organizers, will they permit us a question or two? I think we will close the session and thanks once again for active participation of everyone.
Thank you so much. For the next session on pediatric gastroenterology, may I please invite Dr. S.K. Yacha, Dr. Subhamoy Das, Dr. Sadhna Lal, and Dr. Sajan Agarwal to please chair this session.
Audience. So before wasting time, we are starting the session. So the first topic is in session is transition of care from pediatric to adult. And the speaker is very well known, Madam Anshu Srivastava. She's a professor in pediatric gastroenterology in SGPGI Lucknow.
Thank you, Chairperson. The topic allocated to me is transition of care from pediatric to adult. And what I would like to highlight here is that transfer of care and transition of care are two different things. Transfer is a purely administrative action that once the person is more than 18 years, he moves from the pediatrician to the internist, whereas transition of care is a purposeful, planned movement of adolescent and young adults who have got chronic physical or medical conditions from a child-centered healthcare system to an adult-centered healthcare system. And this is a very important milestone for the patient, the families, their carers, and as well as the healthcare professionals. Why do we need transition? We need transition because if you look at it, the number of publications over the last 10 years have increased drastically. And despite all the guidelines coming up from the West, even in the West, only 1 in 6 children with special healthcare needs get recommended transition. And in India, there are hardly any publications on transition of care. Our average life expectancy as of 2022 is 67 years, and India has got the largest pool of adolescents of 253 million, which is 1/5 of our population. And we need that the children now who are surviving with better pediatric care, they need to be transitioned on to the adult side so that they can be looked after better. We need to invest in the health of our youth and we ensure that they become healthy, productive adults. Are we ready for it? Yes. There is an increase in the number of the training programs in pediatric gastro. Every year now we have around 35 trained pediatric gastro people who are passing out, and all over the country now there are liver transplant centers. And most of the children who have got chronic GI and liver diseases are being looked after by the pediatric gastroenterologist and hepatologist. And there is an adequate mass of people who are now transitioning, becoming 18, 19, 20 years, and we want our adult colleagues to take over the care of them so that they can be looked after better and their outcome can be improved. As we all know that the pediatric and adult clinics are very different. This is a study which showed that the average frequency of visits in the pediatric clinic was every 2 to 3 months in most of the children, and they were requiring a much longer time in the individual visits as compared to the adult clinics. And the objective is that we have to create independent young adults who are capable of living with their chronic condition and making informed decisions about their health. We all know that adolescence, which literally means to grow up, and that's a period of 10 to 19 years, whereas youth is 15 to 24. And this is a very challenging period because here there is higher mortality, much higher than the younger ones. There is a higher rates of substance abuse, mental disorders, risk-taking, impulsive behavior, and a desire to take decisions for your own and independence. We have all witnessed this in our homes, in our children. And so add on to that the burden of a chronic illness, which the child has been born with, like a biliary atresia, and now he's 20 years of age. Many of these children with chronic illnesses have cognitive and developmental delay, they have poor scholastic performance, they have emotional, physical, mental issues, they have poor body image because of drugs, because of surgeries, because of various other things, and they have career and partnership related concerns. So there is a conflict of timing. Overall, the adolescent wants a carefree, independent, risk-taking life. On top of it, there is stress and limitations of having a life with chronic illness. And we are transitioning them to the adult side where we expect them to be responsible, be accountable, adhere to their medication, listen to the advice which are given. So this timing is very crucial, and that is why there is no fixed age at which the transition of care is recommended. This age is specific to each person. It is ideally between 18 to 21 of years, but it is determined by the physical and emotional maturity, the disease activity, and when the pediatric caregiver feels that the child is in an emotional, physical state, that his care can be transitioned over to the adult side. And all of us, there are 4 important groups of people who are responsible for a proper transition. This is the patient, the parent, the pediatrician, and the adult physician. The most important for the parents is that they need to let go, they have to step back because they are so involved in the care that they can't think that the child would be able to, or the adolescent would be able to look after his own care and take his own decisions. We pediatricians have to educate our patients the moment they start going into 15, 16, 14 years of age, and we have to find a suitable physician who's willing to take on to the care. From the adult physicians, we expect that they are willing to accept, they are willing to invest the extra amount of time which is required by these people to answer their questions and also to educate themselves regarding management. And from the patient, we expect that they assume responsibility and learn and adhere. So the recommendations for a proper transition are that first we have to prepare the patient and the family. This whole process will take about 1 to 3 years. Then we have joint clinics by the pediatric and the adult side, and then we transition to the adult care. And mind you, we have to ensure that whenever we are transitioning, the disease should be in remission. We should never do a transition during hospitalization or surgery when the patient is sick. And whenever we are transitioning, there should be emergency plans, and the patient should not be left to fend for himself or herself. The transition document should be detailed and it should have all the records of the patient. And for this is my thought process that the chronic GI and liver diseases can be grossly grouped into 4 things. One is a group of diseases which are diagnosed only by the pediatric counterpart, like biliary atresia, progressive familial intrahepatic cholestasis, galactosemia, various other metabolic liver diseases, where the physicians need to be, adult physicians need to be educated for the unique issues of management. Then there are a group of disorders which are diagnosed mostly in the adult, but some in children. The prime is IBD, where we know roughly about 1 in 5 is a pediatric patient. And we expect our adult counterparts to know about the very early onset IBD and the monogenic IBD and the unique issues. Third group of disorders are those which are diagnosed across all ages and they have similar management. And fourth is a unique group like pseudo-obstruction, intestinal failure, which are really rare diseases and they require specific care and guidelines to be followed, whether we are managing them as pediatric or as an adult GI person. And that is why there are multiple guidelines now. This is the combined ESPHGAN and EASL guidelines for transition of the youth with liver disease. And as you can see, the prime example is a biliary atresia. We all know that now with successful Kasai, roughly about 30% of biliary atresia is surviving with native liver. And this was a very interesting article which titles Delay in Liver Transplantation Referral for Adolescents with Biliary Atresia, Transitioning to Adult Care, a Slippery Slope. There are multiple studies which have shown that the adult listing criteria are not applicable to this group of adolescents with biliary atresia. And that is why the patients, when they are listed by the adult transplant team, they wait longer, they become much sicker, they require ICU admissions. Rather, some of them have gone ahead and said that adolescent BAs should be considered for liver transplant prior to transitioning because their care is missed upon and these children land up with a poorer outcome. Even in the post-liver transplant, there is a high risk of non-adherence to medication in this age group, and this has been significantly associated with alcohol consumption, increased risk of chronic rejection and graft loss, and the anxiety, loneliness, and negative thoughts are much more in this age group of 17 to 25 with chronic illnesses as compared to others. And transition programs, in fact, have been shown to increase the medication adherence in liver transplant recipients. So we don't want that a child who has been transplanted at 2 years of age is doing very well. We shift him to the adult side for care, and at 25 years, he becomes non-adherent and loses his graft. This is what we don't want, and so we have to make efforts. Celiac disease, we are faring very poorly. Only about 1 in 3 patients are basically enrolling into the adult GI clinics. Studies have shown that 86% females and 20% of the males had iron deficiency. 1/3 were osteopenic when the children were followed up into adulthood. And this highlights a failure of the health services after transition. In fact, the Prague Consensus Report has given certain guidelines about how to follow up these children. Similarly, we all know that in IBD also there are specific issues. We know that pediatric IBD is more extensive. We know these children have body image issues, which could be steroid induced, which could be because of the ostomies. There are unique problems of the monogenic IBDs in terms of complications, and various other things are there for which we need a person who's ready to take on the care of these children and provide the optimal advice. So the general advice which needs to be a part and parcel of the adolescent and young adults is that they need appropriate education about contraception, sexual education, vaccination, including human papillomavirus. If they are sexually active and it's not mandatory, to avoid teratogenic medications, education regarding smoking, drugs, alcohol, especially in the NAFLD and CLD, looking after their bone health and vitamin D status, and educated them about the higher risk of malignancy. Obviously, the advice about transition would be specific to the condition, the GI or the liver condition which the child is having, but I can't go into detail about individual cases, but this is an overall general advice which all of these adolescent and young adults need to be given. So the possible solutions are that because Indian healthcare system does not have all the components like a Western healthcare system of a multi-speciality psychologist, transplant coordinator, supporter available. So we need to define our minimum strategy which we need to have. We need to have an emphasis on adolescent health in the pediatric training. We need to have a region-wise network of adult and pediatric providers like gastroenterologists, hepatologists, surgeons, genetic counselors, psychologists, so that if someone sitting in a city of Indore wants to refer a biliary atresia to an adult hepatologist, he should at least know who are the people who are interested, who are the keen, how to contact them. It's easier for us in the academic sector where we have the pediatric and the adult GI part just sitting across on one floor. But in the private sector, it would become much more difficult for the people. We need to have an awareness and a practical disease-specific guidelines for diseases which have onset in childhood. The transition or the young adult clinics are a very good way to go around for patients with complex issues, because we can have group sessions there which can encourage learning and self-efficacy. And the support groups like a celiac support group, the biliary atresia support group, these resources can be called on to educate these young adults, to provide them resources and directions. And nowadays, even online resources and telemedicine can be used to educate these and to plan their visits as per the convenience, because we have to know that these are children who are going to colleges, who are pursuing education, who are writing entry exams. So there is a lot of things which are going on in the life of these children, and to provide them the optimal care, we have to really work with them. And we have to identify the patients who are at risk, like those who have got a developmental delay or those who do not have adequate support, whether it is financial or family. These are the children where we have to go an extra step and provide with them resources which could be regular counseling or telephone availability. So to conclude, I would like to say that transition is not synonymous with transfer of care. A good transition helps improve the outcome of children with chronic diseases. And India is now in a state that we need to have transition clinics. We have adequate amount of pediatric and adult GI and hepatologists who are working across the country. And we need to, both pediatricians and adult physicians need to gear up and start the transition services at their hospitals and clinics. And the ISFGAN, which is the pediatric gastroenterology, and the ISG and the liver, that is INSL, they need to come together, they create awareness, educate and provide support about the transition, because we need to have young, healthy young adults if we want our country to progress anywhere. So together, I think we can, and we can improve the healthcare of our children. Thank you very much.
Thank you, ma'am. I think we will take the questions at the end of session.
So the next talk on the functional GI disorder in the children by Dr. Ujjwal Poddar. Sir is Professor and Head Department of Pediatric Gastroenterology in SGPGI. Over to you, sir.
Thank you, Sajjan. Thank you, Shubhamoy. At the onset, I must thank the organizer for giving me this opportunity. I've been asked to cover the functional GI disorders in children. It's a huge topic. I'll try to concise it in next 14 minutes or so. Then about nomenclature, there is a little bit of difference between adult and pediatric functional GI disorder. As per the Rome 4, in pediatric we have 4 categories. Functional dyspepsia, we don't call it non-ulcer dyspepsia. That is the difference. IBS is IBS, same as in adults. We have a unique entity called abdominal migraine, which is commonly seen in children, not in adults. And the 4th category is basically when it is not fitting with either of these 3 of IBS, functional dyspepsia or abdominal migraine, then you call it FAP, functional abdominal pain, not otherwise specified. So I'll just discuss those which are not commonly covered in adult. Abdominal migraine is basically a severe pain abdomen. When a child is coming to you like an acute abdomen, you thought it could be appendicitis, it could be pancreatitis, it could be a perforation of the viscus, but you are not getting any of this. Then you think about, and this has to be a recurrent episode. They see the criteria, paroxysmal episode, at least 2 in last 6 months, with the intense, acute, the midline pain. It is, and then there is a gap, absolutely normal period, which can be weeks to months, and it is the incapacitating pain, the stereotype. Every time this child is coming with a severe periumbilical pain, with vomiting, lasting for 2 to 3 hours, then everything quiet, nothing is happening. that may be associated with one of these, two of these things like anorexia, nausea, vomiting, headache, photophobia, that indicate that they will have some autonomic dysfunction, and usual functional abdominal pain, that appropriate evaluation, the symptom cannot be explained with anything else. Then lastly is that functional abdominal pain, NOS. I want to discuss it because commonly we see this entity. In children, first decade of life, we hardly see abdominal migraine. IBS is less common in first decade, more common in adolescent second decade. Same is true for functional dyspepsia, but most often we see this functional abdominal pain not specified otherwise. Now, how common is the functional abdominal pain? Huge burden. This is the study I quoted from Sri Lanka, is almost like our India. They showed that 12.5% of the school-going children, they studied the 10 to 16 years age group in the questionnaire base. It is 12.5%. Worldwide figure is also 10 to 15% of school-going children, they have functional abdominal pain. And one study from Delhi, again the 10 to 17 years age group, they also found in India also functional abdominal pain is almost 6%. Now, what is the spectrum? This is the spectrum from our center. Over the 2 years, we have seen 516 patients of functional abdominal pain, but our age group is slightly wider, from 5 years to 18 years. If you take only those adolescents, 12 to 18 years, then that will be almost like an adult. You see more of a irritable bowel syndrome. But if you take this younger age group, this tiny kid, they cannot explain properly. So you have more of a functional abdominal pain. They have only pain, not much of bowel syndrome. And they see the 2/3 of our children in our study is functional abdominal pain, not specified otherwise. And rest are IBS or functional dyspepsia. We don't see abdominal migraine often. Now, why there's such a huge number of children are having functional abdominal pain? This is basically that's related to the stress. Now, what is this brain-gut axis plays here? Normally, when there is a pain, it goes mainly via the afferent pathway to the spinal cord, posterior horn of the spinal cord, and some amount to the vagus, and then it goes to the brain, from the thalamus to hypothalamus to the cortex. Now, what brain does with this, when the pain stimulus is reaching the brain, it usually suppresses. It suppresses the innocuous pain at the spinal cord level. So that's why in a normal person, when you have the normal brain function, you will suppress that pain, which is not to be appreciated. But when there is a stress, anxiety, this cerebral inhibition goes off. So what we call is the visceral hyperalgesia. This is applicable to adult as well. So what happened as a result of the visceral hyperalgesia, the small innocuous stimulus, which is not supposed to be perceived as a pain, this child start perceiving as pain. In addition, the stress related, there is hormonal effect, there is increased release of corticotropin releasing factor, and it has the impact on the GIT, and it causes bloating, nausea, cramps, pain, and diarrhea as well. So, in nutshell, what are the factors which plays in the propagation of this functional pain abdomen? It is the stress which plays an important role. Stress may be environmental, like in the family or school. There may be psychological problem. Environmental reinforcement, very important. The parents are more anxious than the child. So this is called the reciprocal anxiety. Child start believing that I am really sick because mother and father are also crying along with him. Secondary gain. First time he had a pain which was real, but subsequently he realized if he has pain, then he was allowed to stay at home with the mother, with prefer food. So for secondary gain, he will then with a small thing, he will start howling, start shouting. And very importantly, modeling. There is some role model in the family. This is called pain-prone family. We tend to take the detailed family history. Some of the adult members will have some of the functional pain disorder, maybe IBS, NUD, dysmenorrhea, or migraine, something or the other. It is a 25%. This figure may be much higher. So that is the family trend. So what will you do when a child comes to you with a suspecting functional pain abdomen? So basically, investigation doesn't help. And Rome 4 criteria has given you the handle. that it should be all functional GI disorder is a positive diagnosis. Don't investigate to rule out organic cause to make a functional. So go with a positive frame of mind. You believe this child is having functional because there is no red flag, means no anorexia, no weight loss, no fever, no bleeding. Pain is absolutely central, not away. Duration is just short duration. And absolutely happy child, make a positive diagnosis. Don't rely that I want to do a CT scan, I want to do an ultrasound, upper GI, lower GI to rule out a organic disease. That doesn't help. So for that you need to spend some time. That is the most difficult part. Recommendation is that you need to spend at least 45 minutes with the child and the family, and then obviously you will rule out any organic disease. And use the red flag. Usual red flag is anorexia, weight loss, blah, blah, blah. But this is very important. A fishing expedition for organic cause is always unproductive. I will do some investigation before you make a diagnosis, it doesn't help. So you limit your investigation to the routine. What you can get the proper information whether this child is having some inflammatory condition, like you are worried about IBD, do a CBC, urinary infection or stone disease common in children, do urine examination and stool local blood to rule out IBD. What about ultrasound? The advantage is that this is a non-invasive, painless, no radiation, and normal ultrasound will give the reassurance. Now, reassurance to who? To the parents or to the doctors? Probably most of the time it is Dr. Me. I want to get a normal ultrasound to say that your child is not having any organic disease. Disadvantage is that this ultrasound may be detrimental. It will pick up something innocuous. There may be a cyst in the kidney, there may be a hemangioma in the liver, or most often is the mesenteric lymph node. That will start the ball rolling. Anxiety factor. Parents are worried. Radiologists are already informed your child is having TB or lymphoma. Now they will continuously get investigation done, and that doesn't help. So mesenteric lymph nodes, very common. Is there any GI inflammation will give rise to lymphadenopathy? When to worry about that? So in this study is shown, even the normal child will also have lymph node. But the size matters. The smaller diameter, not the bigger diameter. Smaller diameter means the short axis is more than 10, then you can think about investigation further. And this meta-analysis has clearly shown H. pylori has no role to play with recurrent abdominal pain. So functional abdominal pain, don't look for H. pylori. Even if it is positive, it will not tell you that this is responsible for functional pain abdomen. Now this is study I have quoted from America. So this retrospective analysis, they have shown how often there is not the us in India, and we are investigating these children with all sorts of. This has shown lab tests that include amylase, lipase, blood test, LFT, everything. Almost 93% of the children who presented there with functional abdominal pain, they got this lab test done. Now what is the hindsight? 1/4 of them had some abnormality. What is this abnormality? Maybe ESR is slightly elevated, or a lymphocyte count is elevated, and you will keep on chasing that. See the imaging, including cross-sectional imaging, ultrasound, CT scan was done almost half of these children. Abnormality found only 5% cases, and that also non-specific abnormality. Endoscopy, gastroenterology, we love doing endoscopy. See in America also, 43% of the children receive endoscopy. That 70% of them upper GI, 30% receive both top and tail, upper GI and colonoscopy before putting a level of functional abdominal pain. Surgery was done in 5 cases, appendectomy commonly done with a normal appendix, cholecystectomy, histopathology normal. So this is not uncommon. So what is the message? Routine testing in functional gastroenterology may not be beneficial at all. Rather, the routine testing invites more tests, add more worry, more anxiety. So where we are? Same, limit your investigation. Treatment part, treatment should be at the fast go. Don't waste this opportunity. If you believe this is functional abdominal pain, don't tell that get this test done, blood test, ultrasound, blah, 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 amylase or fecal calprotectin, then I'll give you the answer. Fast go, explain, this is functional pain abdomen, right? So even if you ask for investigation, say, I can give you guarantee, this investigation will be normal. Since you are so worried, I'm asking for it. But don't give this handle to the parents that he will come back and he lose the faith on you that the doctor didn't know the diagnosis. So be dogmatic and unequivocal in explaining that there is no organic disease. Doctors can easily become a pathogenic agent in the prolongation of the pain once you show the equivocation, okay, it looks like functional, but still I want to get some test done to rule out maybe chronic pancreatitis, maybe gallstone disease, then your equivocation coming and they will lose faith. So explanation and reassurance to the parents is very important. Never say your child is malingering. He is having pain, he does have pain, but you have to explain why using the brain gate axis. His pain threshold is low. That's why he's perceiving pain which is not supposed to be perceived normally. Never say that he's a liar, he's malingering. So harmful stressor you identify, like those I told you, the stress, anxiety, that needs to be modified. Sometimes distracting maneuver helps the child complain only when parents are around and when he'll ask to read some textbook. But when he is playing with his friend, playing with his mobile, he doesn't complain pain. So that is distracting. Reward illness behavior to be stopped. Normal activity. Most of the school absenteeism is very common. They stop going to school, so you restore this the normal activity, and rarely they require hospitalization for timeout. What about the drugs? Functional dyspepsia, you people use the PPI, but our pediatric studies have shown PPI does not help. Even in the EPS type of functional dyspepsia, there is some role of fiber and amitriptyline coming too. This is the study published just a couple of years back, randomized placebo-controlled trial of fiber in IBS, and they showed that 6-week therapy compared to baseline, there is reduction in the pain intensity in this group. See this, the last graph showing reduction of pain frequency is significant with fiber than placebo. Amitriptyline. So far we have two RCTs from US showing one is showing positive response and is showing negative response, small number, shorter duration of therapy. So we did this study. This study is published last year. Efficacy of amitriptyline in pediatric functional abdominal pain, a randomized placebo-controlled trial. See, the 2/3 of the patient are FAP-NOS, some IBS and FD also. We have randomized, given them one amitriptyline, 10 or 25 depending on the weight, and placebo was folic acid. And see the result. Very significant improvement with the amitriptyline. The pain score overall, including the intensity, frequency of duration, this 64% reduction in amitriptyline versus just 14% in placebo, and almost 1/3 of the children, they are cured. They didn't have pain at the end of 3 months trial. And during the COVID time, some of the patients stopped coming, they continue therapy. On continuation of 6 to 9 months of therapy, there is 89% response. So if you extend the amitriptyline from 3 months to 6 months, then response rate is much higher. And after stopping therapy, 70% of them, they are in remission. They didn't have recurrence of pain, 30% of recurrence. So low dose amitriptyline significantly improved pain and quality of life in FAPs, irrespective IBS and FAP-NOS also, no serious side effect. So what happened to these kids? Outcome, this is a very interesting study after 10 years of original diagnosis, just a couple of slides more. They could fish out around, and what they have shown, that 40% of the children, they continued, they graduated as adult with FAP. That means a significant proportion of pediatric gastro follow-up patients, they go to you as an adult, and most of them, they develop IBS. And if they have associated depressive symptom, then their chance of prolongation is higher. So to conclude, functional abdominal pain is very common. Almost 10 to 15% of the school-age children, they do have. Majority are FAP-NOS because the younger age. Detailed history and examination is key to the diagnosis. Investigation does not play a role. Basically, you need to limit yourself, and H. pylori is not associated. Regarding treatment, be dogmatic and unequivocal in explaining that this is there is no organic cause, and successful treatment depends on proper explanation. Fiber helps, and what we've seen that amitriptyline really helps in the refractory cases and need more studies. Thanks for your patient sharing.
Thank you, sir. As I said, we'll take questions at the end of session. So I'll invite the next speaker now, Dr. Rohan Malik. So this will be a very interesting talk after we had a very brainstorming session on IBD in adults. So this is early onset IBD.
Good afternoon. Thank you, chairpersons. It's a little intimidating to speak after Professor Anshu and Dr. Podar, both of whom are my mentors. So the topic was early onset inflammatory bowel disease, and we'll also talk about very early onset inflammatory bowel disease and monogenic inflammatory bowel disease, which for adult gastroenterologists may not always be very early onset IBD. I'll show you some cases. So why should we characterize something? Why should we characterize IBD? Because it will help us to treat or classify patients, study their physiology. So should we classify inflammatory bowel disease according to age? Is it helpful? So if you trace the history of the classifications of IBD, the first classification in Rome used anatomical, operative, and clinical behavior. In Vienna, which was not used very much, was the first time we saw that age was used as a criteria for classifying IBD. And the Montreal classification, which is followed in adults till date, used the A1 less than 16 years for the first time. But this was an arbitrary classification, just meant so that pediatrics could be a separate group and could be studied separately. Also, it applied only to Crohn's disease, not ulcerative colitis. So the Paris modification in 2011 gave some evidence for classifying IBD based on age. And they said A1A is the early onset IBD, that is less than 10 years. And why they said this was both for CD and UC, was children had a different phenotype younger than 10 years of age. They had isolated colitis, they had different serologies, and lower biological use in and surgery in less than 9 years of age. Now, this was all well till 2011. 2014, we now have very early onset inflammatory bowel disease. These are children who are younger than 6 years of age. And in this group of children, especially children who are younger than 2 years, which is called infantile inflammatory bowel disease, you find a subgroup of patients which can vary from 10 to 30%, who have monogenic disease, who have severe disease, have more consanguinity, family history, do not respond to your normal therapies, often require specialized therapy, stem cell therapy, so are a very heterogeneous, difficult to manage group. So now we have early onset inflammatory bowel disease and very early onset inflammatory bowel disease, and we have the whole gamut of inflammatory bowel disease in itself. So what is the difference? Now, pediatric inflammatory bowel disease in itself is different from adult inflammatory bowel disease in certain characteristics of gender and phenotypic distribution, and more pancolitis in pediatric UC. Growth and puberty is a major concern. Most importantly, if you see this landmark study from the EpiMAD registry, children change, the behavior of IBD in children is dynamic. It changes from inflammatory to stricturing and penetrating disease over time. So this is all early onset IBD as a whole. Now, if you look at this group of children, which is less than 6 years of age, which we call as very early onset inflammatory bowel disease, they in itself are a different group from early onset or pediatric inflammatory bowel disease. Mostly you will find that they have predominantly colonic disease. Ileal disease is not so common in this age group. The disease is often extensive. Oftentimes you are not able to classify their disease, whether it is CD or UC. So the incidence of indeterminate colitis or undifferentiated colitis is higher. The younger the patients, the more the family history. Surgical intervention and failure of conventional therapy is higher. And I will say that with a caveat, because I'll show you some data which has been recently published from India and abroad. So as to say that all VO IBD is not bad IBD. I don't want you to have this idea in your head that, oh, child has developed IBD less than 6 years of age, this is going to be complicated disease. One does not mean the other. You can have a fairly mild, very early onset IBD also. So we know the incidence of IBD is increasing worldwide. The highest incidence is in Northern Europe, where the prevalence will almost be 2% soon. So more than celiac disease. And the same is true for inflammatory bowel disease in children, reporting increasing incidence from all areas of the world, highest in Northern Europe, a very high incidence is there. And the early onset group, that is less than 10 years, is the fastest growing group, age group that is developing inflammatory bowel disease. And within these groups, all three classifications, early onset, very early onset, are all increasing in incidence with time. Now here I'll just take a minute to talk about some developments in genomics, which has helped us characterize very early onset IBD. This is fairly routine for a pediatrician or a pediatric gastroenterologist, but I'm aware some of my adult colleagues may not do this very often. So if you remember the good old days when you needed to sequence a gene, you had to send it to your genetist. They did a Sanger sequencing. It would take months, maybe even a year. The cost would be prohibitive. The cost of sequencing the first human genome was around $2 billion. The cost of sequencing your genome today is around 40,000 rupees. So it has been a great change in how quickly and how many samples you can sequence at the same time. And this is called massive parallel sequencing, which is a next generation technique. So you can sequence certain genes, which is called a targeted panel gene sequencing, which is what is available commercially with you. And I'm sure you have these companies that come to you and they'll give you panels for pancreatitis, panels for inflammatory bowel disease, panels for liver disease, which is TPGS. You can sequence the whole exome. That is only coding regions, but as we know, the whole exome is not really does not explain all heritability. So you can also sequence the whole genome very quickly, in a matter of weeks. So after this happened, people realized that there is a subset of inflammatory bowel disease which is not polygenic. Normal IBD is polygenic. There are several SNPs which confer increased susceptibility to disease. Whereas there was a certain group of patients where were monogenic. Only one gene was involved in the causation of inflammatory bowel disease. And as we had this genomic sequencing develop, genomic sequencing then became standard of care in children who are young and who have some predefined criteria, and even in adults who have some suspicious markers, so that you can look for monogenic disease. And this is what we call monogenic inflammatory bowel disease. And this is a beautiful paper published by Bolton from Oxford in gastroenterology recently, where they've assessed 165 conditions. They looked at the DNA, the sequencing. They've looked at RNA expression, gene expression, single-cell RNA expression, which proteins these genes are expressing, and they have tried to work out a pathophysiological basis for the classification of what we call as monogenic inflammatory bowel disease. And they have labeled 102 monogenic inflammatory bowel diseases, and they have also explained the pathophysiology of each of these genes and how they cause inflammatory bowel disease. So this is very interesting from the prism of IBD as such, because we know IBD is polygenic. You have SNPs in various genes which add up to a probability score that then makes you more a propensity score that makes you more liable to have IBD. Whereas if you have monogenic disease, each gene can be teased out and its role in gut immunity can be studied. So you have in this table, you have genes which control mucin production, you have genes which control epithelial cell production, you have phagocytic genes, you have lymphocytic genes, you have endothelial genes. So all of this really gives you an insight into gut immunity and IBD, and is a good model to study these diseases. So looking at monogenic inflammatory bowel disease clinically, now there are some common genes which constitute about 80-85% of these disorders, and others are rarer. So the common genes are, the most common is the interleukin 10, and the Sanjay Gandhi group published a paper recently with a lot of this in them. XIAP, now XIAP you can see in an adult also. You can see with an adult with severe refractory inflammatory bowel disease not responding to therapy might actually have XIAP. Then you have CGD and some other genes. Very common in children with IBD who are less than 2 years, but look at this, 11% of these cases occur in adults over 18 years. So monogenic IBD is not equal to very early onset IBD. It can occur in adults also. Most of these patients have some extraintestinal manifestation. They even have skin disease, they have some autoimmune hematological abnormalities, autoimmune endocrinal abnormalities, HLH, atypical infections. This should prompt you to think of monogenic disorders. And the treatment is quite complicated. In fact, here I would like to say VOIBD the prognosis is determined by the presence of monogenic disease. If there is monogenic disease, higher chance of surgery, biological failure, and need for stem cell transplantation. If there is no monogenic disease, it will behave just like early onset IBD, and there's some data for that. What about children who don't have a monogenic disorder and they don't have a single gene defect, but IBD occurs in a 4-year-old child? How do you explain that? This is a very interesting paper published in Nature recently, and they looked at SNPs in adults with IBD, in children with IBD, very early onset IBD, and controls, and found that adults and children, very early onset children with IBD, had similar SNP scores for developing IBD. So there is a genetic burden that these young children bear, which predisposes them to IBD. Now look at some series of this of very early onset IBD. This is from the UK. Looked at only children younger than 2 years of age. Monogenic disease was 31%, and most of them did not do well. Required extensive immunosuppression, parental nutrition, bone marrow transplantation. This is data from India, published from the Sanjay Gandhi group. Now 200 cases of IBD over 11 years, 24% were very early onset, and out of them 31% were monogenic. IL-10 was the most common, and children with monogenic were younger, had a family history or consanguinity, had more indeterminate colitis, perianal disease, wasting and stunting, and worse response to therapy or death. This is our data from the AIIMS GI clinic over the last 6 odd years. So we had 100 odd patients. Again, 37%, which is similar to the SGPGI data, and 17% were less than 2 years, and genetic defects were seen in 9. Again, IL-10 was most common. Now, this is the paper from Boston Children's Hospital, which is showing a sort of this is the biggest series of children with very early onset IBD. And what is interesting was monogenic disease was much lower than reported in the other series, only 8%, but similar to the UK Oxford and the Canadian series. And what they showed was really very early onset IBD is either monogenic and bad disease, difficult to control, or if it is not monogenic, does not automatically mean that it is severe and bad disease, and these children might just behave as an early onset IBD or a normal IBD. So don't think very early onset IBD is equal to bad disease always. And if you look at the age distribution, very important for adult gastroenterologists, significant percent, 10 to 12% or 1/3 of these cases are occurring after adolescents. A lot of adult gastroenterologists will see adolescent patients and adults. So if you're having a difficult patient, maybe has a family history of IBD, maybe there is some abnormal infection, or he has some autoimmune features, think of getting a genetic sequencing for this patient, because as you see, some disorders causing monogenic disease occur only in adults and not in children. The GUC gene and the Hemans-Podolsky syndrome are important. XIAP, LD syndrome, CGD, all of these can occur in adults. So as I said, VOIBD is not a homogeneous group. And when do you suspect? Young age less than 2 years, or age less than 6 years with family history. If there is an affected family member with monogenic disorders, multiple family members with early onset IBD, consanguinity. If there is autoimmunity, autoimmune hematological disease, endocrinal disease, recurrent infections, HLH, malignancies, then you should think of monogenic IBD. Now, the treatment of monogenic IBD requires multidisciplinary care and is often based on the individual patient. This is a child, 2-year-old child, came to us about 2.5, 3 years ago. She had a rectovaginal fistula, a fistula into her bladder also, severe perianal disease, was not doing well. She had an IL-10 defect. Mother was pregnant. We wanted to do a bone marrow transplant from the fetus. When the second baby was born, it was COVID. We couldn't harvest the cell. So we did a matched unrelated donor hematopoietic stem cell transplant. That's called a MUD transplant. This child is now 1.5 years post her transplant. The colitis has resolved. She had a divergent colostomy, divergent ileostomy, which has been restored. She's on a normal diet. She's on her stem cell transplant immunosuppression, but GI symptoms wise, she's absolutely asymptomatic. So IL-10 defects, if you have a child with IL-10 defects, they do very well on bone marrow transplantation. I believe this would be the first successful bone marrow transplant for IL-10 in India that I am aware of. Similarly, high throughput screen for TTC7A deficiency shows leflunomide, which is used in rheumatology, works well in this disease. XIAP, this is an adult patient, tadakinib or anti-IL-18 works well in these patients. This is an adult patient, I'm just finishing. This is an adult patient who underwent a BMT for his G6 deficiency IBD. So you have a whole list of specific drugs which you can use, and you need a monogenic IBD multidisciplinary team, which can be a national center which should collaborate with international centers for functional validation of the genetics and for enrolling in any therapeutic trials that you can run. So you should coordinate with a national center. Many national centers, Sanjay Gandhi AIIMS, now have funding for doing the exome free of cost. So we can help you in that way. So just to summarize, age of onset less than 10 years defines early onset IBD. These patients have a distinct phenotype of disease. Very early onset is heterogeneous but should prompt assessment for a monogenic disorder. Monogenic disorders can present at any age. Even as an adult gastroenterologist, maybe you will see one. And the response to therapy in early onset, very early onset, is determined by the absence or presence of monogenic disorders. And monogenic IBD requires individual therapy. Thank you so much for your kind attention.
So thank you, Dr. Maulik. Just before you leave, so are you doing a whole exome or a clinical exome?
As part of research, we do whole exome. Clinical exome is available commercially. Whole exome is also available commercially.
Hardly difference is 1,000 rupees.
It's not a difference of cost. The difference is if
you may get some genes which may not be covered.
Yes, so you are in a research setting, you are looking for a new variant. So, and then that interpretation is very biostatistics heavy. You need a special person to do that. So, yes, the cost is the same. But as a clinician who is practicing, if you get a whole exome sequencing and they give you a report variant of unknown significance, really means nothing to you. So you might as well do a TPGS, and then if there is something, send them to a center which is doing this as part of research.
So we'll discuss again at the end of session. So we'll invite our next speaker who needs no introduction, Professor Malti.
Good evening. Thank you, chairpersons, for this giving me this privilege to speak on eosinophilic esophagitis. So the same topic was speaking in 2005 in IGCON, and that time the title was "It is a distinct clinical entity," and this was the paper at that time. And so by 2022-23, now we have a better understanding of the definition, the pathophysiology, the diagnosis and management. So many things have changed over eosinophilic esophagitis. And I would just like to share this case with you, which was actually from Dr. Prashant. He shared it with me. So I'd like to thank, this is a 6-year-old boy from Kerala, actually settled in UAE. Main problem was abdominal pain, upper abdomen, lasting for 6 months, occasionally reflux symptoms. And as like Dr. Podar said, this was a little different pain, but still upper abdomen pain. There were no red flag signs, but there was a family history of allergy to seafood items like prawns and fish. And he was evaluated in UAE, and as he was saying, the first thing which they all do is do an ultrasound, and you just get a report of mesenteric lymphadenitis. What to do? Then he had come over to India, and then he was seen in Sath Hospital in Trivandrum in June 2022. At that time, investigations also not much, and that was the paper he was also quoting. So you do a lot of investigations, but you may not get anything. The only striking feature was an absolute eosinophil count, which was high, IgE was high, and he had a high antibody level for seafood. As usual, you do doctor shopping, and then August 2022, he had to go back to UAE. But before that, though these people had advised endoscopy was done elsewhere. They saw something white plaques, they suspected candidiasis, and as usual, when a child comes to you with abdominal pain, antral biopsy is taken for H. pylori, D2 biopsy taken probably to exclude celiac disease. Nothing much was obtained. He went back, pain continued. He comes back. These were the pictures they had sent. He comes back to India, and at that time back to Trivandrum. And now, when the endoscopy is done, the person, the eye sees what the mind knows, whitish linear patch. Even the description becomes different in the mid and lower esophagus, biopsy taken, and a very good pathologist, beautiful pictures, and you can see the eosinophils, the pink colored cells, more than 100 per high power field, with eosinophilic abscesses. Whenever you have more than four eosinophils in one area, you call it eosinophilic abscesses, and there was eosinophilic degranulation. So now the diagnosis is very obvious. It is eosinophilic esophagitis, and now what to do. So now we have come to what is this eosinophilic esophagitis and how has this definition changed. It is a chronic clinicopathological disorder. So it is a clinicopathological disorder due to a Th2 antigen immune-mediated inflammation. It can affect both children and adults, and in the eosinophil infiltrate, the count is very, very important. The peak eosinophil count should be more than 15 eosinophils per high power field in the absence of other causes of esophageal eosinophilia. So the number is very important, more than 15. So what is the burden of eosinophilic esophagitis in India? Do we have this problem, or are we just talking? It is that in pediatrics, the prevalence is around 29.5 per 100,000, and the incidence varies from 0.7 to 10 per 100,000. But all over the world, the incidence and prevalence is definitely increasing. This is not only because of the awareness, but probably, as we all know, food allergies are also increasing. In number of endoscopy is increasing, and the awareness that a biopsy should be taken is also increasing. So this was documented even in 2012 in a study from where Dr. Thapa and Dr. Sadhna from Chandigarh, where they done the endoscopy for children who had undergone upper GI endoscopy, and they found those who had undergone upper GI endoscopy, EOE was 3.9%, and another study from North India in adults showed that those who had GRD symptoms in adults, prevalence was 3.2%. That means eosinophilic esophagitis does exist in India. Then why is this diagnosis delayed or missed? I thought there were three reasons. One, the clinical manifestations. The clinical manifestations varies with the age, and sometimes it's very non-specific. See, in infants and toddlers, it's nausea, emesis, abdominal pain, food refusal, failure to thrive. Such common problems which we see in children. Even in our own grandchildren, we see these problems. School-age children, it's abdominal pain, vomiting, and anorexia. Only adolescents and adults, you start seeing the symptoms of esophageal dysfunction or a symptom due to an alteration of the esophageal structure. You get the dysphagia, you get heartburn, you may get food impaction, chest pain, and regurgitation. So this is one reason, and this was the paper which also documented the same thing, that the symptoms of abdominal pain do not differ between EOE when it's present and absent, and the only problem symptom is the food impaction. So, and the other thing is children start adapting behaviors. When they have this problem, they might not tell you, but they'll start. This impact is a mnemonic which you can use. They imbibe fluids with meals. You have seen your children also. They take water with every meal. Then they'll bite it into small, small pieces. And then they'll prolong their meal time. And all we think that, oh, this child is a picky eater. I was also like this. His father was like this, the grandmother will say. So these are symptoms, and therefore it is missed. The second reason why it may be missed or delayed is probably in the diagnosis of EOE, we all know what are the endoscopic findings of EOE. We'll all know. We'll say linear furrows, we'll say the plaques, we'll talk about the trachealization, we'll talk about the strictures. So if you see these findings, maybe you will make a diagnosis. But then in children, this is a nice paper by Chris Licorice where he said in 2005, I want you to see this pie diagram, and 32% it is normal. So it's a normal esophagus. Taking 5 biopsies is not easy for children, and you also don't want to do. So this may be another reason why it's been missed. In histology, you send the biopsy. They might say eosinophil seen. Eosinophil seen does not mean, though in a normal esophagus you do not have eosinophils, even then it could be a parasitic infestation, it could be an allergy, So the number is very, very important, more than 15 per high power field. And in addition, if possible, if you have eosinophilic microabscesses, if you have this degranulation of eosinophils, and if you document lamina propria fibrosis, it will be the extreme, then you can make a diagnosis. And we should always remember there are several conditions where you can have eosinophils in the esophagus, especially what we should remember would be GRD, celiac disease, IBD, Crohn's, infections, vasculitis, and achalasia. Therefore, where do we err in diagnosis? Clinically, yes, symptoms are non-specific. As Dr. Ujjwal was saying, chronic abdominal pain, functional dyspepsia, FGID is more common. You can't keep doing investigations. So probably you will have to identify if there is a family, if there is a history of allergy in the child, if there's a history of atopy in the child, and the child has abdominal pain and vomiting, that may be the group where you will do. Vomiting, you'll always think it's just GRD. Eating disorder, you'll think it's picky eater. And when you do an endoscopy, if by chance you have done, you usually take biopsies from the antrum for H. pylori. You may take a D2 biopsy also to exclude celiac disease, but you don't take biopsies from the esophagus. I have also not taken. So maybe I have also missed children who've been vomiting. Esophagus biopsy is missed, especially if esophagus is normal. That's another thing. And if we have taken biopsies and there are eosinophils, it is important that other conditions are excluded. We have some additional tests which we will not go because of things. Then why is this concern? After all, there are eosinophils in the esophagus. And Eos actually means the goddess of dawn. It's just the pink color, a nice cell. What is it that it does when it infiltrates the esophagus? Yes, the reasons are it can produce inflammation, as I've told you, the rings, the furrows, the exudates. They go in for a fibrostenotic disease. You can get a esophageal perforation. You can even get a dissection, an intramucosal dissection of the esophagus because of this infiltration, dysmotility, and even an achalasia. On the whole, this is the study so far. Life expectancy not affected. Till date, no association between eosinophilic esophagitis and cancer. So the major issue is the tissue remodeling. The word which is used in eosinophilic esophagitis is the tissue remodeling or the irreversible structural change which occurs, leading to tissue fibrosis, progressing to stricture formation and esophageal functional abnormalities. This is the reason why everyone advocates that in early treatment, decrease the inflammation as fast as possible to prevent this. And the medical emergency would be probably a dysphagia, food impaction, and esophageal perforation. The perforation can be spontaneous, it can be due to a regular routine endoscopy, or it can be due to a therapeutic stricture dilatation. There are several comorbid associations in eosinophilic esophagitis. What we should remember would be IBD, celiac disease, IgG4 related disease. So what is the etiopathogenesis? Just like in inflammatory bowel disease, and it is an interplay between a genetic predisposition, some immune dysregulation, here it is Th2 mediated, and you have an altered environment. The environment alteration may be the external, but here it is more internal. As I told you, atopy, diet, food allergens, cow's milk, soy, egg, wheat, peanut. Why should you know this? Because by knowing this, you can avoid these allergens, and in the management, this becomes little more scientific. Alert being because this is one of the causes of that, and the microbiome. So where you can change, you can attack and try to treat it. So the culprit eosinophil, it looks so simple, it looks so nice, but look at the number of proteins and mediators this eosinophil is releasing there. I like this cartoon very much, where it shows that the allergens, either aeroallergens or oral allergens, when they enter, this antigen is taken by the antigen introducing cell, and then the dendritic cell is activated, the Th2 immune mediation, and it's mainly the mast cell, the activated mast cell, which drives these eosinophils into this esophagus. And once it does that, it releases all these inflammatory mediators and cytokines, and you get the problem. So how do you manage? You have to remove the allergen, decrease the inflammation, prevent complications. So you have to eliminate symptoms, reduce mucosal inflammation, and reduce disease consequences and prevent complications. Diet, we have two types of diet. The main important thing is the elimination diet, especially in children. So either you can do the targeted or the empirical. Empirical is, you know, the 6 major allergens. So you do what is known as the 6-food elimination diet for at least 4 weeks, which is mainly dairy products, wheat, eggs, soy, peanuts, and seafood. Or you can do the 4-food elimination diet if you just have to exclude the nuts in this, and the 2-food elimination diet, because 50 to 60% of these eosinophilic esophagitis, they found that dairy products and wheat. So this is a very simple, and this is recommended in all children. Try this first. Try the diet first. Elemental diet, apart from this elimination diet, elemental diet was first spoken about by Licorice long back. He said if there's severe allergy or there are multiple allergies or this failure to thrive, then you give a diet without any protein. This will be the amino acid based formula which you can only give for young children or children who, because they won't tolerate the taste. You have to place an NG tube and then you have to feed the child, but he showed very good response. But now this elimination diet is preferred. The drugs, PPI is now used not only for diagnosing EOE, but as a management itself. You have to give, because it's amazing to know, we always talk about PPIs as anti-secretory, mainly on the acid, but they also have an anti-inflammatory effect, and therefore you can use PPI, you use it for 4 to 6 weeks, and then you find the response. So PPI, REE, which we were using earlier, the responsive eosinophilic esophagitis, the terminology is not used. Topical steroids has now come to play. You can either use the fluticasone spray or you use the oral viscous budesonide. Probably the discussion we can talk, this was first spoken by Fabian when he gave this, treating 4 children with inhaled steroids. Now we have this oral budesonide suspension, which seems to be very effective, and the swallowed topical corticosteroids, which is also a meta-analysis, have shown both fluticasone as well as oral budesonide can be given. The new drug which has now come is this dupilumab, which has been given for those who did not respond to PPI or to your oral steroids, and they found very good results. Subcutaneous 200 to 300 milligram given every 2 weeks for 5 months. Stricture dilatation for those who require, results have been good. One has to be careful. You can use balloon or the bougies. And the outcome, what is the outcome? If well managed, if treated, 81% favorable outcome. So I would just like to say that in the management, you could use the diet, you could use PPI, must use PPI. The efficacy is 30 to 60%, but topical steroids would be the best. So in conclusion, ladies and gentlemen, EOE is a chronic immune-mediated disorder. Symptoms depend on the child. Endoscopy with esophageal biopsy is very important, at least 5 biopsies, dietary therapy and swallow topical steroids. PPI should be considered as therapy and not for diagnosis. Novel medications may be necessary in select situations. Thank you for your patience.
Thank you to all our distinguished speakers. Unfortunately, due to lack of time, we cannot take questions for this session, but any questions can be asked just after the session to our distinguished speakers. Thank you.
Thank you, sir. For the next session in Women in Gastroenterology, can I please invite Dr. Shobna Bhatia and Dr. Deepika Kakeria to please chair the session. I would also request Dr. Jayanti Venkatraman, Dr. Shobna Bhatia, Dr. Prachi Patil, and Dr. Madhumita Premkumar, Dr. Naresh Bhatt, and Dr. S.K. Tyagi also to please come on the stage for the panel discussion. Dr. Govind Makharia, sir, can I request you to be on the stage?
Last year, the ISC Governing Council has constituted a cell in women in gastroenterology, and this group is chaired by Dr. Usha Dutta and Dr. Deepika Kakeria, with the purpose to identify the challenges which are there faced by our Indian gastroenterologists. Of 3,200 of our members, about 10% are women. It's much less, and we should have a better number. With that, Dr. Bhatia.
Thank you, Dr. Govind. We'll get this session moving, and I'm glad that there is a session and a cell called Women in Gastroenterology. We are not looking for reservations, but definitely we are looking for things to get better for the women and more women to take up a challenging branch like gastroenterology. So what the plan is to have the 2 talks Then Dr. Madhumita will be giving us the results of a survey, which is the third talk. And then we have 15 to 20 minutes of discussion, depending on how much time the speakers spare us. So our first speaker is going to be Dr. Anita Afzali, who's going to talk about the Western perspective. And you all must have heard her in the IBD session yesterday. So I'm not going to introduce her, let her work introduce her. Thank you.
Wonderful. Thank you so much. And really so great to see a session like this available during a conference where we're emphasizing and discussing women in gastroenterology. So what I'll do is start with some disclosures. As a disclosure, I was born in Afghanistan. I'm a first generation Afghan American. I'm an immigrant, so I will provide both an immigrant perspective as well as a Western perspective. And especially with what's happening in Afghanistan right now, I am in a position of privilege, just recognizing that. So I'll start with saying I believe that the future of GI belongs to women, recognizing that we need to emphasize women in medicine, gastroenterology, and leadership. I'd like for us to understand the gender inequities, and then also how can we advance the field of women. As a celebration of women, Dr. Elizabeth Blackwell was the first female doctor that was recognized and came into being a national day. National Women Physician Day is celebrated February 3rd every year because of her. And since then, as you can see over time, the societies, the AGA, as far as the first female president was in 1942, we had the first Black woman gastroenterologist, and then my mentor, Dr. Christina Sarawish, as the first ACG female president. 2017 was unique because we had multiple of all societies as female gastroenterologists, and so we were really, really happy to see that among all societies. But you can see, and this is what I meant for this is the time for women, you can see that this is also improving, where we're having more female gastroenterologists serving as presidencies. Now, the number and percentage of active physicians by sex and specialty, when you look at all specialties, male compared to females, and then when you look for gastroenterology specifically, we're still less than 20%. And so we need to emphasize and see this trend that we need to go higher than 20% in order to have that critical mass difference. And this problem is because of this leaky pipeline syndrome, where 50-50 females, males in medical school, but then ultimately who becomes a professor or a chair like myself or a dean, we're seeing less and less representation. And so we really need to address this. And this starts with leadership opportunities, program directors, associate program directors, division chiefs. You can see that overall there's a poor representation and opportunities for women in these positions. And similarly for department chairs such as myself, we're seeing less opportunities for this, recognizing that the majority of these positions are filled by white males primarily, and as outlined here among other races, you're not seeing that. So what I would urge is that we need to start incorporating term limits so there could be more opportunities for everyone, males and females alike, but recognizing that certainly here supporting more females. So what kind of challenges do women deal with and face regularly? I'll start with saying that the part of that leaky pipeline is everything I listed out here, from the gender pay gap to family planning, maternity leave, the third shift, which I'll talk about, lack of opportunities, lack of value and recognition and support, mentorship, healthcare inequities when it comes to human resources or HR issues with Time's Up healthcare and Me Too issues as well. When we look at gender pay issues, specifically from a Western perspective, you can see this pay gap. And specifically, you can see that regardless of whether the individual is an instructor or a professor, you can see that overall, we're still seeing, as female gastroenterologists in the United States, we're seeing a pretty significant pay gap of up to almost $100,000 of a difference every year. Gastroenterology is the 5th largest, as far as specialty, with the highest amount of pay gap among all specialties in the United States. So we need to make changes. Family planning, that leaky pipeline, family planning becomes an issue. And overall, you can see that most female gastroenterologists, as far as are they even considering having children, they're either delaying it or opting out of children or having children altogether in order to be able to advance their career. Similarly, as far as being able to take maternity leave after a mother has her child, what happens is that 40% of female gastroenterologists do not take take maternity leave. And oftentimes this is because of the external pressures, or it's the expectation that they're still taking care of a newborn and working on work, emails, etc. And they're getting a lot of pressure and even threats in regards to being able to promote themselves either from a career perspective or a family perspective. The COVID pandemic, well, this has impacted women's progression significantly. It has put women behind at least 25 years in progress. Why is that so? Because there was greater responsibilities for the female gastroenterologist and for the female in medicine altogether, greater childcare and healthcare caregiver responsibilities, increased work-related stress, higher rates of burnout. All of this has happened because of the pandemic and the demands that has required of women in the field. That third shift that I was talking about, on average, 8.5 additional hours per week that a woman in medicine is needing to commit in order to be able to do that third shift at home, right? So an additional 8.5 hours of housework, caregiver work, support in the house, on top of being a doctor. So when we talk about the Western perspective, and even here, I'm sure that third shift is there. What we know is that there's also procedural time differences with female gastroenterologists. Oftentimes, women endoscopists do take longer to complete the procedures, and maybe potentially this is contributing to the pay gap. Potentially that's why we're seeing this discrepancy, but I would say that's not the case. Overall, we know that women doctors who take care of patients actually have better outcomes. So we know that overall, if the female patient usually prefers a female doctor, and if we take care of these patients, we actually have better outcomes with reduced hospital length of stay, mortality, or other complications. So this is that gender preference. Most females prefer female physicians as well. Most men didn't have a gender preference. So the good news is the future is GI for women because we're on high demand. So what can our male colleagues in the room do? First of all, I applaud each and every male colleague who's sitting in this room today. Oftentimes this room empties out because it's a woman discussion. So thank you for being here. Listen to us, hear her, promote her, sponsor her, include her, pay her, nominate her. How do you do that? Well, sponsor her, mentor her, support her in different ways of being able to allow leadership opportunities, encourage her to be able to have these equitable opportunities for pay, for salary. Be transparent with these efforts. Try to promote her, get her on research projects, get her hospital or clinical leadership opportunities. How do you support her? Well, as I mentioned, the maternity leave and the caregiver role and that third shift role, being able to compromise a little bit with a flexible work schedule. Again, this is helpful. How do you nominate her? Well, the odds of hiring a woman is 79 times greater if at least 2 women are candidates for a position. So diversify the opportunities for leadership for each individual. And the odds of hiring a minority is 194 times greater if at least 2 minorities are applicants for an opportunity. So with that, I would say her time is now. And for each of us in this room, I would encourage each of us to know our value, get involved, avoid that imposter phenomenon, and we could talk about that a little bit further. Grow your network, and being able to recognize and converse and develop those sponsors and those mentors is important. Say yes to opportunities. Say yes, 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 and then start knowing when to say no to opportunities as well if it's not actually helpful for your career. And also be very intentional with what are your career plans. I think this is extremely helpful with knowing what your 3-year, 5-year, and 10-year career plans are, because that way you have the appropriate sponsors, allies, and mentors who can be able to help promote your career progression. So instead of fighting among women for a seat at a table, we should demand a bigger table or build our own table. How did I help build our own table? Well, one of my companies is Scrubs and Heels, where we are basically an organization committed for women in gastroenterology. And we had our first summit. We built a tribe, and we are having more intentional efforts of mentorship, of conferences and summits. And you can look us up in these efforts of exactly what we're doing to be able to support support and empower each other. And with that, I'm going to end with the horrific efforts or issues that's happening in Afghanistan. And so the future is women, and hopefully the women and girls of Afghanistan will have an opportunity to proceed with their education as well. Thank you.
Thank you for your wonderful talk, Dr. Afzali. Next is Dr. Prachi Patil, she's going to talk to us about Indian perspective about women in gastroenterology.
Thank you, and I'm really grateful to the ISG for having this platform for women. I would like to begin with a disclaimer. So Dr. Afzali has shown us a lot of statistics, and my talk is unfortunately not based on statistics because we have very few of them regarding women in India. So it's my perspective on women in gastroenterology. It's a talk from the heart or from the gut, as you call it. So India, as we all know, is quite a conservative and patriarchal society with a skewed gender ratio. We know there are gender stereotypes that women often get slotted into, but history is rife with trailblazers. So right from the 19th century with the first school for girls, the first women doctors, we've really come a long way with the first woman prime minister and also the woman president. When we come to women in medicine, the image on the right is Anandibai Joshi. She was the first woman from India who got trained in Western medicine long back in the 19th century, 1876, and she's paved the path for a lot of women like me to become physicians. And when we look at the trajectory of women in medicine, the Indian scenario seems to mirror Western statistics, although we don't have hard numbers. So an equal number of women as men enter medicine. If we see medical school composition, it's generally 50-50 or even higher for women. As women progress in their careers, we see that the relative numbers decline. You have less and less women when you go into internal medicine, and then there's attrition at each level. So, and it's much more marked for hands-on subspecialties, especially interventional endoscopy or advanced endoscopy. And Dr. Afzali already mentioned this about the leaky pipeline, so I won't go into that. So in India, the situation is such that women in gastroenterology are underrepresented, especially in procedural subspecialties. This underrepresentation we see at all levels, right from trainees to faculty to leaders, and there are very few visible women role models for women today. We don't see hardly any women in advanced endoscopy. There are very few women in leadership positions or as heads of academic departments. This results in fewer mentors and sponsors for women, and this discourages women from entering the field or progressing the field and feeds into an imposter syndrome because they are not seeing anyone like them represented in a big way. Also, there are a lot of negative perceptions regarding a career in gastroenterology. It's traditionally thought to be a male-dominated field, very competitive, needs technical skills and stamina, and a lot of women feel it's not for them. Also, the long and almost antisocial working hours seem to be incompatible with family life and caring duties, and this results in quite a high burnout because of difficulty in having a healthy work-life balance. Probably what can help here is an improved visibility of women, and earlier exposure to women role models and an earlier exposure to advanced endoscopy so that women aspiring for a career in gastroenterology feel that they can do it. Once they do get into gastroenterology, there are a lot of further barriers to be faced. So women are battling cultural stereotypes, there are biases, micro and macro aggressions to battle against. The imposter syndrome is quite well known. An important point is that the trainee and early career years are going to overlap with the years of marriage and childbearing, and frequently institutional policies are not going to be conducive to women regards to taking leave. Also, women inevitably end up taking career breaks. This leads to either an actual or perception of de-skilling, a loss of confidence, and it's difficult to maintain endoscopy skills and to stay updated in such a scenario. Also in India, you don't really have the concept of a job share or flexible working hours, and this results in managing long working hours and calls. Access to both mentors and sponsors is vital in navigating a gastroenterology career, as in any other branches. And here again, in India, we face a challenge in procuring both mentorship as well as sponsorship. And it's important to have a mentor, full stop, whether be it a male or a female mentor. But women mentors will bring something additional to a woman mentee. They will offer practical guidance because they've been there, done that, and they can provide networking opportunities as well as advocacy. So what could help here is to have training programs for mentors so they know how to deal with mentees of both genders, and also matching potential mentees and mentors, as everyone will not be lucky to be in a program where there are mentors accessible. This is an American survey, probably doesn't have a place in a discussion on the Indian perspective, but it highlights a few significant gender differences in mentorship, which I would like to highlight. So from the mentees' perspective, more women preferred a mentor of the same gender, but less often had one, and women had more difficulty finding a mentor as compared to their male counterparts. From a mentor's perspective, more women mentors felt comfortable advising the mentees about work-life balance, but fewer women, interestingly, considered themselves effective mentors, and more women, in fact, felt pressurized to mentor because of their gender. And I'm sure if we would run a questionnaire survey in India, we would get something similar in response. Advanced endoscopy training comes with its own challenges. Most importantly are the ergonomic issues. So the endoscopy equipment is historically modeled with a male hand in mind. So it's a typical one-size-fits-all approach. With respect to the scope size or the weight, the endoscopy room layout, many times the screen height is fixed, and women are different. We have smaller hands, lesser hand strength, shorter height, and this results in a higher rate of musculoskeletal injuries in women, especially upper extremity injuries. Also, women endoscopists are not very keen to engage with industry, and this results in very poor sensitization of industry regarding what women need. Also, at a personal level, we have very poor awareness about ergonomic issues and strength training until we really take a hit because of the ergonomic issues. Another major challenge in advanced endoscopy training is fluoroscopy. There is a lack of clear guidance about reproductive risks and mitigation of these risks. Lead aprons are heavy. If you are in a high volume center, you will end up wearing them for several hours in a day, and they do add to the musculoskeletal injuries. Also, there's a lack of access to suitable advanced endoscopy fellowships. When I say suitable, I mean flexible for women, flexibility in terms of working hours or schedule, and those that don't involve travel, so that the women can be nearer families and manage personal commitments. There's a poor visibility of women in academic meetings. There are fewer women speakers, fewer attendees, and even when women do attend, literature shows that as attendees, men will ask twice as many questions as women. So they may attend, but they will not still participate. And this gender imbalance at conferences actually limits the perspectives and the opinions shared. An important fallout of this is participation in academic meetings will allow for academic recognition, and it's very important for promotions in an academic center. And this lack of participation is further going to propagate the glass ceiling for women. I'll just like to end with a few personal experiences from my 20 years in gastroenterology. So during residency, it was the first time that there were no women co-residents with me. There's no one who's in the same boat. So it's an intense feeling of isolation until you get adjusted to the branch. Endoscopy training is quite challenging. It's a procedural field, needs hand-holding. You got another person in your space and vice versa. And this leads to certain awkward moments. It's also a 24/7 branch. It takes time to get adjusted to it, very few role models. And I ended up with a lot of musculoskeletal injuries over the last 2 decades until I woke up with the importance of, looking after your own body and doing some strength training. At the same time, when you're doing your residency, trying to adjust to a new field, there's this personal level pressure of settling down. Once you become a senior, there are a whole different set of issues that you have to contend with. So you have to find a window of opportunity for an endoscopy fellowship, which again becomes difficult because now there are competing personal responsibilities, marriage, childcare, parental responsibilities. I worked in a place like Tata Memorial Hospital, which was a very endoscopy-focused GI department, and for a large part of a decade, I was working in an all-women department. Now this brings forth a whole different set of issues. So we had to battle a lot of biases, micro and macro aggressions. And I realized that apart from your specialty, you also need some other skills which you need to survive and to thrive. But again, I'm speaking from a position where I've worked only in an academic center. So I've had equitable salaries. There's no gender bias in that. I've had plenty of leave. So I'm sure there are a lot of women who had worse experiences than me. So if I could speak to my own 20-year younger self, I think these are the lessons that I have learned. It's important to speak up. It's important to be visible. We frequently tend to shy away from the spotlight, and that's not good. We have to be our own advocate and also empower others. Seek out mentorship and support. Acquire other skills that are important, like management skills, negotiation skills, and so on. It's important to focus on research in an academic setting. We have to look after our health. I think gastroenterology is like a marathon. It's not a 100-meter sprint. We have to be healthy at the end of it. Keep the imposter syndrome at bay. Network, network, network. And as Dr. Afzali says, find your tribe. And it's okay to take breaks. This is perhaps the most important lesson. So when we are all trying to look for work-life balance, we have to realize that work is really a rubber ball. So once in a while, if we get overwhelmed and we need to drop something, we can drop it and it will still bounce back. But the other balls in your life are not. So they have to be taken care of. Thinking about the path ahead, I'll just take a few more minutes. There are things that the GI societies can and must do. There are things that can be done at an institutional level and as individuals. The societies have already taken a positive step. We need some mentorship schemes, some sponsorship and networking opportunities, increased representation of women. Institutions need to focus on pay parity, on time to promotion, on flexible hours, adequate maternity leave. But as individuals, I think we have a biggest contribution to do. Rather than sit and blame the system, we need to strive for work-life balance, be mindful of our careers, and be very proactive in seeking out what we want. So to conclude, I think the idea of women in gastroenterology is very complex. There are many challenges, but there are also some triumphs. The future is really bright with more platforms, visibility, more opportunities coming up, but we need much more. We need a culture change, we need more advocacy, and we can learn from societies like the AGA that have a Women's Leadership Conference, that have a Future Leaders Program, that have avenues for networking and mentorship. And the ISG Women in Gastro Group is a hugely positive step, because finally we all have to be the change that we want to see in this world. And I'm really thrilled to be a part of this. Thank you.
Thank you, Prachi. That was indeed a lecture written from the heart with some personal experiences as well. I'm now going to invite Dr. Madhumita Prem Kumar. So let me give you a little background. Along with some of the women in gastroenterology, Madhumita and Usha Datta had conducted a survey which we had sent to the men and the women in gastroenterology. We got a few answers, I think 10 or 15% people answered, but it will just give us a perspective on what people think about the women. So Madhumita, over to you.
Thank you so much, ma'am, for the introduction, and thanks to the organizers for organizing this forum where we could actually put forward our ideas. So the first thing, the idea was incepted last year, and we wanted to know what were the issues that women in GI face in the country at every level of practice. So whether they are entering at the MD level, and then they are making up their minds whether they need to pursue a career in this field, and then after they go in for GI training, whether they get to advanced training, how many of them decide to continue in the field or they want to go into an outpatient kind of practice, and how many finally make it to the academic level. So we wanted to get some basic data about India. And we know that we have to start with a survey of the existing ISG members to see how many of them were women. We didn't even know that in the first place, how many were women. And thereafter, we have to navigate these ideas to make it more inclusive or representative. So we prepared a questionnaire in which we send it as a gender-neutral questionnaire to everyone. And we wanted to know exactly what people thought. So most of our responders were male. So again, men dominate even a women in GI questionnaire, probably because there are more men in ISG. And most of them were ISG members. Some were students who were still under training. And the highest qualification was DM gastroenterology and followed by DM hepatology, but there were other trainees as well. And a good number. So we got a neat slice of people at every level of practice, starting from residency up to senior professor level. So let's see how they responded to questions on GI practice and the work environment. So most of the people that surveyed were interested in a general GI practice. And
just a moment, Madhumita, there's a lot of disturbance there. What's happening?
I think they are doing some drilling work. Men at work.
Men at work? Can
men
we ask them to just, can we ask them to be silent?
So we have to ignore the men at work and continue with ours. So
okay.
I can be loud if that helps. So women are really not bothered about what is happening around. We just keep ourselves focused and work on. So let's plow on. So most people, I'm very happy to say, were also stating that they were interested in liver disease, so which means a lot of our gastro subspecialty are actually practicing hepatology also, because that's what we see. And many people, of course, said that we are more interested in surgery, transplantation, or in endoscopy. So we have had a good interest profile. The majority, of course, are clinicians, which is what we expect, but I'm happy to know that 1/3 were also researchers, half of whom were also involved in advanced GI endoscopy, and about 40% were actually involved in teaching. So we need to know that it's not just the training period, but people continue to learn throughout their life and GI practice, and we never stop learning, really. So most people would spend 6 days at work, which is true for us, and many people actually said, oh, I'm working all the time, so 7 days a week. And a large number would be working, about a fourth were working more than 10 hours a day. So if we look at 8 hours and above, that's the major chunk. So we spend a lot of time with our hospital colleagues, which is why we need to be more insightful as to what is going on in the work environment to see if it's okay for everyone. And then we also took cognizance of the fact that there's the third shift. So how are people working at home? How do they manage their life at home? So many hours a day are also devoted to household chores. So we are not presenting the data for the gender discrepancy here, because that is not the purpose of the meeting. We live in society and that will not change. What we can change is what is happening in the work environment. So the major challenge that has been reported by our GI professionals are that they are interested in research, they're not able to do it, so maybe we need to get mentorship for research. They also are stating that training would be required for achievement of leadership positions, and after going through their research, getting published is another stage of hurdle. So although we might be discussing flexibility and building of practice and presenting at a meeting, these seem to be less on the agenda. The idea is if we provide gender neutral, inclusive training for doing research, for learning how to publish, for actually getting the adrenaline rush that everyone gets from being a published author, from presenting at meetings, that would actually help get more women involved in the field. So while we might talk about mentorship, allyship, yes, that is important, but also that this is something that GI professionals need to be trained on right from the MD level and when training happens in gastroenterology, hepatology, and allied fields. So this is an important aspect that ISG can actually take on. So what are the factors that actually hinder women in their medical career? Please note, we have around 100 responses here, and both men and women are answering. So this is more of an opinion. So most people apparently think that a marital home restriction or partner-related issues do contribute, societal pressures do contribute or may hinder women in their medical career. But let's see how the gender distribution played. So when we selected it for women versus men, lack of peer support and lack of mentorship is what women identified as problems, not societal issues like absence of childcare, access of maternity care. Women professionals don't really look at that because we have learned to fend for ourselves. What we are looking for is an equal seat at the table in decision making. So that's the way it went. So when we asked people what factors actually positively impacted their career, most people pretty much said that as they gained experience and time took on, they're doing much better. They found a good mentor or role model. And of course, once they achieve a period of financial security, that takes the edge off the stress and people perform much better. What negatively impacted career development was an absence of role models. So providing the mentor-mentee relationship, gender independent, would be crucial to getting a good GI fellowship across the country, as in fellowship or camaraderie. Familiar responsibilities, of course, are a burden, but nobody would consider it cumbersome. It is something that is a pleasure as well as a joy as well as a pain. So that comes with the package of living. So the major suggestion that has actually come out is that people want mentorship for advanced training. They want leadership role, mentorship for how to achieve leadership positions. And the response to ISG was to provide a forum for providing mentorship or professional training for advanced GI positions. So this is one of the major responses that we got. Coming to work-life balance, The majority were married, and the majority had married another medical professional. Of course, if we look at the number of work hours spent by the self versus the spouse, there was a gender gap, but again, that is a topic for another time. Another major problem, and this is really astonishing, around 150 people we surveyed, and more than a third, okay, 37% said yes for burnout, and 23% said maybe, which means there's a good amount of stress involved here. A high number of people across seniority levels has experienced burnout, whether this is COVID related or work related. Maybe we should be improving our interpersonal relationships and providing a collaboration, maybe on a societal form from ISG. So at this point, I'd like to break it here and just ask a couple of questions to the panel. Dr. Naresh Bhatt, sir, have you ever faced burnout in your career, and how did you deal with it?
Fortunately, really not. I've had a very supportive family, and so I think I've been a little lucky. I've had my health problems, but not a professional burnout. The passion has kept me going.
All right. Jayanti ma'am, have you experienced burnout ever yourself, and
Never,
how have
never.
you?
I've never felt burnt out, never.
So have you encountered any one of your students who has
I mean, my this approach to this is, I think, having discussed all this, I think each of us has to rise on our own, you know, and I think that's the way that one moves forward. I had elderly parents to look after until 2010, but I could manage home, I could manage my hospital work, I could do the administration, go in for academics, research, attend conferences, meetings. I could do it. So I think for women, I think it is all that was mentioned. I think each woman has to rise on their own and have the timing and the time, what do you call it, adjust their timing to work, to their workplace, look after the family, as well as, I think, representation in a conference like this. In my own state, I'm not able to get women to come forward, even giving them opportunities to present, even giving opportunities to come forward and participate, we're not getting them. So we have one group which is at the higher level, then we have the postgraduates, but the in-between group, we don't see them at all. Even in the present conference, I've not met any of our own colleagues from Tamil Nadu state. So I think it's an individual.
So it has to be normalized to see more women at these meetings, or maybe more invitations, or is it constraints that prevent them from coming to the conferences?
No, that's what, I don't know why the women are getting burnt out after finishing the graduation. You know, they finish the DM gastroenterology, they get the degree, and then they have their practice, little practice they have. They look after their family, and I think they're satisfied with that. I think if there are some postgraduates or someone, they can give us some information as to what is it that prevents them from moving forward after completing the course. I know many women who, I mean, we have many of them here in the front rows who have a family, who have done great jobs and have come forward. So I think some of the postgraduates or who have just qualified, they can come forward and tell what is it that prevents you from coming forward and taking up.
So Dr. Goenka is going to make a point.
Just 1 or 2 points. I think this was one of the initiative of this governing council for the first meeting itself. I proposed it and we discussed that we have never done anything for women in gastroenterology in India. But then in the last 9 months, the progress has been slow. So my point is that while you should ask for the support from the male counterparts, it's you yourself who have to come forward. It cannot be, you can't be pulled into. You can be supported, we can handhold, but don't expect that we'll be pulling you all the time to come to the front.
I agree to that.
What I find lacking is, I'm not talking of few people who are sitting on the dais, but I find lacking is ambition. Until you have ambitions, until you have dreams, I don't think anybody can pull you to the front.
Passion,
So I think that passion has to come from within.
Yeah.
And your male counterpart should help you in getting that passion. But we cannot always create the passion. So I have been surrounded in my nuclear family by 4 ladies, my wife and 3 daughters. So I understand the importance of acquiring leadership and moving forward for women. And I would say that ISG you will find full support from the ISG Governing Council. I can say even after 1 year of my next 1 year, I'll be there. But after that also, I'm sure there is a changing the trend. But then you have to come forward yourself. Don't expect that your male counterparts will be pulling you all the time.
So, 1 minute.
So,
Is it a cultural driven issue that they lack ambition?
I think
Or
it's a process which has to change.
an
Over the last
individual.
20-25 years, if you look at ISG, there have been hardly one, possibly one or two women presidents. Anita showed us the list of presidents of women presidents in USA. But I don't remember, other than Saroj Mehta,
Nobody else.
nobody else has been
Nobody
the president
else.
of ISG. And there have
No.
been 63
No,
presidents.
never.
So there have been 63 presidents. So it's not that there's no ambition. I mean, I wouldn't say no ambition, but there is a lack of ambition. If you are happy to be one of the delegates and you don't want to be a faculty, you don't want to be a leader, it's very difficult for anybody to push you to become a leader.
I agree.
So, Mahesh, can I just answer that? You know, many women drop out. What Dr. Afzali also told us about the leaking pipe syndrome. Many women drop out for 4 or 5 years because of family, children, and then somehow it's very difficult for them to come back. Now, if I am invited to a conference and I don't come for 2 years, the third year probably the governing council is not even thinking of calling me. And that's not their fault, but the fact is if we drop out, and that's for everybody, if they drop out,
Shobnaji, it's not the physical attendance. You
no,
have to
I know that, but
keep
I
the
mean
people,
that
keep
way.
the network on.
Yes.
Even if you're busy with something, if you completely go into the background,
Correct.
then it's
Then you
likely
get
that
forgotten.
people will, so you need, even if you're not actively present, there's some way you can show your presence even being physically being absent.
Right, sir. We totally agree with you, and we agree with the point made by Dr. Goenka. The passion has to come from within. It's a fire
Yes.
that comes from within, and I totally agree with that. So we need to ignite that passion as well.
But
So
Madhumita, I just want to add in a point here. We have sent this survey to everyone in the country. So if the women want us to do something about it, why are they not even answering the survey? There are a lot more doctors. So
So
I
that-
think they should answer the survey.
There are multitude of reasons for not
Yeah.
answering. Dr. Gushal, one moment.
Yeah,
Dr.
very
Zali
good.
wanted to
I think
respond
it is a
to.
very good initiative that we have taken. But let me tell you, just Dr. Anita enumerated a lot of things. The society in US is different than in India. In India, we have a lot of positive things, I'll tell you. There is no pay discordance between male and female as far as a job is concerned. We are not talking about private practice. Now, even in US, obviously the public sector thing is totally little down. On the other hand, in India, in public sector, there is no job discordance. Now, in India, female get a maternity leave of 6 months and nobody has the right to question. Nobody, including the top boss like Prime Minister. Male get 15 days paternity leave. So that is the second thing. Third thing is that one more thing, like we are talking about female in gastroenterology. Look at the participation. 90% would be man. So we are there for you. Because we know female are our mothers, female are the powers. That's why we have Goddess Durga, Goddess Kali. We put them in the front. And I tell you, whatever microbiota work I do, all credit goes to her. So she gets the priority, not me, but because I speak more, because people like me to speak. So therefore I am there.
Not an assumption.
But she's the one whom I'll give all the priority.
So,
what I'm
one
saying is
thing.
there's a difference.
So we should
but we have to come
congratulate.
forward.
So we should congratulate Uday. I remember Ujjala as a very quiet girl, maybe 20 years ago. Very quietly she used to sit, and Uday just pulled her into the limelight. Uday, congratulations.
If permitted, I would of course like to share my experiences, and I agree with Dr. Shobna, and would like to differ a bit from Goenka. Of course, passion has to be there, but it has to be fully supported by the family. Like from my experience, I would like to tell, I got married when I was just MBBS, and immediately next year I had a child. Then when I got selected into MD, I had to choose either between the career or my son. Then it was he and my mother who left her house, who had 3 sons and full family, but she wanted me to study. I had no father, lost at very age, and she supported me. So she wanted me to read, so she left her house so that I go to the hostel, and she came with him so that she could take care of my son and support it for 4 years. So I had like toppers in my class. I was not a topper, other people were, but my friends, they had to sit at home because they did not get any support from the family or from the husband. And many of them sat at house for 8 years. Many of them had to be medical because they told, no, you have to take care of the child, and we cannot like share the responsibility. So I am here, whatever I am here, because of the family. I had that passion. I wanted to do something in life, but it is only because of their support, my mother's support, his support. So that is very important in early career of life, because that is what, when do you post-graduation, you had a family. So only passion, Dr. Passion has to be there, otherwise you cannot do anything. But for a ladies, for females, family support is very important. That is what I'm trying to say.
Jala, that is a
Well
very
taken
important
point.
thing.
Ma'am,
Yes.
Dr. Zali wanted to make a point. Sorry. Go ahead.
Yes, Afzali. After that, Radhika.
All right. Thank you for sharing that in that case. Yes, madam, go ahead.
I'm Dr. Radhika Chavan. I'm an interventional endoscopist. I beg to differ with Mahesh sir opinion. It is not that we are not ambitious, we are not passionate. We are. But I don't understand the parameter to represent, whether it is publication or how to promote ourselves. Because you told 79 times chances of nomination if there are 2 women in a committee. What if there is no one?
Yep.
It always takes time, Radhika, you know. It is, I mean, I think we all came to the limelight when we were at the age of 50.
Sir is going to
Until then, we didn't
rebuttal
give up.
soon.
We didn't give up, you know, 30, 35, 38, 39, 40 and all. We were sitting, we used to attend all the conferences. Malti and I were always the first, the front row benchers. It was only around the age of 50 when everything came to limelight, when the publications came in, then we started moving between the groups, came into the core group. So you cannot expect a representation at a very young age, but you have to pursue and you have to keep on moving forward. And there will be a time when there will be a breakthrough. But once you give up that, it goes for a crash.
Thank you. And one more thing actually I want to comment, that we always talk about role model, but role model cannot be born in one day. We have to create, or we have to give that environment to for a role model to come up and represent.
So, Dr. Radhika, you're going to be a role model for those young ladies sitting over there. Look, interventional radiologists. So, yeah, time to look forward to that. Dr. Nagpal? Yes.
मोदी साहब ने लोगों से कहा था थाली बजाओ to cheer up doctors. I am sorry to say 96,000 MBBS graduates graduate from this country every year. 55% of them are women.
Where are they?
What is the percentage of women among the DM and DNB specialists in gastroenterology? Can somebody give me the figure?
10% or less.
My point is, we are talking about supporting, but obviously there is something which we are doing which is keeping them back. And I'm part of it. There is no such thing. Is there a selection bias? I'm asking hard questions. No, don't.
So
go there.
the thing is that women, when they decide to take up post-graduation, they're looking at themselves first. When they're doing gastroenterology, they're going to be exposed to radiation. They're going to be long hours during endoscopy. So many of them at the time of MBBS choose branches like anesthesia, pathology or other paramedical branches. Pathology, microbiology, anatomy, physiology, PSM, where there are no long working hours and they are working 9 to 5 or 9 to 6. Even amongst radiologists, you find the women doing more ultrasounds than interventional radiology.
Are they deciding, or their husbands deciding, or their families deciding?
Somebody's
Number
deciding.
one.
Or they're taking up gynac.
It's a
Let me tell you,
combination.
they are not deciding.
Can I just make a comment in response to that? So I don't think it's a selection bias, it's more of a perception bias in the minds of the medical graduates and the specialty graduates who pass out. So gastroenterology is not considered as a woman-friendly discipline, because you are going to see, I mean, you ask 10 people who want to take up DM gastroenterology, and 9 of them are going to say, I want to do advanced endoscopy, and that's the reason I want gastroenterology. So it's perceived as this semi-surgical branch with where a lot of stamina is needed, where you are exposed to radiation, and I think it's just a mental block that women feel that I probably, cannot do that.
You're
Dr.
not audible,
Nagpal,
Neeraj.
You're not audible. You're
Your
not
mic
audible.
has to be switched on.
National Medical Commission has published its regulations, and they are talking of continuous professional development, in which one part is a feedback from the audience. If you have taken for ISG Con credit hours from the Medical Council, you are also to submit a feedback from each and every member who has attended. My question is, this, what has been done, is admirable, but this should be done with every graduate, male or female. We have to start taking a feedback from them, and our questions have to be designed in such a way that they feel free to give a feedback. Because unless we know the problem, it is very difficult to tackle a problem. There is a problem. 55%, 10%, ma'am has said it clearly. So whether we agree or we don't agree for one reason or the other, we are losing females from higher medical education. So from the limited number which is coming, a further limited number comes into leadership roles.
Absolutely.
And that is a, so if we just increase the base, the denominator, if that is increased, if from 55%, let us say 25% women can be coming into super specialty courses, I mean, obviously the chances of women coming into leadership roles will automatically increase.
So thank you, Dr. Nagpal. That was a very nice comment. We have someone more, and after that, I think Madhurita, you need to finish your talk.
Yeah. I'm Srijaya from Trivandrum. We have 6 residents per year, and I wanted to convey a happy news. We practice what we preach. A number of lady residents have been increasing, and I think in the past year, out of 6 residents, 4 are women.
Wow.
So thank you.
So these are things that need to be applauded. So
Can
we
I just
did.
have one more comment?
Yeah, sure.
We are talking about all the women who have been in academic institutions and who have come up. Please give me the number of women. See, the number of men who have worked purely in private sector and have come up in a big way in advanced endoscopy. You look at any of the advanced endoscopy center, they are mostly in the private sector. But women who are working in the private sector, it's extremely difficult in this current context for a woman in the private sector to come up to a leadership role. So there is some block happening at that particular level which we need to address.
So that's what we are trying to address find out over here. There is definitely a precept societal. Women are apparently dissuaded from taking up medicine, and then of course the trickle down effect happens, and they're fewer in gastro, and further trickle down occurs because of other societal issues. But what we need to do is, at least at the training level, what opportunities can be further provided and can be corrected. So we ask people how their work environment actually affected their career. For women practitioners, only a third said yes, night endoscopies, emergency procedures are a concern. But a majority of them, what we would conventionally think, when we asked other people whether what were the issues, the availability of a creche, child support, most people did not really want. Most people were actually asking for availability of mentorship and opportunities. And large number of our respondees said gender did not affect their career at all, but the women tend to notice that they were offered fewer opportunities than male colleagues and may have been deprived of some leadership positions. Physiological functions were largely, other than pregnancy and childbirth, which obviously affect the career development, the rest women did not rate as being important. So the solutions are as follows. Most women in GI were actually responding that they want some allyship, some peer support, how to do research, and these are actionable points. So just an idea that has been floated. We're talking about India's, Dr. Poddar just pointed out that women have the right to vote right from the inception of this country. We didn't have to fight for it. We have equal pay, at least in government institutions. Maternity leave is protected by law. We have many rights which we have enjoyed because the writers of our constitution were ahead of their time. But there are a few things we need to do further. So legislation which is mandating equal pay has come in Iceland. Possibly the US needs to be looking at these for looking at equalization, not get 80 cents on the dollar. And of course, there are other European countries which have also promulgated policies for actually looking at gender equality. So I'll thank you with the ending note that we are looking at the precipice up ahead. It seems daunting towards MBBS students and MD students to choose this field, but it's not. There's a very gradual route on the face of Mount Improbable, and it'll be slow steps. This is a beginning. I thank the ISG Governing Council for actually beginning this process, and by the gradual route, we'll find ourselves at the peak soon enough. Thank you very much.
Thank you, Madhumita. That was indeed a nice closing remark. We have to close this session because we are already time up. But I think we have another session for women networking. There's a room being allotted to us, so we'll be going there. I think it's Hall E.
I just want to make a point here. The survey is still with everyone. We can just send the emails out again. A lot of people have not filled up the survey. So if you can please fill up the survey, whether they are men or women, if you can fill up the survey, we get more answers and we get better, information from everyone as to what needs to be done.
53% men, 46% women, 151 responses.
So 151 is very less for the number of members we have in ISG.
How many
We have
women were
3,000
posted?
members.
What percentage of women responded? That's
So how many women are there in ISG, Govind? 300. Out of 300, if 75 responded, that's a big number.
Around 70 have responded. Yeah. We'll wind up.
Okay, I think we'll have to close this session.
We have to move on. Thank you very much.
Thank you. Thank you. Indeed, an interesting discussion. For the next session on medical legal issues, can I please invite Dr. Ashwini Kumar Setya, Dr. B.S. Satyaprakash, and Dr. Jimal Shah to please chair this session.
Good evening. And the last topic for today's discussion is really interesting. Every one of us are really concerned these days about the legal issues in our clinical practice and endoscopy practice. The patients are no more behaving like patients like earlier days. They are all behaving like customers, and they expect some sort of a service. And at the moment in India, the laws are not as good as we expect in favor of a medical profession, and this is going to be there in future, and we have to be prepared in a better fashion rather than take as granted. We have Dr. Ashwini Kumar Setya, who is going to discuss about Consumer Protection Act 2019 and what is it that we have to learn. Dr. Ashwini, please.
Thank you, Chairpersons. Let me begin by thanking Professor Makharia, Sandeep Nichavan, and ISG Organizing Committee for extending this privilege to me to be talking to you on a subject which is not exactly gastroenterology but concerns all of us. I can see that we have to work harder to make importance of this subject sink in the audience and the doctors in general. So on July 20, 2020, a law came into being after notification, which is popularly known as Consumer Protection Act 2019. And our fraternity spontaneously broke into euphoric celebrations. But I thought that was misplaced. I'll tell you why. In 2018, when the bill was presented and passed in Lok Sabha, the healthcare was included in the definition of service. And a lot of protests broke out on the streets. Doctor protested loudly. And as a result, when it was presented in Rajya Sabha, the then Civil Supplies Minister, Mr. Paswan, promised that the healthcare would be excluded from the definition after it was brought to his notice by Dr. Subramanian Swamy. And it was excluded, but alas, the drafting did us in. How? So as you can see in this definition, the word healthcare is not there. But it says that the service means service of any description which is made available to potential users and includes but not limited to. So that takes away the actual exclusion because it has not been expressly excluded. Over the next few minutes, let me just take you through on what can be the implications of this new Consumer Protection Act 2019. I would take you to a judgment, a case in April 2018. This is an actual case, but we have concealed the details, identifying details. The patient was a surgeon himself with multiple comorbidities who was referred to a renowned endoscopy center from interiors from a smaller town for diagnosing and treating the biliary colic, which was diagnosed on the basis of deranged liver function tests and ultrasonography by the referring physician. An endoscopic ultrasound and ERCP was performed on the patient. Roundworms were detected in common bile duct, and those were removed endoscopically after giving a wide biliary sphincterotomy. Albendazole suspension was injected after complete ductal clearance, and this was followed by putting a stent 10 French in the common bile duct. The patient was discharged on the very day of the procedure of sphincterotomy and stenting of the CBT. But on the same very day, he developed abdominal pain and he took some local treatment because he alleged that the endoscopist was not available to his calls. Having said that, a CT scan was done on the 9th post-procedure, that is post-ERCP day, and that reported that a CBD stent is displaced and seen with the upper end in the 3rd or the 4th part of the duodenum, and it was extending inferiorly into the region of right iliac fossa. There was focal peritonitis and edema was also noted. Exploratory laparotomy was performed 2 days later. The CBD stent was found to have been migrated after perforating the 3rd part of duodenum with a localized abscess cavity. In addition to the removal, of course, the abscess was drained, and other than that, cholecystectomy and feeding jejunostomy were also done on the patient. He was discharged 1 week later. What were the allegations of negligence? That there was incorrect diagnosis. The doctor did not take informed consent and did not take the risks. And a metal stent was inserted in the CVD after a wide sphincterotomy, which was not indicated. Remember that these are only allegations. These are only allegations in front of the court of the law. And further, he did not advise, the patient was not advised immediate hospitalization even when he complained of severe pain on the same day of discharge. He avoided taking phone calls or corresponding in any manner with the patient after bringing to his notice that he's been having severe pain. And further, he did not attend to the patient immediately on hospital admission, where he was admitted for doing a laparotomy. Finally, he claimed for 25 lakh of rupees for negligence. As is usual, the doctor denied all allegations because this is what the advice usually is. So the judgment is that prima facie there was no negligence found in the treatment of the complainant because there were experts produced from both the sides. So the judgment was that. However, the deficiency of service was established on the basis of the fact that there was no written consent obtained by the patient, from the patient by the surgeon. And there is no document record giving details of the consent and the OPD procedure carried out. So there was no documentation. So that's the reason why deficiency of service was established. The doctor was ordered to pay more than 13 lakhs, the breakup you can see. Now let us see what would happen. This was under the CPA 1986. The judgment came in April 2018. What would happen if the case was to happen today? So I'll take you to 2023. Now the patient asks the endoscopist to apologize. The endoscopist is smug in the belief that healthcare has been excluded from CPA, so he says go ahead and dares to file a case against him and refuses to apologize at all. However, a few days later, when he gets a notice from District Consumer Dispute Redressal Commission of Madhubani in Bihar, he's shocked to get that notice. And the claim is 5 crores in today's day. He contacts his lawyer in disbelief because he's always believing that healthcare has been excluded. He's no longer supposed to have got that notice. The lawyer now explains him the new law. And I'm going to explain it to you now. So remember that there were no amendments were made on CPA in CPA 1986, which was repealed. And it is a new law that has come up. As far as removal of healthcare services is concerned, let me give you 2 examples, two explanations. Section 1 says clearly that save as otherwise expressly provided by the central government by notification, this act shall apply to all goods and services. So, what is all goods and services? Since the government has nowhere expressly stated in the act that healthcare has been excluded, so it remains within the purview of CPA. Similarly, Section 2, subsection 42 defines the service. What is a service? Service of any description which is made available to potential users and includes but not limited to banking, financing, etc., but does not include the rendering of any service free of charge or under a contract of personal service. I'll explain these 2 terms to you now in next slide. A medical service would be considered free of charge only if this is true for all patients, which means that in a hospital, if a patient is treated absolutely free of charge for pneumonia, but another patient pays something for his CT scan, then the person who is treated absolutely free can also sue for damages for medical negligence. There is a difference between contract for personal services and contract of personal services. For services establish a doctor-patient relationship where it is the provision of service is not dictated by control. The person asking for service is not controlling you, but rather one's skill as happens with the doctors. On the other hand, in contract of personal services, there is a servant-master relationship that is established. So a master cannot sue the servant or a chauffeur in case of deficiency of service. Now the battle royal starts. Patient now has the right to file case at his native place and not necessarily at the place where cause of action is accrued. For example, if he comes to the metropolitan city of Delhi or Calcutta or Bombay, but his home is at Madhubani, he can file the case there. Also, he can file the case from where he is working. So he can do it anywhere. Section 34 of District Commission says that District Commission, very important this, District Commission shall have pecuniary jurisdiction to entertain complaints where the value of goods or services paid as consideration does not exceed 1 crore. It has been modified to 50 lakhs, as you can see in the red. But it is not the compensation demanded. So what is determining this thing is now the bill paid, consideration paid for the services. And in state commission, this limit is up to 2 crores and beyond 2 crores, it is in the National Commission. What is the implication? Implication is that most cases will be filed in District Commission. At the risk of inviting wrath of the Supreme Court, may I say that the competence and integrity of the judges or the members in District Commission is suspect. Endoscopist requests appearance via video conferencing, though it is permissible, which means it is permissible through electronic means, but the arrangements have to be there. There were no arrangements in Madhubani district. So he has to appear in person or through his lawyer, and it is advisable that in such cases he should appear in person. So on realizing the difficult situation that he is in, the endoscopist wants to settle and go for mediation. Now that is the only silver lining in this dark cloud, wherein the mediation is permitted. So there is a provision for settlement or partial settlement through mediation. Having said that, there is some ambiguity now. Consumer Protection Act rule states that the matters relating to proceedings in respect of medical negligence resulting in grievous injury or death will not be referred to mediation. Now, see, as far as surgery is concerned, the moment you give a cut, there is always a grievous injury, depending on how the judge perceives that. Good point is that once settled, one can't appeal against the settlement and done through the mediation. So plaintiff in this particular case refuses for mediation and persists with fighting the case in district commission. Judgment again is that no negligence is found. However, deficiency of service is established because of consent, which was there earlier also. This time the defendant is ordered to pay 1 crore towards cost, towards surgery bill, etc. and mental agony. In addition, unfair trade practice provisions are invoked, and an additional amount of 10 lakh rupees is imposed on as fine. Now, what is unfair trade practice? It also entails a punishment or jail of 1 year imprisonment and up to rupees 10 lakhs fine by the Central Consumer Protection Authority, which is an overseeing body. Section 49 and 59 give the new act unfettered powers because they can declare any terms of contract which is unfair to any consumer to be null and void. Now, they consider that unfair, which is again very subjective. Unfair trade practice includes overpricing, decisions, breach of confidentiality, advertisement, etc. And a recent judgment of the National Commission, Vinod Khanna versus R.G. Stone, on a pre-printed generic consent form has been given as an unfair trade practice, although that has been stayed by the Supreme Court now. So unfair contract includes imposing on the consumer any unreasonable charge, obligation or condition which puts such consumer to disadvantage. Again, very subjective, very ambiguous. So as you can see, these are very subjective definitions. Endoscopist wants to go in appeal. He will have to deposit 50 lakhs in commission before filing the appeal. Can you beat that? Because he's been ordered to pay 1 crore. There's no clarity yet whether this deposit would be refunded. Same conditions are imposed for filing an appeal in National Commission or the Supreme Court, whatever the case may be. Further, very important, let us say that you can't neither pay 1 crore nor do you want to pay 50 lakhs. Non-compliance of an order of commission is punishable with imprisonment for a term which shall not be less than 1 month and can extend to 3 years. Also, a fine or fine of 25,000 which may extend to 1 lakh. This is my final slide. So there is certainly no cause to celebrate. There's cause to mourn. Remember that in 1986 CPA, there was a frivolous case and there was a fine also which could have been imposed onto the complainant. But there's no such provision now. There are new inclusions which include e-commerce and telemarketing. So your telemedicine also comes under this CPA now. Extended definition of deficiency, as I told you, that this would also include deliberate withholding of relevant information. The new act give unfettered powers to the state and national commissions. And an appeal can be filed in the National Commission only if it involves a question of law, which means you can't go just because you're not happy with the judgment. Only if there is the judge in the district court or the state commission has erred on the question of law, can you go and appeal. Thank you very much for your attention.
Can I just ask one question? The patient was himself a surgeon,
Yes.
wasn't he?
Yes.
So why was he waiting for 9 days to even get a CT scan done? I mean, why did the endoscopist not pick this up?
Kedia, Dr. Kedia. See, I have given a disclaimer on my first slide. Okay. You may ask me the questions which are linked to medico-legal this thing rather than the technicality of the ERCP or what.
I'm just mentioning this.
Right, it's a huge, it's a huge this thing, and you know, when the cases come, the lawyers bring up the stories.
Sir, is it mandatory to have informed consent in written, or can we have a pre-printed formats?
Pardon me?
Do we have to take informed consent in writing, or can we have a pre-printed formats?
No, you should. The consent. It's a one full day's conference that I can take on consent. It has to be written consent. wherein everything is written, including indication, the chances of failure, the risks, the benefits, etc., etc.
Thank you, Dr. Ashwini. I think we'll have lots of questions coming from the audience.
So we have
Let
the
Dr.
last
Nagpal
15
also.
Before the next talk,
Yeah.
I just want to add one thing. The District Consumer Dispute Redressal Commission has powers of civil court. And if you do not obey that order, not only is there imprisonment up to 3 years, fine up to 1 lakh, they can attach your property. If you decide to commit suicide, your legal heirs will have to pay. It doesn't end.
Okay, we are in the wrong side of the law, I think.
My point is, we cannot prevent unless we are united. And in India, there is no such law. What a judge thinks on that particular day, that became a law. Most of the doctors are not aware that after the collegium system, all these things developed. Before the collegium system, before 1990-91, there were no such. Only things developed. Now what a judge thinks on that particular day, it became a judgment. No law established. When the Supreme Court gave that this is the evidence you cannot do, that is given by a single judge. And when most of the doctors, now Ajit Bharati is doing a lot of good things for all people, criticizing bluntly, they were not expert to decide the medical cases. First question should come to the judges. That they are not expert to give the verdict in medical, you are not expert. Just like Attorney General argued in demonetization cases. You are not financial expert to give it. My point is to create the doctors' awareness, not only doctors, to everybody, that what is going in this judiciary and in this collegium system,
Yes, sir.
how they are making the laws. Instead of the parliament is entitled to law, not the law meritorious collegium-based judiciary.
Sir,
That
we
is my
allow-
point to the everybody.
We allow Dr. Nagpal to talk and then we come back, because so many things beyond our purview are discussion. We cannot discuss politics and judiciary here, but we see what best we can do to protect ourselves. Dr. Nagpal, please. He is going to discuss on whether the existing law has affected actually the doctor-patient relationship adversely. The answer is yes. Yes, sir.
And these are litigation are increased, how to exploit. And there is no consumer court on the advocates.
I know, sir.
They are not picking the court. Nobody is raising why doctors is included in consumer court. Why the lawyers are not included?
Yes, sir. So many. I think we have to discuss in the parliament. I think so many things are beyond our control. I think there is no need to be excited. Dr. Nagpal, more you delay, I think more will be postponed. I think.
So my topic today is, has law affected the doctor-patient relationship? The question sir has raised, I will answer in detail whenever you catch hold of me later. Ashwini will be very happy. I'm going to finish this talk today in one slide. He is very upset with me every time I overshoot the time which is given to me. So I'm going to finish the talk today. But you are scientific people. You need convincing. My say-so is not sufficient. So the issue is, there is a fear which is palpable today. IMA had conducted a study. Medicos Legal Action Group, we have conducted studies regarding violence. And it is clear that majority of the doctors today are stressed. Happiness? I wish Dr. Randeep Sood was here today. I would answer many questions of his regarding happiness. I would have answered many questions today regarding many talks I heard yesterday in the Hall D. But the point remains, doctors are stressed. And they are stressed because of violence. They are stressed because of litigation. So if you ask me, what is the evidence? The first question is law affecting the doctor-patient relationship? Yes, doctor-patient relationship is diminishing. It is deteriorating. There is no denying this. Why do we say that? We say that because of all these reasons. There is increasing litigation against doctors, increasing violence, increasing negative narrative and abuse in media. Doctors do not want their children to join medicine. What does this say? Doctors were asked to vacate flats in housing societies during pandemic despite being the frontline workers. थाली बजवा लो, बहुत अच्छा काम किया है डॉक्टर्स ने, मगर फ्लैट वकेट कर दो. Increasing defensive medicine, doctor shopping. There is a lack of trust. One person goes and shows Sandeep Dhawan, next day he has to come and show me, and he will not show me the report of Sandeep. He will discuss with me first, then he will bring out the Sandeep's this thing, this is what Dr. Dhawan had told me. But there is a lack of trust. Then this idiot syndrome, internet-derived information obstructing treatment. There is a full talk on this thing. We have too short a time. I will not go into the details. And doctors are exiting the country or the profession. And these are not doctors who have just done MBBS or MD. These are doctors who have come into practice, practiced for 2, 3 years, 5 years, 10 years, and mid-practice they are leaving. What is the reason? We have under RTI asked PGI and 52 government medical colleges all across the country. Give us the data of the number of residents who have joined, worked for 3 to 6 months and then left the program. We were talking about Guru Dakshina yesterday. Guru Dakshina in our time made sense. Today a guy who has paid 3 crore for the DM seat, he thinks I have bought it. He is not concerned about Guru or the Guru Dakshina. We should have made sure he did not have to pay 3 crore for that education. We were the leaders. We have not done that. And bright youngsters today are opting for professions other than medicine. Can anybody tell me what is the cutoff percentage of NEET undergraduate this year? Huh? Sir, kahan ki baatein kar rahe ho? 16.25% marks is what is the cutoff. 16.5% marks वाला जो है वो डॉक्टर बनेगा और कल को मेरा और आपका इलाज करेगा. This is what is happening. Can this move forward with this? If law has in some way caused or promoted any of the indicators I have mentioned in the previous slide, then law has affected the doctor-patient relationship adversely. And when we say law, the law can be parliament or legislature made law, or as sir was pointing out, this is your answer, judgments of Supreme Court under Article 141 of Indian Constitution. They take the force of law unless parliament overrules it. So you cannot say judges can themselves decide and lay down the law. My question is deteriorating doctor-patient relationship a disease? Well, it afflicts living human beings. It can kill those who are afflicted with this disease. Idiot syndrome is one example. I can give you multiple examples of idiot syndrome. Golden hour loss. Our Prime Minister, when he goes on election speeches, he is talking about छल्ले डाल देते हैं और वो अमेरिकन होते हैं और इंडियन होते हैं और इमरजेंसी क्रिएट करते हैं. Now, when a person with acute myocardial infarction comes to an emergency and doctor today advises a stent to be placed, he has a doubt in his mind. While we were coming, Ashwini got a call from a relative of his कि जी वो डॉक्टर साहब तो स्टेंट डालने की बात कर रहे हैं. Now, they have his trust, so what he says they will follow. But how many patients have doctors on their direct speed dialing? And some people will hesitate in getting that primary angioplasty, and some people out of those, some will die because of not having that primary angioplasty. What is the cause of death? Is it MI? It could have been treated. The cause of death is the deteriorated doctor-patient relationship. Head injury. The decompression has to be done. Doctor साहब वो मेरे चाचा जी आ रहे हैं घर से, वो बताएंगे. You have cholangitis after, I mean so many examples, all of you are well aware. Then judiciary lays down procedures. You look at Samira Kohli versus Prabha Manchanda judgment regarding how consent is to be taken. and this common cause society. Every day doctors face the problem that patients' relatives cannot afford to pay for the patient on ventilator. And they request with folded hands ki doctor sahab isko nikal do. Do you have any idea what is the legal procedure how to remove a ventilator? Well, you can. Ma'am, you can. No. Read the Common Cause Society judgment 2018. But the procedure is so convoluted. Effectively, I do not know of a single doctor who has followed that procedure. How many of you have made an advance directive? Dr. Naresh, why not? Tomorrow, if something happens to me, how I wish to be treated, it has to be an advance directive. But none of us does it. So the legal process which has been laid down for these issues is so complex, and the decision has been taken away from the doctors. It can unnecessarily increase the cost of treating this disease in addition to the basic disease. The deteriorating doctor-patient relationship is a disease in itself, and what the patient comes with will cost X amount. Treating this deteriorated situation is going to cost X plus Y amount. Defensive medicine is there, obviously. When a patient comes to me and I know exactly what the problem is, I can treat the patient easily without doing an endoscopy. I can easily treat the patient without doing a colonoscopy. But डॉक्टर साहब उन्होंने तो कहा था कि अंदर से फूड पाइप चेक करा लेना. I got a 4-year-old child 3 days ago. The mother is coming to me कि जी pediatrician ने कहा है इसकी फूड पाइप चेक करानी है. Why do you need to give anesthesia to a child of 4 years to do a diagnostic endoscopy in a child who has been having occasional vomits once or twice in a week? It does not make sense to me. But the patient will go to 10 doctors and maybe 2 will do it. And that anesthesia itself will cause death. It can be associated with significant disability. It can spread to others and has already become an epidemic. In PGI, you see one patient party beating up a doctor. Another patient party sitting in the other corner also thinks they have the right to do the same. This is infectious. One person thinks there is a newspaper report that Dr. Naresh Bhatt has been penalized with, let's say, 50 lakhs. And his previous patient thinks, oh, he had done the same to me too. Let me also go to court. So this is infectious. So I think this is a disease. And what is the etiology of this? Consumer Protection Act 1986, overly generous and unrealistic judiciary, propaganda by press, political and civil society, stingy government investment in healthcare. One of the most important reasons are these two. Local politicians' desire for notoriety. They act as catalysts. वो आग लगाने का जो काम होता है, MLA की सीट नहीं मिली, कोई बात नहीं, अगली बार मिलने के लिए you have to come into the limelight. How do you come into the limelight? There is death occurring every day in PGI. There is death occurring every day in any hospital. Go there. Some patients will be disenchanted. Encourage them. Throw a few stones. Negotiate. Have some 100 people gathered over there to make slogans. Corporatization of medicine and increasing use of technology is also one reason. But again, doctors are not responsible for this. Private for-profit medical education. Haryana government says it costs them, they are going to charge 30 lakh fees from the government students in MBBS. Where is the guru and where is the guru dakshina? If you don't want to pay that fees, you have to work for 7 years as bonded labor for the Haryana government, which has been reduced now to 5. We are thankful for that small mercy. Selective use of law and order machinery. आप एक थप्पड़ किसी जज को लगा के देखो, सुप्रीम कोर्ट से आपके ऑर्डर आएंगे, आप चाहे जुडिशियल मैजिस्ट्रेट फर्स्ट क्लास को आपने थप्पड़ लगाया हो. You will be, suo moto notice will be taken. When daily doctors are beaten up right, left and center, the court can't hear, can't see. There is selective blindness, selective deafness. Rampant quackery and cross-pathy is there. Deliberate state-sponsored health illiteracy. This is very important for the state. If it does not want to invest in healthcare, that the people do not start demanding quality healthcare. For that, it is very important that they sponsor Ayush and mixed treatment, integrative medicine, because this confuses everybody. Insurance foray into medicine is another reason, but as I say repeatedly, this is also a talk for a full 1 hour. I will not go into the details of this. And when you read the new regulations also which have come, they mention only duties of doctors, rights of patients. There is only one privilege you have, that you can charge for your services. Thank you so very much. You want me to pay 30 lakhs to a government institution, 1 crore to a private institution for MBBS, and you are giving me your generous gift of allowing me to charge. The propaganda, doctors place stent unnecessarily, steal kidneys, doctors do cesarean unnecessarily, dead body on ventilator, declare patient, harvest organs. This was also there. Doctors are sponsored to go on Dubai. And the Prime Minister in UK, when he was with the press, when he made this statement कि doctors को तो sponsor किया जाता है इस चीज के लिए यहाँ और यहाँ, the meeting itself was sponsored by one of the pharma companies. Doctors write expensive medicines, doctors do investigations only for money. I mean, the propaganda is phenomenal. You have suddenly pressed the accelerator and started increasing the MBBS seats, the postgraduate seats. We do not have the infrastructure, we do not have the facility, we do not have the staff to maintain this. Tall election promises, myth is propagated that private hospitals shall provide free treatment. Ayushman Bharat is this. If a rate which you are giving is a viable rate, obviously you expect problem or conflict. Opening of new medical colleges and aims. As I said, no proper facility or infrastructure is there. No funds, passing the buck. When you discuss with the central government, make a representation, they say health is a state subject. So we can't do everything. Overworked contractual doctors and delays in appointment of resident doctors. In our time, if we finished our tenure on 30th June, 31st or on 1st of July, we were working. Today, there is forced unemployment of 6 months, 7 months, 8 months, and there are 3 sets of residents, first year, second year, third year. The third year has passed and gone, the first year has not joined, it is only second year which was working during this COVID period. Obviously, conflict is going to arise. But who tells the judiciary all this? Brunt of the blame is of poor outcome is on doctors, and they can't do the same to other health workers because they are organized, unki union hai. This negative sentiment, newspaper headlines. I postponed a case for 3 days because PTI report was not available to do a sphincterotomy and then go ahead and remove a migrated stent. What was the newspaper headline? Doctor leaves operation midway. This is the kind of thing which creates distrust, which creates conflict. And law is driving a wedge between doctors and patients. So if you permit me, I will take 5 minutes more.
Please go ahead, sir.
Consumer Protection Act, your entire focus is on documentation. Patient ko resuscitate kara ya nahi kiya, not important. You have to write down कि मैंने उसको cardiac massage दिया, मैंने उसको atropine लगाया, मैंने उसको intracardiac injection दिया. जो भी आपने किया या नहीं किया वो लिखना ज्यादा जरूरी है. करा है या ऑक्सीजन लगाई है या नहीं लगाई, it does not matter. When I am talking to a patient, I am more focused on नाम क्या है, age क्या है, sex क्या है. The person, after I have done my filling, when I look up, the person is my first girlfriend from my school days. And she says, Neeraj, ye kya hai? What kind of rapport am I building with my patient? I am focusing, there is no eye contact. And the law is forcing doctors to discriminate between patients. Profession has become a trade, treatment a commodity, forcing doctors to go against their ethics and act against patients' interest. These are 2 very, very important things. If I get 2 minutes, I will explain. Because if I take a knife and stab Ashwini, or I take a knife and stab the person who is standing there. My punishment should be same, but it is not. Under Consumer Protection Act, it depends on what he earns and what he earns. It does not depend on what my crime is. This is where the problem lies. During COVID, you have emergencies, you had so many patients on Ambu bag. You have one ventilator which becomes available. Senior resident over there has to decide, I have to give ventilator to one of these two patients. Which patient will he give it to? One patient if dies, he will be sued in crores. The other patient dies, he will have to pay 2 lakhs. So who do you think he'll give the ventilator to? To the one who's rich? So are we agreeing that medical resources in India are going to be the prerogative of the rich? This is what Consumer Protection Act does. Samira Kohli says if you have given anesthesia, you're doing a procedure for which the patient has given consent, and you find something which is needed, which is in benefit of the patient, you cannot do it. You have to let the patient come out of general anesthesia, give a consent on a different date, and then go ahead and do it. 2 anesthesias, the risk of anesthesia has doubled, the cost of everything has doubled. But the court says very clearly, it may be in the patient's interest, but you have nothing to do with it. It is law is interfering with my medical ethics and work. PCP and DT Act. It's a social problem. You cannot have a bureaucratic pill for a social ill. If males are selectively preferred in India, I mean, Clinical Establishment Act, you need compliances over patient care. This I have already covered, so I'll rush through. There are unrealistic judgments which have come in. India, we have 70% healthcare in small and medium healthcare sector, which means 30 beds or lower, which means small clinics. And we have weird judgments. I mean, if I tell you, if I have to write what all facility I do not have in my nursing home, it will require 45 pages to fill that. I don't have this equipment. And Apollo Hospital was penalized because they did not mention that they do not have machine to check methotrexate levels. I don't know how many of you have that. Section 302, murder charges have been applied against doctors. And the decision to remove ventilator, this is a full topic on its own. These judgments and these laws make it mandatory for you to treat emergency patients. They do not create any mechanism on how you are to recover the cost. No lunch is free. There are no free lunches in the world. But this is what the law is forcing. And obviously this is going to create a discord. Physicians are frequently becoming targets of political repression. Even in foreign countries, this is there. Binayak Sen, I don't know whether you know this gentleman, he was working in a tribal area and treating tribals. So he was put in jail ki tu Naxalite hai. Routine test for fallopian tube patency. The judge is saying if the patient had died, it would have been better. Because the patient is in a vegetative state, so you go to jail. Great. And this is not only India. Look at this bill. Reimplant ectopic pregnancy or face murder charges. This is US. Fashion or trade? Consumer Protection Act says we are trade. National Medical Commission says you cannot have self-regulation, you cannot have autonomy. If you look at the definition of profession, you have to have self-regulation and autonomy. So supposing in 1947, the Britishers had said, okay, take your country, but we will appoint 500 Indians to the parliament. Appoint. You will not elect. And if we like, we will overrule their decisions or we will disband it altogether. Would that have been acceptable as a democracy to India, as a Swaraj? This is what National Medical Commission has done. Regulatory body should be representative and elected by the professionals, not like this. Jacob Matthews, State of Punjab, all of us clap ki yes, very good, we have now some protection against. Protection was already there in Indian Penal Code. Why did we need this? This has simply put a stamp of authority that yes, doctors can be prosecuted in criminal courts. So this is not a good judgment. I say this is a very bad judgment. Because IPC had already given us all that protection. CPA 1986, CPA 2019, डॉक्टर साहब has covered very well. आप अमेजन पे जो ऑर्डर करते हो, आपके अगेंस्ट कंप्लेंट्स वैसे ही बेडरूम में से बैठ के अमेजन पे अब की जाएंगी. This is all because no patient obviously pays more than 5 lakh to 99.999% doctors. So all cases are going to district forum. There is going to be no fee. He can file from anywhere. And the quantum of compensation, this is just escalating. Not only the Kunal Saha judgment, there is a cascade effect after that. And not only in the consumer courts, you have all these places, including the court of WhatsApp justice and media trial, where you have to defend yourself. The consumer courts are in addition to these remedies. This was what I feel when I am told कि जी डॉक्टर पहले तो बड़े एथिकल हुआ करते थे, चार्जेस बड़े नॉमिनल होते थे, कोई टेस्ट नहीं कराते थे. और today earlier the doctor and the patient both were fighting the disease. Today the doctor is fighting the disease, the cost, the ignorance, the insurer, the government, the courts, the patients, and the press. How is the cost going to be the same? We have now defensive medicine because of all this. Excessive investigations, excessive specialist referrals, unnecessary hospitalizations, unnecessary invasive procedures. Doctors have started avoiding risky procedures. What my experience is today was not what my experience was 30 years ago. But I have stopped doing all the high-risk work. Increased cost of healthcare, focus on clerical work, demoralization. This is a fact. What is clear is cost of treatment has nothing to do with the deteriorating doctor-patient relationship. 70% of the violence is in government institutions. Government institutions cost is not the issue. Most experts will tell you improve the communication skills, problem will go. I tell you no. Are doctors not at fault in this decreasing doctor-patient relationship? We teach the false narrative that medicine is a noble profession. We are no longer a profession. How can we be noble? We refuse to unite as a group and follow a leader. We are an army of generals. Each one has his own views. We have let our organizations and associations be dominated by a non-representative few. We refuse to become proactive and believe in get beaten, go on strike hypothesis. This is our response to all events which occur. We are basically cowards who have been taught since the beginning of our careers to tolerate injustice. पुराने जमाने में ना डॉक्टर के बेटे को टीचर मार नहीं सकता था, तो एक बच्चा उसके प्रिंस के साथ भेजा जाता था. If the prince did something wrong, ये जो बच्चा दूसरा भेजा जाता था spare, he used to get beaten and he used to be called the whipping boy. And doctors today are the whipping boys in India. Summary, we have a feeling of prosecution fueled by irresponsible media, and propaganda has been used to blame doctors for failures of successive governments. It is the failure of successive governments. These are not the solutions. This bridge course for quacks and universal healthcare, generic medicines, free subsidized treatment, this is not the solution. Integrate with the society, promote health literacy, legislative approach, legal approach, coercive approach. We will have to use all this. Pump money into healthcare, eradicate quackery, remove cross-pathy, create a conducive environment for medical entrepreneurs, and strict implementation of laws to prevent violence against doctors. There's a broken window principle. Person throws a stone at your window. If you do not take action there, next time his escalation, his violence will escalate from simply breaking your window. Take action at that level. Send all your injured staff and doctors to nearest government hospital, get a medical legal report prepared, follow it up. Do not settle and remove medicine from CPA. Medical Legal Action Group made a representation to the government for a medical injury compensation and liability bill. These were the points in that. And attend events beyond gastroenterology. 12th of February 2023. We are holding our 9th Medical Legal Action Group annual conference in Chandigarh, and this will be a whole day on various topics on medical legal issues. So I invite you all and all those who feel that we are NABH accredited, we are JCI accredited, send me one file. Just one file where you have done a procedure, patient has remained in ICU for 3 days, redact all the name of the hospital, redact all the name of the patient's identity. If we are unable to find a fault in your file, we will give indemnity insurance worth 1 crore to the team leader. Thank you so very much.
Thank you, Dr. Neeraj. I think you raised more questions than answers. I think this is a very hot topic. Morely discussions only will raise more problems and more, confusion. But ultimately, I just wanted to you to tell what is the best policy a doctor should follow today, 2023.
He didn't live up to his promise. He said he'll finish in time.
He has done it. He has done it.
Sir, I have one
So,
question.
the policy for the next 2 decades, I do not see a very bright future for the medical professionals. So as the first part of the policy, I want you to stop forcing your children into medicine. If they are really interested, let them come. Don't force them. So as part of the policy, yes, healthcare as a business will boom. But healthcare professionals will have a very tough time in India in the next 2 decades. So that one. Second, we need to, I have doctors who come when the problem is there. And when I tell them, we have held so many conferences, why have you not attended? This all has been discussed umpteen times. You may be a head of department in a government medical college, you still require indemnity insurance. Why do you need to be reminded of that when you get a claim of 1 crore? These are things which are simple. You should be proactive yourself to learn, and the knowledge is available. This is going on everywhere. This is not only here. So, I mean, we need to start developing an interest in the subject or in our problems, and then only we'll be able to.
Sir, I have a few questions. So first of all, I think there is a Facebook group that you have already started. So is there any book or something, you have any pages or something where we can read all these previous reports and we can learn from
So
them?
I had published my first book on medical negligence in 95. Second book was published in 2004. After that, I stopped because internet came in, and internet gives you sufficiently more data than what we can research and provide in a book. There is Institute of Medicine and Law, which is publishing many books. There is Dr. Gitendra Sharma and Hitesh, they publish books. IMLIA is there. They publish books on medical legal issues. So if you wish, you can go to all them and get the info.
Okay.
My book should be coming soon.
Okay.
It is called as real solutions to practical solutions to real problems.
Yes, because whatsoever you have highlighted is absolutely correct, but we have to have a realistic views that now at this age we cannot change the profession.
Sir, the first thing is start listening.
Yes.
Don't come to my office and tell me, Neeraj, I want to commit suicide. I have had 7. No, I have had 7 doctors. And it is not a nice feeling to have a 68 years old doctor sit across your table and tell you, Neeraj, I am so harassed, I want to commit suicide. And this gentleman was head of department of an institution and major government institution.
Second thing, sir, what we can do is, I think we should also push that this should be an important mandatory subject from the MBBS curriculum, and it should be even in MD and DM curriculum.
So to some extent, they have started. To some extent, I'm invited to deliver lectures in medical colleges also. Rohtak also have given.
But sir, it should be a paper based.
And
then people will understand the importance.
National
and
Medical-
we have to,
Medical Commission has accepted our suggestion.
That has been started.
My one point is, whatever teaching you do in MBBS in law, it will not change till we are get rid of collegium system. The second point is, in India there is no law, different courts are giving different judgment on the same matter, same year. And there are division benches.
Sir, we
One
can only
benches will
discuss.
give a different. No, that is very important for every doctor to know why the doctors are suffering. Because of there is a deliberate litigation how to bleed doctors by the corrupt advocates, and these laws are delivered by the judges to increase it. When the people will realize that these litigations are forced on doctors, these laws are forced on doctors, These are not warranted. Non-warranted laws. These consumer, why they have not done anything in their Bar Council of India, they changed Medical Council of India. But there is no change in PCI and BCI. No doctor is putting any effort.
I'll answer your question. Sir, I'll answer your question. I have filed through Medical Legal Action Group 5 cases in Punjab and Haryana High Court, 1 in Bombay High Court. Even against Consumer Protection Act, we had gone to Supreme Court, and we have 4 cases going on in Supreme Court. My question to you is, what have you done? Have you contributed to our effort?
Yes, sir. I am writing every day against our inefficient, low meritorious judiciary every day. And it is the day will come, the doctors will get eradicated when they know the real picture. Then why these judgments are going on? Because of our non-meritorious judges, low-grade graduates from a different substandard law college, and they are delivering, and that is considered as a law.
Sir, shouting doesn't help here.
I just disagree. One point, I just disagree. There was no provision in the constitution. The judge will make the judge. They rejected NGSC with their interpretation that we can take the law and we can make the law. Law is to be made by the parliament, not by the judges. No constitution has it in it. But they have now forcefully.
Sir, I think this is out of purview of this.
Yes, and I think we'll write to conclude.
We will not talk about the things which are beyond our control, and we should know how to make best use of the existing law.
How do we doctors unite in our country? I think that is the most important.
Ma'am, we have so far only 7 deaths among doctors from patient violence. I'm waiting for 700 deaths. Then maybe we will unite.
The lawyers are very, very united.
No, ma'am, I'm telling you my answer. I'm telling you my answer. We will require cases where doctors have had to pay 200 crores. We will need cases where doctors will commit suicide. We need cases where doctors will be killed by patient party. Then doctors will unite.
Thank you so much, sir. I think you have raised so many questions rather than answered them. I think these are the hard topics which need to be discussed again and again, and then only we'll become more aware of that. I thank all the audience for actively participating at the end of the day. Thank you so much, Dr. Neeraj and Dr. Ashwin. Thank you so much.
Very good evening, everyone. Welcome to our General Body Meeting of 2022. And let me invite Dr. Mahesh Goenka, the President of ISG, to come on the dais.
Good evening, everybody. I welcome you for this General Body Meeting. As you all are enjoying the ISGCon at Jaipur with great hospitality by the G6 team, I think we would have some serious discussion today about the various issues related to the ISG. I would just say that I had this tenure of presidentship of ISG for the last 11 months, and I really enjoyed this tenure, and whatever small contribution we could do from the Governing Council to uplift the level of ISG, we tried our best, and we'll continue doing that for months and years to come. I must also, at this moment, congratulate the new people who are being inducted in the Governing Council, and an announcement will come very soon. As well as I must thank all the Governing Council members for being so supportive for all the actions which we wanted to take, in particular our Secretary General Dynamic, Dr. Govind Makharia. And I must use this opportunity to thank Nisha, who has supported all the activities, and she was working 24/7 to see that the things are in place. With that, I open the meeting for the evening.
Thank you so very much, sir. And I must start with that Dr. Goenka have been the dynamic president. A lot of initiative. We'll discuss what initiative he has taken, and has been a wonderful, wonderful president. So as I said that the Governing Council of ISG has transformed itself. Earlier we used to have just 2 meetings, one midterm and one in the annual Congress, and the rest of the time, lull time. For last 2 years, COVID gave us opportunity that we have to have online meetings, and Dr. Amit knows and Dr. Matthew and Ajay knows that we had, for last 3 years, the COVID time, we had at least 7 to 8 meetings every year, and this year we had at least 5 online meetings of Governing Council. Second, that the Governing Council of ISG have been very, very supportive. very supportive. Every activity discussed openness, frankness, and collective decision. So each decision what we took was all collective. They also, so therefore, the Governing Council of ISG have been tremendous in terms of supporting each other and taking activity of ISG forward. So now coming to the membership of ISG, again over last many years, again efforts of Dr. Goenka, we had membership have increased to almost 3,120. And last year, we have enrolled about 285 members of ISG. And why it so happened? Because every ISG activity, like our program for training for youngsters or our trainees, to attend any program sponsored by ISG, you have to be a member. Therefore, we had a large number of members this year. And now for membership, you can just go to website. Membership is online. You can pay. One can become a member just like that. And online membership is much easier. At this time, if there is no member out here, non-member, may I request them to leave the hall. Right. So coming to ISG election, and ISG election held by Dr. Sandeep Nijavan, the President-elect. May I invite him to announce the results.
We had online election pattern, and there were 2,280 eligible ISG members who could vote. Out of them, 1,345 members voted. That means the voting was 59%, so it's a good number actually. And every member was actually informed multiple times, and voting was open for more than 3 weeks. So enough time was given, but still actually we want that this number should increase further in next year elections. For Secretary General elections, there were 2 candidates, and Philip got elected. So congratulations to Matthew Philip. Then we had election for the president, and Govind actually won the election. So he is our new president-elect.
Thank you so very much.
Our new president-elect this year. We had 2 governing council members coming in. So the first one was Sudipto Chaudhary, and second Bhaskar Nandi.
Bhaskar.
So congratulations to all who have won. And I think one post is getting vacated because Matthew is getting upgraded to Secretary General. So we in Governing
would discuss in the next Governing Council.
Yeah, that will decide. Thank you so much. Thank you.
Dr. Nijavan, thank you so very much. The election done very elegantly. I think all of you agree that doing online voting was so easy, and we have almost 1,300 plus people voted. So it's 2 things, that the involvement of each one of you in the ISG activities, that's a fantastic, and online voting is had added value to our society. Moving forward, coming to ISG awards and orations, and you know that the ISG award were given, all of you are aware, just to report to the general body, that the FPNTR Lifetime Memorial Award was given to Dr. Jayanti, and this is the highest award for our society, and given to those teachers or those members of ISG who have contributed immensely to our society. So this time, the Governing Council and the committee decided to award to 4 people: Dr. Jayanti, Dr. Ramesh Ruprai, Dr. Kochar, Rakesh Kochar, and Dr. Gauradas Chaudhary. And all the awards were conferred a day first today during inauguration day. Again, there are 3 orations. One, the P.N. Chitani oration. is to be delivered by Dr. B.S. Ramakrishna in next year. The C.M. Habibullah oration by Dr. Ajay Duseja and Dr. Rakesh Tandon oration by Dr. Vivek Saraswat. This year, Dr. V. Balakrishnan Distinguished Credential Award was conferred to Dr. V.G. Manu Prasad for his distinguished service to our society. And S.R. Naik Award, a memorial award, which is the award given for the best publication in one calendar year 2021 is Sunil Taneja from PGI Chandigarh. And one of the young distinguished person, which award is called ISG OP Memorial Award, given to a person who is less than 40 years of age, but has contributed to Indian gastroenterology, is Dr. Sridhar Sundaram. This year, this initiative of Dr. Goenka, that we have 19 state chapters, and each chapter is doing a wonderful work in their own capacity, and therefore this was decided that we should award a state chapter award, best state chapter award, and this year we had 3 applications, but Kerala chapter got the award this year, and this award was conferred during the inauguration. And also I want to highlight this point of time that Kerala chapter of ISG have been remarkable in their activities, and they have published this book. This is a book which is a kind of coffee table book, and this is done by inside the wonderful pictorials and wonderful articles. And thank you so much, Dr. Matthew Philip, Prakash, and the whole team of the Kerala chapter. Moving further, last year we started Masters of ISG, and this year we gave a 20 Master ISG Award, and this was conferred today afternoon in Hall E. And so is a fellow of ISG, 33 this time, and this award was conferred today in the afternoon. And also all these awards happen in the as ISG calendar, and in the month of probably June we'll announce these 2 awards, Master ISG and Fellow ISG, and every member who qualify for this award are eligible. Please do apply for this award as the call comes in month of June 2023. And this is a group photo taken. So I just got one group photo of fellows, but again, all the photos taken today will be posted online. Also, the ISG started giving the Best Thesis Award to the thesis published into a publication, and this year we had 13 theses submitted for application, and 5 of them were awarded the Best Thesis Award this year. Coming to ISG activities, just to brief on that, there are 4 flagship programs of our society, and 3 of them are quite mature, and a couple of them are maturing. The mature program, which is called Young Clinician Program, which is a program for first-year trainees, which is going for the last 12 years continuously, 1 program a year, and in this about 100 first-year students participate for 3 days of training. Then second program is Gastroenterology Young Master. This program is again happening for the last 12 years continuously, 2 programs per year, 1 program for North and East, other one is West and South, and 2 programs, and this is for 3rd-year trainees who spend time discussing cases in 3 days. The 3rd program we started this year, and for 2nd year, and the purpose was to train them or to tell them the best clinical practice guidelines of important GI disorder. And the first program was held this year. And the last flagship program of ISG is the Train the Trainers, and we strongly believe that training our trainers is very important. And this concept have come from a World Gastroenterology Organization, and we had 1 program of Train the Trainers in 2019, but 2020, 2021 we couldn't hold the program because of a COVID pandemic, but this year we are going to have this program also. So maybe request all of the members to send your students and your colleagues to all the 4 programs. And other program is masterclass, and masterclass have been a wonderful program, we believe. COVID gave us opportunity, and we have almost 38 of 12, 38 plus 12, 50 good classes are there on ISG website, and we get a lot of feedback from the members and students that these lectures are fantastic and they are very, very useful. And why they are fantastic? Because of all the faculty who participated, they prepared so well. So they want to thank all the faculty members who gave these master classes, and each lecture is wonderful. So there are some of the pictorials of GYM this year, which happened in Coimbatore. Then this is a evidence-based gastroenterology first program in Bangalore, and this is a YCP happened. This is a YCP happened this year in Hyderabad. So this is the calendar of our ISG activities, and we try to make a calendar. All the state chapter, I request that if you are holding your meeting of your state chapter, please let secretariat know that what are your dates. So there is no competition between dates of different state chapters. It's a big country. Certain overlap can still occur, but we'll try to avoid overlap of dates. Some more activities, like one of the important point was that the PPI are used or misused both. So what is the PPI steward step? Just to highlight that the Governing Council suggested, why don't we have a guideline on PPI? And this guideline was led by Dr. Rakesh Kochar, Dr. Sovna Bhatia, and Amit Datta, and his team. And this team has done wonderful work. We had this meeting of PPI guidelines about 2 months back, and Dr. Amit Datta and his team is writing the report, which will publish in our journal soon. And I think this guideline is not just for publication, this is for application practice. I think we should take this guideline to every physician of our country. First to gastroenterologists, and then to physician colleagues of our country, and to what is the best use and how to avoid misuse of PPI. So I'd like to thank all the members of this committee who contributed immensely in making this guideline. The second guideline is a caustic-induced injury. Again, this is an important subject, very relevant to our country. They are not published, they are not wonderful articles on this. Why we thought, why not? We have expertise in our country, and Dr. Rakesh Kochar from PGI, he had done remarkable work in corrosive. And therefore, why not we thought, why not we use his talent or his experience to make this guideline. So Dr. Rakesh Kochar, and supported by Anupam, his colleague at PGI, are making this guideline. So we have an initial draft of this guideline. About 34 or 54 statements are being drafted. Tomorrow we'll have presentation of this guideline, short version, but guidelines still to be done. And other guidelines to be made is a celiac disease guideline. The Goenka was of the opinion that we must have a multi-center studies. And maybe Dr. Goenka want to say?
I think the way forward is that we have enough volume of data, but we need to systematically analyze that. And so we have, for the first time, planned a pan-India colonic polyp study. And we had a very fruitful discussion today afternoon. And I was really impressed by the enthusiasm shown. We had kept only about 25 seats, but we had to increase it to about 45 because everybody wants to be a part of this study. And we hope to collect a data of 20,000 plus colonoscopy being done at 25 to 30 centers, and to see what are the pattern of polyp and what are the types of polyp which we find. And anybody who can contribute is welcome to join this study. I think this will be a golden study from our end. We have called it at this moment as an IPL study, Indian Polyp Study, but we are looking for a better terminology. So if there's any suggestions, please connect with us, and we would incorporate the suggestions. I'm really excited about that study.
And also in the same vein, I should think of if anybody has an idea to start a task force or any multi-center studies, please do come forward and take a lead in that. I think the time has come that all of us together join hands together for Northeast, Southwest, and initiate multi-center studies. One of them is the polyp study, but many more such are most welcome. So every member of ISG is requested to think about it, and if you have any suggestion, please do write to Secretariat. And then again, this book was published, this ISG. Again, I request Dr. Goenka to say a few words, and meanwhile, while I say that, I'll show you the book.
So I think this is something which is very satisfying for us. We just planned it only about 6 months back, and then we thought that we must have this annual book, which was last published 3 years back when Dr. Ajay Kumar was the president of ISG. And we thought because of many reasons there was a gap, and so we collected a list of 40 chapters where significant progress has taken place after the last Schlesinger's edition. And we connected with 40 leading authors and researchers from India, and nobody refused. And with the help of the co-authors, total of about 85 authors are there, and this is a book which has almost about 470 pages. And I personally feel that this will be a very good book to read for not only youngsters, for all of us to get updated about the various aspects. So all the members will get the book. Those who have collected the book here is fine, but otherwise the books will reach your chamber within a month's time through some pharma company.
Also, these two things are available at ISG counter. This is the coffee mug which is made for every member of ISG. Please do collect this mug from ISG stall there. And this is a cup with ISG logo. You might like to keep at your home or your office. So, other important agenda. Our constitution was made in 1960, and since then there have not been much amendments. They were done time to time for our work, but it was not formally changed into our constitution. For last about 5 years, this was agenda that we must redraft, or not redraft, amend our constitution. So over the last 5 years, and led by Dr. G.N. Ramesh and team, they looked at each aspect of our constitution and amended that. So this activity started in 2019 or 18, in fact 18, and we completed this year. And now our constitution was completely, I would say partly rewritten, and this has been sent to all the members of ISG through our ISG web page about 3 months back, with a request that if you have any comment to make, please do make the comment. And we have received just one comment on constitution, and I believe that the ISG constitution is agreeable to all of you. If you say with voice vote, if you all of you say, then we'll approve formally.
Thank you, everybody.
Can you raise your hand? Take a picture. Nisa, take a picture of this, please. Take a picture. Because this will.
Go to the ISG website. It's there on the website. If you have any suggestions, please
those
come
who
up.
agree, please raise your hands. So we want to just for capture.
दीपिका हाथ उठा दो तो देखते क्यों नहीं हो फिर फोटो में नहीं आऊंगा
Well, thank you so very much. I think the constitution is posted on our website. So please go over, and if still will feel that something to be, I wouldn't say change, suggest, then certainly will consider that. Further, one more activity again. This is initiative of Dr. Mahesh Goenka, and I'd like him to speak on this.
So I think this is one of the earlier decisions which were taken as the new governing council started functioning, and we have been traveling all over, and everywhere there is a noise about women in gastroenterology being not done as much as it should be, and there was no activity whatsoever for women in gastroenterology in India whatsoever. So we formulated a group which is led by Dr. Usha Datta and Dr. Deepika Kedia, and they have already started the activity. They had about an hour of discussion today where some of us were there, Naresh was here, and we want to really support this activity in whatever way we can, and we would take it further. I know this is a slow start and a little late start, but I'm sure that this would have an impact of more and more participation of women in gastroenterology, both at the initial level as well as at the leadership level.
And in the same vein, I'm happy to tell that the number of women gastroenterologists is increasing in number. NISA tells us of 3,000 members, they about 180 or 200 are women members. And last year, won the program of first year YCP Hyderabad. Of 100, there are 28 girls. Of 128 girls. So that's a fantastic change in our society, that more and more ladies are taking gastroenterology as their career. And this is for any society, this is a very positive and change, and we must appreciate. And also, many of you are heads of department of gastroenterology, both DM and DNB. If you find a candidate coming for interview, do consider and have a positive or have a more positive kind of approach towards them so that you can take them as your training. Absolutely, absolutely. So unless they come to our leadership role, they have to be kind of a mentor and kind of so ISC has made many scientific committees, and the scientific program is made by scientific committee, which consists of a group of people in luminal, pancreatobiliary, endoscopy, and liver. And this committee makes the program, sent to secretariat, the committee sits and finalizes the program. And for this again, we have been lucky this time to get a great opportunity or great topics by all the scientific committee members. And we like to thank, if this Congress is so well, is partly also because of the scientific committee who thought of the program and gave us the suggestions. So thank you every member of scientific committee to help us in making the program for ISGCon 2022. Other thing which happened last year was there was no policy for endorsement. We get a lot of letters from different societies that we are doing this program, will ISG support it? So we have framed the endorsement policy, and now which is implemented from this year. Coming to ISG state chapters, so as we know, we have a total 19 state chapters, and one state chapter was inducted this year, that is Jammu and Kashmir, and we all of us welcome the chapter of Jammu and Kashmir to the fore. And if General Body approves the chapter formation, then we want to raise your hands.
Is Dr. Yasin here? Dr. Yasin? Okay.
Perfect.
Dr. Yasin was the person who actually worked around developing this chapter, and I must thank him for taking it forward.
So, and also this is very so encouraging that a vast country like ours, we have a 19 state chapter, and each state chapter is fantastic. They do a lot of scientific activity, at least 1 or 2 meetings per day. But we request now that, as we know that 30% of our people will have GI disorder, and most of them are treated by physicians or family physicians. Therefore, we must reach as a specialist to the primary care physicians and secondary care physicians and optimize or help them learn a little bit of gastroenterology of right practice. And therefore, I request each member of society that if you get an opportunity, please go to physicians in small CME, organized CME for physicians, and if you do on the ISG banner, this will be fantastic. So, and for state chapter now, the guidelines have been framed that what are the working pattern of each state chapter. ISG office, all of you probably are aware that ISG, we have bought this office, and with the concept that for any society to rise, there has to be a central secretariat, and with staff at the secretariat, and so that everything is organized in time and as per rules. So all the rules are being framed, the working rules are being framed, and this will be the office in Connaught Place is a bit expensive. We have spent about 2.4 crores, and thanks to all members that we have to be able to raise that money through contribution through different conferences, and this office is to be renovated and should start functioning now. Coming to one more important event to tell you that our journal is doing very well, and it has over time with all the editors, and this journal has come to great height. the article publication, its value, international articles coming to us has been great. And they all have been done because of efforts of Dr. Uday Ghosal, our last editor-in-chief. Dr. Uday. You want to say something? Uday has finished 5 years of his editorship, and our journal is doing very well. Uday.
Thank you, Govind. I will take 2 minutes. You see, currently our estimated impact factor is 3.3. I wanted Springer to publish it in the front page, but they have some legal issues, so therefore they are afraid to put that in the front page. But the site score is not a copyrighted item by Scopus, so our site score is 2.6. Earlier, our impact factor was below 0.7, and the site score was non-existent. Now it has come to 2.6. But remember one thing, very simple. I believe in one thing. Give where you live. Give where you live. We have a tendency to cite the papers which are published from the West, not read our own paper, not respect our own data. So what happens is, whatever happens in the West is not the panacea. They know how much limitation they have, and we don't know how much fortune we have. So what happens is, so you don't know what you have. Unless you see the West, you know how much limitation they have, you will see what we have. So publish paper, keep your data, analyze. One of the things what is lacking in India is how to analyze, how to publish. There is a tremendous publication bias. So international journals have a tremendous publication bias. There is enough evidence now. But what I am saying is, cite your own paper, publish your own data, read your journal. That is what I wish. So with support from all the reviewers, many of them are our ISG members, but many international reviewers, we got now tremendous growth in the journal. Now, earlier we used to get 250 articles along with case report and case snippet. Today we get up to 600, 700 articles when we have removed case report and case snippet. Now 30 to 40% of our submission are from all over the world. And if you take any issue, you will find 30 to 40% publications on a very burning issue, very cutting edge thing from America, Japan, Australia, and whatnot, Europe, are published in India Journal of Gastroenterology. So I'm very happy. I'm going to brief everything in an article as an outgoing editor, and I wish this journal take a greater and greater height, and it should be one of the top journal in the world, because India is a big country, we can do wonder, and that is what I wish. Thank you so much.
I think Dr. Ghosal should be given a standing ovation. Thank you, Dr. Ghosal, for being such a wonderful leader in taking our journal forward. So after completion of his term, we had a selection of a new editor-in-chief. So we have 3 applications. All 3 were interviewed, and based on the interview, and also the demand of experience, based on those 3 things, a committee decided Dr. Usha Datta to be the new editor-in-chief of society. So she has already taken charge since 1st of January, and I think all of us should support our journal and our editorial team led by Dr. Usha Datta. Now coming to ISG conference. First, 2020 and 2021. The Pune team has done extensive efforts in 2020. COVID didn't allow conference to happen, and it was a virtual. Then hope came that in 2021 they will be able to hold us physically, and each one of us interested to go to Pune, but again COVID restricted in 2021. So they were dissatisfied, but they did still get a great congress in 2021 as a virtual. So I'd like to thank Dr. Amol Bape and Dr. Pamela Lavate for their team for extraordinary effort in holding 2020 and 2021. We have already got audit report from them, and we'll examining that and get back to later. Coming to this year Congress, Dr. Javan, want to say?
We, the members of Rajasthan chapter of gastroenterology, are thankful to the Governing Council for giving us the opportunity to hold this year's ISG. And this time we had registration which are more than 2,500. So I think the number is very good because there were almost 394 faculties which participated. There were 255 lectures in ISG, and there were around 12 panel discussions. Total 65 sessions were there and 4 orations. And CME we had 35 talks in 9 hours. As far as morning breakfast sessions were concerned, there were 5 and 3 evening symposiums. And apart from these activities, we had 5 more activities added on to this ISG. I don't know whether it will be continued in the next year's ISG or not, but they added flavor to this ISG in the form of, we had a photograph gallery by endo shooters in the wildlife. Then we had one golf tournament in the morning. We had a gastro run, and then we had a hall D made for inspirational talks by the stalwarts. So these were the added on activities, and we had a little bit of problem in getting the sponsorship initially, but now it went to around 60. So there were around 60 sponsors, the pharma industry people, and because of their support and because of all of you who attended, I hope you liked the conference and made it successful. Thank you very much.
Do you like the Congress? Louder. Dr. Mathur, Dr. Kalla, Dr. Ruprai, Dr. Govil, and all the, Dr. Dadich, and all the team of Jaipur. 3 cheers. I think we had a fantastic scientific deliberation. All the halls are get up, whole venue is so beautiful. Our evening, cultural evenings, food, everything is lovely. Thank you so very much for hosting so well. Don't do again, otherwise we'll have all Congress in Jaipur. Do you agree? Right. So, moving to 2020-23, we will have our Congress in Bangalore next year. And to hold the Congress, there are charter or some certain guidelines have been given to the team of Bangalore. And they are also very excited about this Congress. Anybody from Umesh is here? Dr. Madhava? So you want to say something? So the whole they only have a full committee. The dates are being decided, almost the final, but they would declare in a couple of weeks' time. The venue have been decided, and they are very excited about holding us in.
Dr. Madhava, you want to make some comment and invite them formally?
Yeah.
Good evening, dear friends. I think I should start by saying sincere thanks to Professor Mahesh Goenka and Dr. Govind, who have started guiding us to the beginning of the session. It's almost difficult to fill in the shoes when it has been, the conference show has been like this. But Bangalore will try to live up to our expectations. We have our doyen with us, Dr. Naresh Bhatt, who is guiding us. We have a young enthusiastic team who will make sure that all your aspirations are fulfilled. As Secretary General has told that we will be announcing the dates very soon, and Bangalore being one of the most cosmopolitan city, and the garden city of India, we would like all of you to officially invite there, come and enjoy the hospitality. We want to make sure that you have the best of the scientific deliberations and a wonderful, associated activities. Some of them we will take the cue from Professor Sandeep Nijavan. He said some of them we will like to continue, some we will add from our side. Dr. Naresh?
I think we have a wonderful young team, Raju Wadhwa, Umesh Chalial, Dr. Gubbi, and many others. We're putting in a lot of effort. They've already started about 6 months back. And the most gratifying thing is that a lot of seniors in this audience have just walked up and said, why don't you consider this? Let me help you with this, and things like that, which makes us believe that it is our conference, that all of us will participate, and we are just the catalyst. I welcome you all to Bangalore.
Thank you so much. And they only started campaigning that you come to Bangalore. So now moving to one other agenda, that next Congress in 2023 Bangalore, 2024. So as we know that now guidelines are that only state chapters can hold the Congress. So we invited all the state chapters to apply. And this year we have 3 bids, one from Punjab, Tamil Nadu, and Uttar Pradesh. I may request Dr. Harpreet Singh to come forward, and a small announcement. So would the ISG, this selection will be done by general body through e-voting, and e-voting will start probably in February sometime, and in that during time, each state chapter will have a small video of 3 to 5 minutes to allow you to see that and take your decision that we go to which city in 2024. Dr. Harpreet Singh.
Hello, good evening everybody. I, being the president of Punjab chapter of ISG, have the honor to invite you and bids for the ISG conference 2024. In Amritsar, the holy city of Amritsar, Golden Temple city, an historical place, and has a cultural background. Everybody knows about Jallianwala Bagh and the Partition Museum and the retreat ceremony in the Wagah border. Amritsar has all the infrastructure which one can boast of, being holding a national level conference. We recently performed 2 conferences, one at the national level of orthopedics, another was going to be held next week, national level of radiology. Amritsar is well connected by air, rail, and road. As you know, the airport has domestic flight to all the metropolitan city of India. We have around 50 flights daily coming in and coming down, and about 25 flights of international routes also available. There are a lot of places to visit around and socializing. We have evening cultural programs in Jallianwala Bagh, Wagah border, as I told you, and we have being the historical city of capital of Maharaja Ranjit Singh capital regime. There are a lot of to offer Mughal gardens we have sanctuaries of bird sanctuaries in Harike river where one can spend time in the evening. So I suggest Amritsar being the next city for ISG conference, because Punjab and Amritsar has never presented being on the national level of ISG, although you have seen the chapter on the blackboard coming there, but let it be this time ISG conference coming up in 2024. Thank you very much.
Dr. Ubal Das. Dr. Ubal Das is the Secretary General of Tamil Nadu chapter. And it is a very short speech.
Good evening, everyone. And I'm the secretary of ISG Tamil Nadu chapter. And last time we have conducted in Chennai in 2003. I think Professor KRP proudly says it's one of the well-conducted conference. So far, we are waiting for the last 21 years. We didn't get any chance because most of the members forgot about the city of Chennai. So I think please remember the a state called Tamil Nadu and there's a city called Chennai. And I think KRP is now rejuvenated and we have a young team to support him. And in a lighter vein, if you have Amitabh Bachchan, we have Rajinikanth to inaugurate the first. Thank you.
And all of us can have a lungi dance there. Ubal, lungi dance then. So, Uttar Pradesh, Dr. Dixit.
Going to talk about after Rajinikanth.
Modi sir.
Yes. Dear colleagues and Dr. Mahesh and Dr. Govind, we had the last conference in 1994. And you know, Varanasi is considered one of the oldest living city of the world. And it's a Makkah for all the Hindus. They always had desire to at least visit once to the Varanasi. And so it's a very long time since 1994 when we had the last conference. It is a cultural heritage city, educational city. It has got the largest university in the Asia, almost 22 square kilometers. And it has got a wonderful infrastructure. You name any conference, national level, which was not held in VHU. Whether it's the ESICON, whether it's the Handocon, or whether it is the Epicon, all the conferences. So we have enough infrastructure. And then Modi, because of that, we got a lot of new actually auditorium also. One which is recently built by the collaboration with Japan, this is Rudraj, it's wonderful. And then multiple utility center like this, JEPC. Similarly, there is a Varanasi also, there is a same structure there where the conference can be done. And recently we had a Epicon. So friends, Varanasi is long awaiting you to come and visit Varanasi, and I think you will have a wonderful time. Whether it is in the terms of handicrafts, saris, and so many things. And there are a lot of excursion places, whether it is Sarnath or lots of ghats on Ganges, and it is a city of temples. You name any lord where the temple is not there. So it's my humble request to consider Varanasi is one of the very important next venue for the conference. Thank you very much.
So we will have online voting on these 3 state chapters in month of February. Please do vote and choose the city where we want to go for our next Congress. Now it's time to know our balances, and Dr. Ajay Jain is treasurer, and I must tell before he comes here that he has been extremely supportive and a wonderful treasurer for society, and he has a lot of money, you must know.
Good evening, friends. President Dr. Goenka and Secretary General Dr. Makharia. This society has been growing leaps and bounds in terms of its financial strength. And about 3 years back, we had bought an office in New Delhi in the office area like Connaught Place. So the kitty of ISG has grown and it has become much stronger. At this point of time, our total assets are about 7 crores and 28 lakhs. And out of these, about 4 crores are in our fixed, 4 crores and 40 lakhs are in fixed deposits. This year, again, we had an expenditure of about 44 lakhs, and we are surplus by a fund of about 24 lakhs because of our incomes are much more than our expenditure. And we are spending a lot of money on training our new generation. So all our activities like YCP, gym, train the trainer, and evidence-based medicine, they are being supported by the funds which are being raised by the ISG over the years. If there are any suggestions from the members as far as the other ISG activities are concerned, we are open to it, and GC will consider all those suggestions. The last thing, we are supposed to do some of the public activities under the ISG forum. So any member or any state chapter who wants to do any public forum activities under the banner of ISG, they must contact the Secretary General and President, and the same can be incorporated in our budget for the next year. Thank you very much. If there are any questions regarding the ISG budget or ISG thing, I'm ready to answer those questions. Thank you.
We would also, I mean, is there anybody wants to make any comment? We would also take the consent of the general body that if we require some fund for conducting the multi-central trial, which we have planned, Indian polyp study, we would take the money from the ISG and we would request you to give us a consent.
Thank you. Thank you.
Yes, we are already exploring, but we don't want to stay back and wait for something. If it comes, it's fine. If it doesn't come, then we'll take it forward.
Thank you, sir. Thank you.
Thank you, Dr. Jain. I think we are not more the money is still better, so that the advantage is that you can do all your activities without support from any other sources. Now, before we come to the other items, we have 4 governing council members who retire from governing council, and the first one is Dr. Rakesh Kochar. Dr. Rakesh Kochar has been the governing council member. He has been the president of society for the last 3 years, and he is the past president. He completed 3 years of his term. The Kochar, thank you so very much. You want to say something, sir? Then we have Dr. Uday Ghoshal as editor-in-chief and also as a governing council member. Dr. Piyush Ranjan. Thank you so very much, Piyush. And Dr. Rana. So the 5 governing council members has completed the term very successfully, and your contribution is immense, and the society will be indebted to you forever for your kindness, for your support, for your wisdom, for your advice, and for your encouragement. So before we go to next item, if there are any other agenda, with permission of chair, if anybody has any questions.
We have some time, any suggestion, any comments, any criticism, please come and speak out. Yes, Dr. Ghoshal.
Something new coming in this ISG, that was the photography, and I tell you burnout, and then the session organized by Dr. S.P. Singh, the burnout is becoming common, and this is not an Indian phenomenon, rather it is more in the West, but obviously it is going to come in India as well. So this, what has been initiated here, if it can continue with a stamp from governing council, so that what happens is those who do extracurricular activities, if these are projected here, they will tend to do it more for the next ISG. For example, photography, for example, painting, for example, poem, for example, song. It will be a good activity for the society, so it has been initiated here. Let us, my request is keep it up for every ISG.
Bangalore team has already told us that they will only add to the activities, and these activities will continue. Dr. Naresh Bhatt, Dr. Umesh, Dr. Wadhwa. Yes.
If we are having consistently crores of rupees in the FDs, is there any advantage of putting this money into the mutual funds after mutual agreement?
I think Dr. Ajay Jain would contact you and get your advice on that. Dr. S.P. Singh.
This is regarding the award of MISG and FISG. I have been through the list, last year's list as well as this year's list. I think one name is absent, you know, that is very conspicuous. And that is the name of Dr. S.P. Mishra. Dr. S.P. Mishra's name didn't figure last year, neither this year.
So, can I make a comment on that? See, these awards we only consider when somebody applies for it.
Last year, most people who were given, they never
No,
applied
it's not.
for this.
It's not true. They had maybe that their formal application did not come because we want this award to be valued, and we want this award to be actually demanded. So if I would, we have great respect for Dr. Mishra, and we would see to it that we get it done by him. He puts his application, and he would be given an award.
But last year I checked with many people, they had not applied, and they said we had not applied, and yet we are very grateful that ISG.
So this is a process which have just started. We are maturing in this process. There must have been some mistakes, but we'll see to it that the mistakes are not repeated and they are rectified. Any other suggestions?
Dr. Ramesh Ruprai have been so generous that he made a medallion for all the president of ISG, and 33 this time. So may we request all the president of ISG to please collect this medallion as a kind of memory of ISG from the VIP room just here. And I have three of you here, Dr. Guha Majumdar, Dr. J.K. Bhargav, and Dr. Shiv Sarin, but all of them are there, so please do collect.
So since Dr. Rai was missing when we were talking about this conference, we would, Dr. Rai, say our thanks to you for organizing along with the G6, organizing this wonderful conference in a great venue with great academic activities, great extracurricular activities, and great food. So from the ISG, I'm showing my thanks and appreciation for the efforts which has been done. I'm sure you would have a 5th conference in Jaipur not too far.
Any more comments anybody has? Avinav.
Any other comments?
Avinav.
Sir, each society, maybe it cardiology society or urology society, they have certain laid down criteria to become a member. Means you cannot be a member of urological society unless you are qualified MCH or DNB in urology. Our criteria are very fluid.
No, let me just, we got what you're saying. If you go through the constitution which has been framed now, it is very clear that only DM, DNB in gastroenterology can become a member. Now they are already those who are existing without these degrees, we cannot expel them. So we have made a cutoff point. There are a lot of people who are state chapter members, do not qualify for these criteria. But then those who have become chapter members, we cannot deny them the membership of the national body. We have told, today also we are going to meet the chapter head tomorrow, that March is the dividing point. By March 31st, all the state chapter members who are existing has to become the national member, otherwise they cease to be members. So if you look at the constitution which has been framed now and is put on the website by Govind, it clearly says that only DNB, and the DM students or past candidates can only become members. So I think it's very well defined. So we have to see, we had done mistakes, we need to rectify the mistakes.
Yeah,
so it has already been done.
Very welcome step.
Any other? Yes, Dr. Babu.
Yes, Umesh.
With Western qualifications, some of them, go to US and UK having MRCP, FRCP.
So those will be discussed in an individual case-to-case basis in the governing council. We are not taking a decision that they would all be included or they will all be excluded. There will be some criteria which will be done on the basis of individual basis.
Dr. Goenka, just clarification here. There are a lot of people who go abroad and train and they come back. So
he just said that.
I'm talking not because we're taking surgeons also become ISG members. So they are MSc, MS, and then they do MCH in different specialties. So they are also allowed to become members of ISG.
No.
They're
From
not.
now onwards, it will be a medical gastroenterology
So the surgeons
association.
will not be
Surgeons will no more be taken into the ISG. Those who are already there are welcome, they will remain. But from now onwards, this will be an exception rather than a rule.
Okay.
They would be all associate members. So they will never become governing council members. They will not have voting right, but they can be associate members. So there are only two categories of member now. There's full members and there are associate members. The full members have to be a qualified gastroenterologist, and associate members can be any specialty, whether they are PhD students or whether they are pathology, radiology, surgeons can become associate members.
What about hepatology?
Hepatology is gastroenterology. We don't differentiate hepatology from gastroenterology. Why Lawrence has to ask that question?
I wanted to comment on the criteria for various awards. It is skewed in favor of a couple of institutions, because almost all the awards, they have one thing in common. You must have 20 publications with, you must be the first author and the corresponding author of so many. So by that what happens, it's only people from say AIMS or PGI or similar CMC Vellore who can get the awards, and the contribution to the society through ISG in different years is not given that much credit as it should be. So there should be a relook into the criteria for various awards.
So I would answer that. This is a point which we have discussed many times. These awards criteria were made about 2 years back and were accepted by the ISG. I totally agree that there are two components of anybody's being given an award. One is his own personal achievements in terms of publications, presentations, representing various societies. But the second and the very important component is contribution to your own medical fraternity, and particularly to Indian Society of Gastroenterology. We have taken this time when we selected the award, this second criteria was given enough importance. Now, we also have some awards like Balakrishna Award, which is not based on publication, but is based on your overall contribution to the society. So Balakrishna Award is not based for any publication. Now, let me tell you that your point is well taken. We have also taken a decision in the Governing Council, subject to confirmation by the general body, that once you get an award, any of the orations, you do not get another oration for the next 3 years.
3 years.
So if you have got a PN Chutani oration this time, you will not be given Habibullah oration next year. So 3 years will be a gap. Just like that for the chapter, we gave it to the Kerala chapter now. It has been decided once a chapter gets the best chapter award, that chapter doesn't qualify for the next 5 years for that award. So that the next other chapters, because that chapter will remain the first. So these are some of the issues which we have done, that if you have given a PN Chutani oration this year, you will not get any oration for the next 3 years. Is that fine, Dr. Singh?
Any more?
Yes, there's some comments from there. Dr. Panda, be brief.
Sorry.
And not aggressive.
No, sir, no. Sir, one thing, the selection about for the ISG Con, there was a tradition to give the presentation here. So GB approved immediately. There is why it was kept pending till February, and they will be remaining uncertain till February.
No,
why not today?
We got your point. Let me tell you that everything has a plus point and a minus point. We have seen that people used to generate audience for the general body to get the voting in favor of that. So we must give the whole population of the ISG members a chance to decide, not only the people who are present here. So I think this decision was taken 2 years back and is welcome. There may not be enough people from Chennai here to vote for the Chennai, but there are many people who want to support Chennai. So I think it's a democratic society, and we thought just like we are voting for the secretary and the president, let's vote for the conference venue also through this. And this has worked out well, I think, till now.
Sir, I differ. In a democratic society, the best thing in the presence of GB, not the behind. Many people will forget and many will not be aware when there will be a year. The best thing in a democracy when in the GB is going on. That is my suggestion.
See, everything has a plus and a minus points. We have discussed this last time, the general body also, and a decision has already been taken.
The presentation will be uploaded on the...
And the presentation will be there as a part of the e-voting. You would have a presentation. We didn't want to spend too much time in the general body for do that.
I think with this, I think we have a formal agenda is completed. But I would like to take 1 minute of your time. I have been Secretary General of the Society for the last 6 years, and I'm completing my tenure, 2 tenures tomorrow. So I'm so... Thank you. Thank you so very much. And I must say, that we together, the governing council and general body, we together has achieved quite a lot in the last 60 years, and we have become a very vibrant society. While I took over charge of the society, I had a lot of dreams, and dreams was that we must be more academic, we must have more academic activities, and we want to be transparent and want to reach out to every member. I'm not sure we have fulfilled all our dreams, or my dreams, but while doing working society, I was supported by Dr. Gauradas Chaudhary and Dr. S.P. Mishra, who guided me through the nuances of working with a society as big as ours. I was supported by all the governing council members for the last 6 years, each one of them were extremely supportive. You propose an idea, everybody say, yes, go ahead. No question asked. Certainly their methodology are discussed, but no question asked on the credence of the society. And that shows openness and supportiveness of all the governing council members.
Yeah.
Dr. Rai is pointing towards our new logo. I think hope you liked it. I'm also supported by the 6 presidents, starting for Dr. T.S. Chandrasekhar, Dr. Naresh Bhatt, Dr. Ajay Kumar, Dr. Vikesh Saraswat, Dr. Rakesh Kochar, and Dr. Mahesh Goenka. And all of them have been great supportive for all the activities ISG. I'd also like to thank all the committees of ISG in advising for activities and supporting in all. I'd like to thank every member of ISG for your kind support, love, appreciation, and regards. I can say for the last 6 years, I have achieved a lot. I get so much of respect from you and love and encouragement that I'm so much indebted to you. I'd like to thank all the faculty members of all the congresses to helping us in this program. I'd like to support my own department who spared me during this whole process. I spent many hours of my professional life into activity of ISG. So I'd like to thank all my department for allowing me to do that, and also allowing the ISG office to work in the premises of AIMS. So thank you so very much, AIMS, and for that. I'd like to thank my wife, Suman. She has been a great encouragement to me, and my parents, my daughter, and my son-in-law, and all my family members. I also like to thank Nisa. Nisa, can you stand up, please? I think finding a person like her to our society is, I would say, big boon. And she works through, she's working for the last 1 year, and she looks after, she understood our society working, and she delivers every aspect in communication, in writing letters, maintaining records. So thank you, Nisa, for all that. You want to say something for her?
Yeah, so...
and well, before you take one more person, Vikas Sachdev is again one of our colleagues at AIMS. He looks after our finances and maintains the finances book with under guidance of Dr. Ajay Jain, and he has been terrific in supporting for the last 6 years the finance of ISG. Thank you so much, Vikas.
So I think if there is no more discussion, we will need to close this meeting, and I must again thank each and every one of you for sparing this time and being here. And I would also put on record my appreciation for the great work done by Professor Govind Makharia and other members of the Governing Council, my predecessor, Dr. Rakesh Kochar, who has been my mentor and friend, for all the contributions which we have done. And I'm being there on the Governing Council for 1 more year and would do my best to take the ISG to the higher level. I firmly believe that there's no reason why ISG should be anything less than AGA or ASGE or ACG. We have the potential. We just need to pump everybody a little bit more, and I'm sure we'll do that. So thank you very much.